scientific committee, namely Rami Soriel, Yan Wang, Chao Li, Yixin Chao, Guo Qiangxiang, Sahid Noor, Amin Chenoy, Parth Sanchetti, Kuku Herdugarahanto, and Ricky Utapia. With their hard work, we have assembled some of the most prominent names from all over the world in the field of hip and knee surgery to share their expertise during the next 3 Saturdays. Through strong international collaboration, we have been able to design a highly engaging program which includes the plenary sessions, live surgery, debates, panel discussions, and symposia, as well as a free paper presentation. To all the participants, I would like to encourage you to attend all 3 days to get the most out of the meeting. There will be 2 auditoriums, one for the knee topics and the other for the hip. I would also like to acknowledge and thank our industry partners, especially our platinum sponsor, Stryker, Zimmer Biomet, DePuy-Synthes, and Smith & Nephew, and our titanium sponsor, Corin, for their generous support toward this conference, which enable us to foster the international academic exchange and educations in our field. Through this virtual meeting, these companies will educating us with their own industry session in program, demonstrating the recent technological advances in their products and service, and that they have developed to aid us in providing the optimal care for our patients. I encourage you all to visit and engage with them in this exhibition foyer at our virtual platform. We have other exciting plans going forward, including the Reverend Fellowship and a Young Surgeons Forum meeting toward the end of the year. Finally, my deepest gratitude to Alison and Michelle, Sophie and Bridget, Peggy and Jessica, the AV team, Wolflight, and Ray Entertainment, who had worked wonder behind the screens. Without all your support, this meeting would not have happened. Thank you very much for your attention and enjoy the meeting. All right, ladies and gentlemen, let's start the meeting with the first presidential guest lectures. I have the privilege to moderate together with Professor Wang Yan. He's the founding father of Asia and the past presidents of the APAS. And also we have Professor Charlie and Professor Parth Sanchetti. It is an honor for me to introduce my good friend, Professor Seth Leopold, who is the editor-in-chief of Clinical Orthopaedics and Related Research. Seth, you know that CORE is a high-impact journal with over 3 million article downloads and about 30,000 citations last year. He is also a professor in the Department of Orthopedics and Sport Medicine at the University of Washington School of Medicine in Seattle. The title of his presentation today is How to Get More Out of What You Read in Orthopedic Journal. So welcome, Seth. Please.
Well, good morning, good afternoon, wherever you are in the world. And I'd like to thank the societies as well as President Professor Buddha Parama for this very kind invitation. I'd like to speak with you this morning a little bit on the subject of critical appraisal or getting more out of what you read in orthopedic journals, how to become a critical reader. By way of disclosure, I'm the editor-in-chief of Clinical Orthopedics and Related Research, and for my work there, my institution receives salary support. So let's imagine next week, you come back from this weekend, you're on call, there's an active 55-year-old woman attached to this x-ray, and the question is, how are you going to help her out? Lots of choices, as those of you in the room no doubt know: hemiarthroplasty, bipolar, hip replacement, maybe fixing the fracture. And the question is, how are you going to decide? You can toss a coin, ask the implant rep, ask one of your partners. If you're one of the younger people in the room, might you do what you did in your residency, which may or may not work for a couple of years, but after passage of time, the things that you learn may become out of date. You could do what you learned at a course or a conference like this one, but how will you know that it's the right thing to do? hopefully you'll go do a search, a PubMed search or something similar. But the question is, how will you know what you find is good? How will you know it's worth your attention? And you're so busy. How are you going to read through all of the things that you find on a search like that? Nobody's born doing this. This is an acquired skill that can be taught and learned. And so let's talk this morning a little bit about how to do it. It's important to do because critical reading should inform our decisions. If our skills added are soft, then less reliable information sources may drive our practices. So if I'm going to talk to you about evidence-based medicine, what's the alternative? Well, some people call it eminence-based medicine, listening to people who ought to know. They often have gray beards. This is C. Everett Koop, former Surgeon General of the United States, and he was once quoted as saying, "It is true that there are people in my situation who could not receive it, but I do." Maybe he does, but it's awfully difficult to take somebody at his word saying things like that. And so it'd be nice to be able to figure these things out for ourselves and not rely on people who ought to know. We ought to be able to know. Advertisements are another particularly bad source. We all say that they don't affect us, and every study that's looked at it says that they do. Sometimes advertisements don't look like advertisements. This is a web page from an academic website, a university. Makes the claim that PRP has been demonstrated to be non-inferior, that is similar to and even superior to hyaluronic acid for patients with knee arthritis in multiple studies. The problem is that neither of those things is very effective. The American Academy of Orthopaedic Surgeons put out a clinical practice guideline on hyaluronic acid and biologics and found that they couldn't recommend either of them. And so the idea that there are academic websites, they look like neutral sources of information. They're putting out information like this. That doesn't help our patients and it doesn't help us. The problem is, since that clinical practice guideline in 2013, the market share of these products has only increased. It's now $2.6 billion. That's an enormous industry for something that doesn't work very well. Here's another claim from an academic website, orienting itself, as you can see, towards somebody who's at least in middle age. Makes the claims about arthroscopic knee surgery that it is minimally invasive. It can remove loose fragments and bone spurs and repair damaged cartilage that are causing pain. The problem is that there's no evidence that this is true and plenty of evidence that it isn't. Again, this is an academic website. We need to figure things out for ourselves. We can't depend on the claims of others in those contexts. Ads, not articles, do influence our practice. Whatever we think about it, every study that's evaluated has found this to be true. One found that studies of exposure to information provided by commercial sources with higher prescribing frequency, higher costs, and lower quality. No evidence of net improvements in prescribing. So we know that reading should drive our practices. We know what needs to happen. We know that how well we read affects our patients' lives and their health. And so how are we going to do that? So this morning, this afternoon, I'd like to speak with you about the topics of validity and bias, the most common kinds of bias in clinical research, the importance of no different studies and how to evaluate them, and the questions you can ask of the most common study designs. So I'm going to focus first on two types of validity. Internal validity, which some people call methodologic rigor. In this situation where you're looking at this, the methods are sound, the interpretations and conclusions are supported by the data in the study. There are different criteria for assessing internal validity for the different kinds of studies we're going to read, and we'll talk about the common ones. External validity is also called generalizability. Here, the question is, can the results of a well-designed, internally valid study be applied to your practice? Here, you're dealing with questions like the patient population, the study site, the provider experience, the equipment or the approaches and the technology. Consistent criteria for external validity exist across all different study designs. The problem is, as external validity increases, internal validity usually decreases. What do I mean by that? As inclusion criteria become stricter, the study does become more homogeneous, but it tends not to represent all comers who you might see in the office. So am I saying that good studies can lack validity? Absolutely. They say some people are rats, but rats aren't people. So studies done in rats may not apply to humans. More realistically, in clinical research, let's imagine I'm trying to convince you to use a new implant that I've designed. True disclosure, I haven't designed anything. Let's imagine I'm making a claim that my new knee replacement has no risk of failure at 10 years, but I may have neglected to point out, and you may not know to look, that the patients have to be thin, lightly muscled, women over 75 with blue hair, and, of course, insurance. Not this kind of blue hair and not that kind of blue hair, but somebody like this. If I put my new knee replacement into somebody like this, in fact, if you put anybody into somebody this fit, they're likely to do okay. And this is what you have to sort of suss out as you're reading this kind of research. So let's talk about bias for a moment. The AMA defines it as a systematic situation or condition that causes a result to depart from the true value in a consistent direction. Bias refers to defects in a study design or how it's measured. Bias is not the same thing as preference. Preference is in the mind or the heart of a person. Bias, for the purposes of this conversation, is in the design of the study. There are 4 common types of bias you want to be aware of, and I'll talk a little bit about each. Selection bias, transfer bias, performance bias, and detection bias. Selection bias is sometimes called susceptibility bias, and it deals with the idea that a study might try to compare results between groups that are dissimilar at baseline, prognostically dissimilar. And so if groups are dissimilar before they got their treatment, they get a treatment, the results of that treatment may not be caused by the treatment. They may have been caused by the differences between the groups that were present even before the patients got treated. One way around this is good randomization. Stratified randomization is even better when resources permit, but there are other ways. Since only about 3 or 4% of orthopedic studies are randomized, we're going to have to find other ways to work out the problem of selection bias, and I'll show you how. Transfer bias deals with the question of whether the follow-up is sufficiently long and sufficiently complete to detect all the harms that you might care about. It's especially important when you're comparing 2 groups and there's a difference in completeness of follow-up between the 2 groups. Non-responders usually have worse health status. And so you can ask yourself, imagine all of the missing in both groups did poorly. Would that change what I think about the treatment? Performance bias deals with the possibility that there could be dissimilar skill levels between people doing the operations in a study. It could be that there are different approaches or techniques used. But importantly, it may not have anything to do with experience at all. It could deal with what they call co-treatments that are alongside the test intervention. So imagine I'm trying to convince you to use a less invasive something or other. But in addition to the different approach, the less invasive group got more nonsteroidals. They got more physical therapy. They got more follow-up. They got more hand-holding, more painkillers. So there are lots of ways that performance bias can influence your studies, and we'll talk a little bit about that in a moment too. Detection bias, sometimes called assessment or assessor bias. Here, you're wondering who's asking the questions and what's their interest, and maybe even more importantly, what questions did they ask? Are they standardized or inconsistent? Validated endpoints, blinding examiners, those are the best ways to get around this. So let's talk about 3 common study types that make up together well more than 90% of articles in orthopedic journals. Studies about treatments, prospective or retrospective, studies about new diagnostic tests, and then review articles like meta-analyses and systematic reviews. Now, obviously, there are many other kinds of orthopedic studies, but they're beyond what we're going to cover today. Those will be topics for some other day. We'll focus on the big 3. If you want to pause and take a screenshot, go ahead and do so. This is a great resource for people who are curious and want to go deeper than I can go in 15 minutes. Gordon Guyatt and Drummond Rennie really invented this stuff back in the 80s and 90s. And in that book, which fits into the pocket of a white coat, it covers this topic in great depth. But I'm going to focus on 3 questions that you can ask of each kind of study that you might read. The material is also available at Clinical Orthopedics and Related Research in this editorial if you want to take a screenshot. And we've even programmed a tool on our website that you can use that walks you through the reading of an article. It's built for reviewers, but it's equally good for readers. And you can find this at Clinical Orthopedics website, www.clinorthop.org. I should add that I've also provided a handout that's downloadable, and Professor Buddhaparama can tell you how to get that resource on the website for the conference that goes through all this material. As you approach an article, you might begin by assessing its external validity. Could you apply it to your practice? Are the patients similar to your patients? Or are they dissimilar? Do you have the tools and technology that the authors had and the experience, perhaps? I would say that if the answer to those questions is no, don't bother. Skip that article. If the external validity is good, if the patients look like yours, if you think you could do this operation, then ask yourself, well, let's see what they had to say about it. If their claims, exactly as they made the claims in the conclusion, are true, would it change my thinking? Don't try to figure out at this point if it's true. You can't figure that out from reading an abstract. You've got to read the whole paper. But first you want to see, can you even tell what they're studying? Did they ask clear questions? If their conclusion isn't that interesting to you, then there's no sense wasting your time. Skip it. But if the patients look like yours, you think you could do it, and the conclusions look like they would change your thinking, at this point you want to skip the introduction and go right to the methods section. And you're going to look there for major deficiencies or fatal flaws. And if you find any, here she is again. You're going to skip it. At this point, once you're into methods, there's a few key questions you can ask for each study design. And what I'd like to do is, for each of those 3 study designs I mentioned earlier, ask you the 3 questions for each of those designs. So again, studies about treatments, studies about diagnostic tests, and review articles make up almost all of what you're going to read in orthopedic journals, so we're going to focus on those. So retrospective studies about therapies or treatments. Ask yourself who is included. That's the question of selection bias. Can you tell how they decided whom to include? Can you tell who received the operation in question or the operation and the comparator or control? What proportion of their practice were enrolled and which ones? Then ask yourself, was the follow-up sufficiently long and complete? This is the question of transfer bias. Imagine they make a claim that they were completely successful, but half the patients were lost. You can't count on that claim being true. The missing are not doing as well as the accounted for. Were the outcomes measured appropriately? The question of assessment bias. Did they use validated tools? Were they assessed by somebody other than the surgeon? Sometimes they'll say that we've got some limitations. The study was level 4, and I would say, don't worry about that. Sometimes level 4 is just right, particularly if the intervention failed. There's no need to go on and do another study like a randomized trial. But typically, level 4 studies that make big claims, you've got to realize that the kinds of bias we're talking about, selection bias, transfer bias, and assessment bias, all tend to inflate the apparent benefits of treatment. These biases are additive. They don't offset one another. They all push the results in the same direction in favor of the new treatment. That's why as study quality gets better, we see smaller effect sizes. This happens again and again. How about prospective treatment studies? These are the same, you ask the same questions as we asked a moment ago about selection bias, transfer bias, and assessment bias, but in addition, you can ask were the groups similar at the outset. Here, randomization helps. Other than the experimental intervention, were the groups treated equally? Here, blinding helps. And if they randomized the patients, did they use the intention to treat principle when analyzing? We can talk about that during the questions if you'd like. Moving on to the second kind of study, diagnostic tests. Was the new test evaluated against a gold standard? This is important because you need to know how they figured out whether the new test is worth anything. And then importantly, did the results of the new test influence the decision to apply that gold standard? If they only applied the gold standard, let's say, to patients who tested positive on the new test, you're going to inflate the apparent effectiveness of the new test. Did they enroll a suitable population of patients that covers the full spectrum of disease that you might be interested in? This is sort of an external validity question, but one worth asking nonetheless. Finally, review articles. Did they describe their search adequately? Do you know how they found the information they found? Which databases did they look at? Are they likely to have missed something important? Did they tell you how they decided what to include or exclude? Did the authors deal with the fact that not all studies are similarly well designed and similarly convincing? It's not appropriate to lump in level 4 studies with randomized trials and treat them as though they're the same. As we've already found out before, they're just not. Did they grade the studies so that you can see whether the evidence base that they're using is of a high quality or low quality, and how much do you have to discount the results because of that? Do they deal with the questions of publication bias and in particular heterogeneity? Is it even appropriately to mathematically combine to meta-analyze the results? Let's talk about heterogeneity for a minute. So the idea of heterogeneity, imagine there's a meta-analysis that's evaluating some treatment in which half the patients were killed by the treatment, half the patients were cured. If you average those, you might conclude that there's actually no effective treatment, but that's badly misleading. You need to drill deep and figure out why some patients were harmed so severely and some were helped so much. That's analogous, if you like, to averaging night and day. You just get a quantity or a quality that's not even sensible to talk about. You've got to just drill deeper. If there's a lot of heterogeneity, you shouldn't pool them together. At this point, if the study passes your test, you can read the results next, and you can decide what you conclude. Is there anything new here? Is there anything you could put into your practice? Are there any caveats or limitations that you would apply based on the shortcomings that you identified? You don't have to count on the authors. We can take a short detour into no different studies. I think they're important to publish. Positive outcome bias makes meta-analyses misleading. If the literature consists only of studies that found treatments to be helpful and suppress the publication of no different studies, then meta-analyses are going to make things look better than they are. It's going to overestimate treatment effects. This is going to influence how we use resources, and this is a real problem across science. No different studies may not be fun reading in the sense that they're not always so dramatic, but I find them important because they tip you off that the early positive findings that we thought were true may not be true. And so this is where you find the early cautionary messages that suggest that something that you thought was good may not be as good, may not be as good as you thought. And it's important to know that sometimes there are studies that are too small, and the authors need to tell you how that if the power of a study, the power of a study is low, it doesn't need to be realistic, it doesn't need to be realistic about that. And no difference finding and no difference finding and no can be understood in paper. You need to know that the absence of doesn't mean that there may be better study to detect that. At this point, you could read the introduction, and you've already decided that you don't have to take the office, you don't have to take the office, then if you have the discussion, they give you discussion, they give you some discussion, they give you some then you can be critical, you can be critical to do that, you can decide for yourself, you can decide for yourself, you can decide for intimidated by the office of their own insurance, which I understood. It's easier to put into phase than because every study, and your task as a reader, to say, given the limitations, there's just something I'm saying here. That's okay. Can I use any of this item that I have this? Even a part of it. I understand I'm going to take the questions straight away, that there's going to be another talk from Professor Parvizi, and then after that, Phil should take the questions, and I look forward to that. Thank you again for this kind invitation.
Thank you very much, Seth, for the excellent presentation. But I think maybe we can start first now to the Q&A while waiting for Jay. I will have some questions for you, Seth. And if you look at most of the publications on new technology, CAS or robotic, are underpowered in my opinion, because the sample size is too small to be detected using the traditional RCT methodologies. And if you look at the follow-up time, mostly are only 2 years. So I think, for example, to reduce an outliers of the alignments from 20% to 10% and an alpha threshold of 0.05, one might require more than 400 samples, for example. Or an outcome to change reducing the aseptic loosening from 8 to 4%. One needs, I don't know, maybe a couple of thousand samples, but I've never seen in a publication. So I would like to share, what is your thought? Maybe you can share with us, Seth.
That's a great question and a really important one. And as a medical editor, it's a question that's dear to my heart, because as you can imagine, every year we see a couple of thousand papers coming in, all with new ideas. And the question is, how do we know when an idea is good enough to recommend it? And here in particular, you're dealing with technology that can be expensive, that has a learning curve associated with it. And during the learning curve, people can get hurt. Patients can get hurt as we get better at using these tools. And so we want to make sure that if we're going to use one of these tools, that we're really confident that it's making a difference. So I would say there's a few parts of your question that are worth unpacking. The first is, what is the endpoint that we're looking at, and is it the right endpoint? So is looking at the reduction of outliers the right thing, or do we want to really, before we invest in an expensive technology that has a learning curve where people could get hurt, do we want to make sure that we're looking at an endpoint that really makes a difference, like the reduction in revision risk? And I don't think it's enough to have a hypothetical benefit, like the reduction of the number of outliers. And I don't think it's okay to say that we're underpowered, and so maybe there's a benefit, but we just didn't detect it. It seems to me that before we can recommend something new that has new costs and a learning curve, it has the obligation to demonstrate its value to us. And if it can't do that because the value is so small that you need thousands or tens of thousands of patients to tell a difference, then maybe the effect size just isn't that big. Maybe this technology isn't going to do what we hope it's going to do. And so I think we need to wait on the deployment of that technology until it proves itself to us. I don't think we should always assume the best about every technology, because the history of our specialty has shown that a lot of well-intentioned ideas have wound up hurting people. I think this is different if you're dealing with an operation that's generally well-behaved, like knee replacement or hip replacement, that most of the time patients do pretty well with it, then it would be, let's say, if you're talking about some kind of an unsolved problem. So imagine somebody came up with a new approach for pelvic discontinuities, or extensor mechanism disruptions. There we don't have good solutions. And so, we can be a little bit more experimental or a little bit more open-minded about how we deal with those problems. But when you're dealing with a generally well-behaved operation, like let's say a first-time knee replacement or a first-time hip replacement, it seems to me we shouldn't embrace these new technologies based on the idea that hypothetically they should be helping people because there are fewer outliers. That's just too much of a risk. Those technologies need to prove themselves to us in a more definitive way before we should embrace them.
Thank you, Seth. Maybe Parag, you would like to have some questions? Yes, please.
Yes, excellent talk. Really learned a lot of new things, Professor Leopold. My question is slightly different. We always talk about doing multicentric trials, and they say it's one of the best ways to really prove a point, versus to doing well-done RCT. So what do you think, which generates a better evidence, or which we should follow, a multicentric trial which gives it out, or a randomized control trial done by one center? And which has better evidence, because there's always a lot of confusion. And to add to that, we also have this systematic reviews. So there's always a conflict in my mind, which is better than the other. So can you just throw some light on this question? It's a little different, but I thought I should ask you.
I love it. I'll do my best. So I think I understood the question. The first part of the question was, imagine you could have a trial from one center of 1,000 patients, or a trial from 4 centers, each of whom contributed 250 patients. Which would we rather read?
Correct.
Right. Well, it depends a little bit what you're trying to get out of it and who's reading it. So, on the one hand, it might be nice if I did that technique exactly the same way as the large center that did 1,000, then that trial might be really exciting for me. If I do it exactly as they did, having 1,000 patients would be more interesting than having sort of slight variations on that theme at each of 4 places. But the real world being what it is, where each of us does things a little bit differently, there's something very appealing about what I called in my talk external validity or generalizability. So if that technique works in one place, you have some confidence in it. If the technique works in 4 places, you have a sense that it's a more forgiving technique, perhaps, and that it may be generalizable to more centers. So I think that's sort of the first order answer to your question. But then at the end of your question, you threw in a couple of other things that I think are even more fun, which is, what are the other kinds of study designs that can inform us? And you mentioned the systematic reviews. Or let's call it a meta-analysis if they're going to pool the data. So imagine we're still talking about randomized trials where you can mathematically pool the data. That adds yet another level of generalizability. Sometimes when you ask people what they think the gold standard study design is for a study about surgical treatments, people will say the randomized trial. But I would assert that the gold standard study design is probably the meta-analysis of randomized trials, just because it gives you a measure of generalizability that you don't get from a one center or even a several center trial of a technique. If you can find other things that are worth pooling together and similar enough to justify pooling, I think that gives you the added confidence that this is maybe a more forgiving technique, or a technique that you don't have to be a professor who's done 10,000 of them for it to work. There's one more kind of study that you didn't mention in your question that I think is worth adding in. Because as we're getting a little bit sort of savvier about this, a little more experienced with clinical research, we see that a lot of different study designs can complement one another. Right. And so the other kind that I find really enjoyable to read and to sort of hold alongside the randomized trial is the National Registry study. So when you look at, if we're talking about, let's say, arthroplasty, on the one hand, you've got studies, randomized trials, and a really big randomized trial in orthopedics might be 400 patients. But now you can put that alongside a meta-analysis that might have 10 studies. So now you're at 4,000 patients. Well, now imagine you had a study that had 40,000 patients, 10 times as much as that. That might be the Swedish Arthroplasty Register, or the Norwegian Arthroplasty Register, or the Australian Arthroplasty Register. And those are fun because they're unlike randomized trials. They're not quite so validity where everything is controlled for, but they have this wonderful quality of every man or every man and every woman, because they're evaluating the treatments just as they're being used in the community. So again, you don't have to be a high volume professor of something or other to consider that work applies to you. I figure I'm an average surgeon, right? None of us really knows if we're above average or below average. So let's all assume we're all average. It's nice to look at registry studies and see what the average result looks like in that setting. And it's even more fun when you can compare and contrast randomized trials that may have one result. Maybe it's a little different in the registry. Maybe the results of that randomized trial don't play out in practice or don't play out quite that way. So to me, all of these things complement one another. The nice, tight randomized trial, whether single center or multi-center, the somewhat more generalizable meta-analysis of a bunch of randomized trials, and then the sort of man on the street or every man and every woman, experience of a country in a registry context. So I think if we look at those things together, it kind of gives us a well-rounded picture of how something is behaving.
Perfect. Yeah. Thank you. That shows.
I would like to remind the audience as well, Parag, to send their questions to the Slido. So I haven't seen any questions here. And maybe I would like to ask Seth another questions. Is nowadays all new technology becoming hype. Like robotic, or that's a hope. And then I read an article in last year and by Michael DeFrance, which shows that 91 published on robotic declared that the financial conflict of interest, of course, reported for a positive result of the robotic. Now, because it is a difference and publication bias and investigator or study aside preference, and how precise was the estimate to the treatment effect? Because otherwise, if you read only about this, then you thought it's like a norm nowadays. Everybody has to use that stuff. So what is your thought on it?
Well, these are great questions because each of them can be taken in so many different and fun directions. But so let's talk a little bit about the idea of industry-related conflicts of interest and other kinds of conflicts. And then we can talk about precision of estimate of effect size. I think that in our specialty, I'm an arthroplasty surgeon too, as you might know, and so I'm comfortable with this conversation because this conversation has been going on for as long as I've been a surgeon. I think, we shouldn't assume the worst. I think that a lot of innovations are going to begin the life cycle as industry funded in our specialty. I think that that's just the way it is. And the fact that something comes to us from an industry study, we shouldn't assume that it's not true. We shouldn't assume that the person is trying to advantage himself or herself or advantage his or her company. But I do believe that the fact that so much of the innovation in our specialty is industry funded should force us to ask for more before we put these tools to use in common practice, in general practice. I think that if an initial study comes to us from an inventor or an innovator or a consultant to industry, I think it's probably reasonable to ask, has this been replicated by somebody whose relationship to industry is maybe not quite so tight? And maybe we shouldn't rush right in and change our practice over the first study or two that may have been delivered to us through an industry partnership until some other people have replicated the work. If it's a really promising technology, there should be a lot of excitement about it, and there should be some independent trials following, hopefully not too far behind. I think the question of publication bias that you mentioned is maybe a little bit different. To me, publication bias doesn't mean that the person was funded by industry. It doesn't mean that he or she is enthusiastic about something. To me, publication bias is not something that I can tell as a reader from reading one study. To ascertain publication bias, another word for publication bias, positive outcome bias. And this is the concept that journals may be more likely to publish studies that have favorable conclusions or show differences rather than studies that have no difference or negative conclusions. And it's the same phenomenon that maybe reviewers are more prone to recommend for publication exciting findings, studies that show difference, as opposed to no difference studies, which they may perceive to be a little boring or unspectacular. You can't, as a reader, even as a really good reader, you can't tell from reading one study whether there is publication bias present. In order to tell whether there's publication bias present, you have to look at a whole literature on a particular question. And there are mathematical ways to work it out. These are things called funnel plots. And I'm not a statistician. I'm not a mathematician. I can't even do a good imitation of a mathematician or a statistician. But when you look at this mathematically, when you can plot out the results of a bunch of studies on a subject, and if what you see is that that plot, imagine a scatter plot, is missing the dots that you'd expect to see where you would look for small different studies, then you can assume that journals are saying, well, these small, no different studies, maybe they were underpowered, they don't justify our attention, we're not going to publish them, perhaps somebody else will. The problem with that, the problem with publication bias, is that if guys like me, journal editors, favor studies that show difference and we suppress studies that show no difference, this can hurt patients, because then when meta-analyses happen, the meta-analyses can only pool what's been published. And if what's published has sort of systematically tilted towards the positive, then meta-analyses are going to overestimate the apparent benefits of treatment. And that's misleading. That can harm patients. It also wastes resource, because imagine, you're a sensible investigator, you see a bunch of studies that all seem to show the same thing, that something works, but you can't make it work in your practice. And so you think maybe we need a trial on that, but it turns out maybe there are already 5 trials showing no difference, but they couldn't get published. So it's important that journals, that editors like me, be especially open-minded to negative and no difference studies, even if they're smaller. And this is something that I've written a lot about. It's something that I think journals don't do as good a job with as they need to. But publication bias has unquestionably harmed our patients and misled us as surgeons. So it's up to people in positions like my position to do better. It's a good question, Nika.
Yeah, thank you. Parag, maybe...
Yes, so one question which always comes to my mind, and this is more for the newer generation, the young doctors who are just finished their residency program and got into practice. And, when they talk about research and when they are asked to do research and get into that thing, especially in countries like India and Indonesia, there's always a reluctance for research. And one of the common excuses given is that, oh, there's so much of literature already there. What new is to be taken? How do we really get into this? So I just wanted some tips from you, Professor Leopold, for beginners, to entice them or to stimulate them to get into this research, because they say, oh, there's a click of a button, you get 1,000 articles. I don't want to add 1,001. So, those kind of answers are always seen. So how do you motivate them?
That's a great question. So the first part of it, I think, just as I said a moment ago, I have a responsibility as a journal editor to deal with the problem that Professor Buddhaparama just brought up. I think all of us who are part of this talk, you and Professor Buddhaparama and me and Professor Kauli, and all of us who have been fortunate to enjoy good mentorship. And I think you'd probably agree that each of us can look back on our careers and point to people who have mentored us and guided us and helped us and encouraged us. I think we have some obligation to pay that back. And obviously we can't pay it back to our mentors, so we have to pay it back to the next generation. So we have to look around us and find the people who we think would be really good at this and tell them, I think you would be really good at this. And I think too often, as people who are in our positions, we wait for them to approach us. And I think they're often intimidated to approach us. They may fear approaching us or wonder if we would embarrass them or maybe not support them. And so I've been pleasantly surprised when I see somebody who I think has some of the qualities that I would like to see in the next generation of academic orthopedic surgeons. And I tell them that unsolicited. The smile that it creates is very spontaneous and very authentic. And it's been fun to watch some of those people who previously said they had no interest in academics, just because somebody like you or Professor Buddhaparama goes up to them and says, I think you'd be really good at this. They may reconsider their career choice. Simply saying something kind like that unsolicited makes a difference. But as far as what you said specifically, the question you specifically asked me is how can we, if they approach us, what do we say? Or if they, even worse, they approach us and they say, I'm not interested in that because I don't think there's anything more to be learned there, or I don't think I could contribute. One of my mentors suggested to me when I told him, when I first arrived at the University of Washington, I said, I'd like to set up a registry at the University of Washington in Seattle for knee replacements and hip replacements to see how they're going to do. And this mentor is very smart. He said to me, you know, Seth, you could do that. You could do that. But the year is now approximately the year 1998 or 2000. I forget when exactly it was. He said, the Mayo Clinic has got a 30-year head start on you. And Harvard has got a 30-year head start on you. And God knows the Swedish arthroplasty register has got a 30-year head start on you. Do you really want to put all of that effort into answering questions that these other places are going to answer probably more effectively than you can? And even if you could answer some questions that they forgot to ask, it would still take you 10 years before you could start to do that. He said, he gave me the best advice I got starting out, which was find some corridors of relative indifference. That was his expression, and I'll never forget it. Some pathways or roads of relative indifference. Find some things that may even seem small, but around which you can frame some small answerable questions, projects that you could answer in 2 or 3 months rather than 2 or 3 years starting out. Specific sort of hypothesis generating questions, yes, no questions, small questions that aren't the things like, should we use posterior stabilized or cruciate retaining, or should we use cement or no cement? Leave that for the Mayo Clinic, leave that for Harvard, leave that for the Swedish registry. But Seth, why don't you ask some questions about, at that time, actually, it was positive outcome bias was one of the first things I did. It didn't take me enrolling any patients. All it took was a pencil and paper and a stack of journals. And I could start answering questions about industry sponsorship and positive outcome bias. So look for the smaller questions. And you may find that there are a lot of small questions that can get you excited. And I know that worked for me starting out. And in fact, I never really left the small questions. I never really wrote anything about cruciate retaining knees or cement and cementless. For me, it's always been sort of the questions that other people have left aside that are the most fun.
Okay. Yeah, Nico, you want to ask a question? There's just an announcement that Professor J. Parvezi could not join because of some issues, but we will take his talk on DVT prophylaxis a little later. You know, the talk was an interesting talk, VTE, money, politics, or patient outcomes, but we will fit that in later. So, Professor Nico, we have time for 2 more questions, and then we go to the live surgery. Over to you.
Yeah, actually, I would like to encourage also the audience, because now we have the Slido, especially during the live surgery, because if you look at, we have 12 live surgery, and with all this, with all the latest technology. So I think I encourage everybody to use this Slido. And it's another question, maybe Parag, from you.
Yes. There's one question on this statistical analysis, which I always have an issue with. You know, there is something which you can play around the statistical analysis and at times make it work in your favor. So what is your take? Which is the best way to do statistical analysis? Because most of the times we just outsource it. I will tell you very honestly. You know, we get the data and we have a couple of people, a couple of agencies who do that for us. So do you have any guidelines on how one does the statistical analysis? Because I think that's important for you. You know, unless you see there is some significance in that study, you would not be happy to take it through the editorial board and approve it. So please enlighten all the delegates. We have more than 600 people who have joined us now, Professor Leopold, on the statistical analysis part.
Well, that's a great question also, and probably more than I can answer in 3.5 minutes, because every study is different. And just like orthopedic surgery is a living science that changes every year, and we have meetings like this, our biostatisticians have meetings like this every year because their science is a living science too, and it continues to improve. But if I could say just one thing about statistics that I think readers should focus more on, and probably editors too, is worry less about the p-value and focus more on the question of effect size. So as a reader, if something's in a journal and it's coming to you and there's a p-value attached to it and there's a statistical analysis and you're not an expert on that, maybe leave that aside for a minute, because you're probably not going to become an expert by the end of that article. But focus your attention on how big the difference was. So if there is some new expensive technology, like we were talking about before, that might have cost associated with a risk or novelty that could hurt people, and it gave you 2 points out of 100 on the Harris Hip score or the HSS knee score or something else like this, maybe that effect size isn't big enough to care about. Maybe let's focus our eye more on something that the methodologists call the minimum clinically important difference. But you don't even need big words like that. Just look at the differences between the group, not the p-value, but the actual number of points or the range of motion differences or the time of healing, whatever the parameter is it big enough to care about, and focus a little more on effect size. And I think if we spent a little more of our energy focusing on effect size and maybe a lot less on non-experts like me trying to sort out what the analysis should be doing, we'd probably be further along. It's essential that guys like me get that analytic part right, and we've got a good team to do that. But I'm never going to become an expert at that. What I can do is try to ascertain whether the effect size is big enough to care about, or big enough to pay for, or big enough to expose my patients to risk over. And I think that's something that's often missed.
Great.
All right.
So
Yes.
we have one quick question from Nico, and then I have a short question.
No, you first. You first.
So the last question for this session is, how many articles in the last 1.5 years did you receive on COVID-related research in orthopedics? And, how did you tackle them and how did you select them? Because doing research in 2 months, 3 months, 6 months, I believe I have been reading, and then some of them just got published like this. So
Right.
How many articles did you receive and how did you view them? What was your, perception of these, and how did you decide to publish them?
Right. We created a fast track for COVID-related research, hoping that we would see some exciting and transformative work. And we saw a little bit of it. We saw a lot of submissions, but I wouldn't say we saw a lot of transformative research. And as I look more broadly across all of medicine, there were an extraordinary number of COVID-related submissions to all journals, and ours was no different. We got hundreds and hundreds of COVID-related submissions. We published probably a handful of them because many of them were, as you can imagine, something you can throw together that quickly is often not very spectacular. And COVID is not really an orthopedic illness, right? It's a pulmonary illness. There's not a whole ton of things orthopedic surgeons can say about it. I would say the most common article we got, and we got dozens and dozens of copies of this article from all over the world, was an article that asked some version of this question. If you close down your operating room because of COVID, what happens to your surgical volume? And the answer is it goes down. And, it's a little bit silly, right? And, when I was talking to an editor at JAMA, he said they had something just like that in internal medicine, which was, if you take a patient with COVID and you give them a blood transfusion, what happens to his hematocrit? And the answer is it goes up, because you give anybody a blood transfusion, their hematocrit. So the fact that these things happen in COVID are not terribly enlightening. We saw a few good COVID articles. And as I read the other good journals like JBJS, they saw a few good COVID articles, but it really wasn't an orthopedic illness. Most of the orthopedic articles were about systems. How can you get the OR working again after COVID? And there's sort of going to be a transient interest in that, but life is going to go on.
Perfect. Thank you. Thank you so much, Professor Leopold. We really learned a lot from your talk. That brings us to the end of the opening ceremony and the plenary session. It was really awesome. Our apologies that Jay Parvezi could not join, but we will tune in later for that talk. With this, I want to thank all the event managers, the Alison in particular, also Peggy and the entire team back office who have been a wonderful job. And last but not the least, Professor Rami Sorial from Sydney, Australia. for putting all this together. He has put up a wonderful scientific program and has been stimulating all of us. Thank you. And we go forward to the next session, which is a combined session for knee and hip in different auditoriums.
Good morning and good afternoon wherever you are. I am Mohammad Amin Chenoy. I'm speaking from Karachi, Pakistan. It is really an honor to be moderating this session along with Jim Sullivan, who is going to be our first speaker for this morning. Jim is a past president of the APAS, and he's going to talk about the direct anterior hip arthroplasty, here to stay. Over to you, Jim.
Good afternoon. I'm very grateful for Rami and Nico for inviting me to open the hip session. I'm going to talk about direct anterior total hip at APAS 2021. Is it here to stay? A recent survey of members of the American Association of Hip and Knee Surgeons with a response rate of 44% indicated that 56% of surgeons currently use the DAA. Non-DAA surgeons cited increased complication risk, no clinical benefit, and a steep learning curve is not adopting. Non-DAA surgeons reported loss of cases, and only 3% at that stage suggested they would change. The Australian Registry started recording approaches in 2015. The 2020 report records 157,000 cases since that time, 27% anterior, 54% posterior. There's a lot of literature comparing different approaches. Just going to talk about a couple. One is a study sponsored by JAMA of 30,000 patients in Ontario between 2015 and 2018. Only 10% were anterior, 70% were lateral. After matching the groups, the anterior had a 2% major complication rate compared to 1% for the lateral and posterior. They found that the anterior group had a higher rate of infection requiring surgery, dislocation requiring closed or open reduction, and revision arthroplasty. Study from the Norwegian Arthroplasty Registry from 2008-2013. Again, not a very big study, 21,000 with only 9% anterior and 54% lateral. They found no difference in implant survival at 2 and 5 years, increased risk of infection for the direct lateral, increased risk of dislocation for the posterior, no difference in periprosthetic femoral fracture. Much larger study from the Australian Registry, the 2020 report of 150,000 hips, 27% anterior, 54% posterior, no significant difference in the revision rate at 5 years, but there were different reasons for revision. The anterior approach has a higher rate of revision for loosening than both the posterior and the lateral. The anterior has a higher rate of revision for fracture versus the lateral for the first 3 months and posterior for the entire period. The anterior has a lower rate of revision for infection versus the lateral for the first 3 months and versus the posterior for the entire period. No difference between the lateral and the posterior. The anterior has a lower rate of revision versus the lateral for the first 6 months and versus the posterior for the entire period. And also the posterior has a high rate versus the lateral. My experience started with Charnley's back some years ago. Trans-trochanteric approach, I experienced a lateral approach. Most of my career I've been using the posterior approach. About 8 or 9 years ago, changed to the anterior approach. The major advantage that I've found is the ability to check the implants with intraoperative imaging. It eliminates that recovery X-ray anxiety. Done over 1,000 cases, and I still use image intensifier for every case. The X-ray is used to check acetabular penetration and orientation, femoral size and alignment, leg length and offset. Still use the posterior approach for revisions and primaries which have difficult anatomy or patients with a large fatty apron. Prefer to use the table. I think the advantage is that you need only one assistant. Ease of imaging. Disadvantage is you need a table and you need an experienced technician to minimise risk to the patient. Just briefly go through the procedure. The incision's over and in line with the fibres of TFL. The tens fasciolata fascia is opened and retracted. The muscles retracted laterally to expose the interval between sartorius TFL. So it's an internervous plane. You ligate the anterior circumflex vessels, expose the capsule. The capsule is opened along a line of the iliopsoas and vastus lateralis, and it's kept attached superiorly, so it can the retraction can sit on it to protect the tens fasciolata muscle. The neck cut is performed just above your planned level. Use a tapping sensation so you don't overshoot and decrease bleeding. And it's important to avoid a step cut. Don't want to be cutting into the greater trochanter. You can always lower the cut once it's been done the first time. Femoral delivery and preparation is probably the hardest to get familiar with. The process is to release the pubofemoral ligament so that you can readily palpate the left trochanter with your finger, and then progressively externally rotate the leg. Clear the superior capsule, superior to piriformis insertion, and as you progressively externally rotate the leg, you can lift it forward so that the trochanter is no longer behind the acetabulum to reduce the risk, to reduce fracture risk. And then you can see you've got ready access to the femur to put your broaches in. Perform a trial reduction with the true cup in situ, trial liner and femoral broach, neck and head assembly. Check stability anteriorly with 90 degrees of external rotation, and then get the imaging. We image both hips in the same plane and orientation with magnification. And a good radiographer can reconstruct a pelvic shot like that if they can see the symphysis pubis. We can compare the intraoperative imaging with our planning, which is maybe CT-based or templating, and the usual landmarks to check height of the implant, leg length, offset, sizing. The learning curve is an issue, has been an issue. The literature suggests that a paper from Steiger suggests more than 50 cases for the learning curve. A lot of those cases were done without X-ray, and a more recent paper out of Paruccio suggests the learning curve can be eliminated with progression with surgical assisting, using videos, cadaver workshop, good case selection, and use of surgeon proctors. And I can't stress enough the importance of intraoperative imaging. Conclusions. I believe the anterior approach is here to stay. Many surgeons want to have experience with different approaches. I think if you are established hip surgeons, it is good to be able to familiarise ourselves with the different approaches. It can be learnt safely. There's evidence of lower infection and dislocation risk. It's not extensile, and it's not the best option for everybody. Thank you very much.
Good morning, ladies and gentlemen. My name is Sal Karachi from Sydney, Australia. I'd like to start by congratulating Nico and Rami on putting together such a wonderful conference despite the circumstances. And on that note, our thoughts go out to everyone affected in the Asia Pacific and the subcontinent. I'll be talking about MIS, hip philosophy and results on posterior approach variance. Well, the philosophy is very old and very simple. You minimally invade, you cause less trauma and hopefully a lesser inflammatory response, positively affecting surgical parameters and ultimately resulting in a quicker return to function. There's publications dating back to the 70s by Watanabe, but really the credit in creating a spike in interest for hip approaches has to be given to the work of Vail and Skulka with their incision posterior technique. With Steve Murphy describing SuperCap in 2004, Brad Pennenberg describing PATH in 2008, and more recently, Doug Rogers with his transpiriformis or direct superior approach, as well as the direct anterior approach, which has left its mark in the last 15 years, at least in Australia, all being a manifestation of an evolution of the same philosophy. In regards to described variants in the posterior approach, they fall into two categories. You have either the mini-incision posterior approach or you have the supracapsular approaches, and they're known as that because of the location of the incision on the hip capsule being posterior superior. And of these, there are four. You have the DSA, direct superior approach, supercap, PATH, and superpath. The mini-incision posterior technique has been around for about 20 years or so, and it's essentially like a posterior approach, but the aim is to try and preserve the quadratus. And you achieve this by the use of curved Cobra Hohmann retractors and smiley face retractors. But there is a bit of emphasis placed on the size of the surgical incision as a descriptor for this technique by some authors, including in the title of the technique itself. We know now that that's not of any consequence. You can perform a maximally invasive operation through a very small incision. So we're looking for some consistency where the size of the surgical incision is not as relevant, it's what you preserve underneath. And that's really the underpinning philosophy in the supracapsular approaches, where a spectrum of preservation within those techniques and that degree of preservation being the descriptor amongst those individual techniques. They're all expansile. They can easily be converted to a posterior approach. And salvage is very easy, so there shouldn't really be a learning curve unless you're trying to do it in a rush. Broadly speaking, you classify them into ones where surgical dislocation is required or ones where you don't dislocate the hip surgically. And the initial part of these techniques is all very similar across the individual techniques. You have a lateral decubitus position. Probably the top half of the posterior approach incision is utilized. You go through gluteus maximus, exposing medius and retracting that anteriorly, exposing the rotators and minimus. Minimus goes anteriorly, rotators get incised or preserved, depending on your choice of technique, exposing the posterior superior capsule. So they're all very similar up to this point, but the variation is from this step onwards. So looking at DSA, for example, you identify and tag the piriformis and conjoint tendon. Then you expose the capsule, you do a capsulotomy, and you extend the capsulotomy superiorly and inferiorly, or anteriorly posteriorly, to achieve the desired degree of excursion, dislocate the hip, prepare the femur and acetabulum in routine fashion. But you do need special instruments, including an offset reamer in this photo here, which was sent to me by Doug Rogers a few years ago. Supercap is very similar, except for when you do the capsulotomy is a straight cut. So you don't extend it superiorly or inferiorly. You pretty much maintain the ilioischial ligament in its entirety, which means you can't dislocate the hip. And that means you have to perform an in situ femoral preparation, broaching, etc. And then you do an in situ neck cut like this. And once you've performed the in situ neck cut, you excise the femoral head, often piecemeal because it's easier to do so. Once you've done that, you prepare the acetabulum using an offset reamer and trial implants. But for the very same reason you couldn't dislocate the hip, i.e. the ilioischial ligament, you can't relocate the hip as easily. So you have to perform what's called an in situ reduction, where you put the head in first, then the stem, and reduce the neck of the stem into the head. And then you close the capsulotomy, and it should give you a very stable construct. In fact, Steve Murphy aimed for a non-dislocatable construct on the table. A few years later, Brad Pennenberg introduced the cannula, and that was great because that obviated the need for an offset reamer. You could perform an inline preparation of the acetabulum through the cannula, putting the reamer shaft through the cannula. Although in his technique, he did describe femoral head dislocation as part of the technique. With SuperPath, it's a fusion of these two techniques. So you have the cannula-like path, which allows you to prepare the acetabulum in line and obviates the need for an offset reamer. But because you preserve the ilioischial ligament and you didn't dislocate the hip, for that very reason, you have to often perform an in situ reduction, or you can perform an ex situ reduction, but you just have to release a bit more. The implication of that is that you have excellent stability on the table. We also aim for a non-dislocatable construct on the table, and I tell patients there's nothing impossible. I'm sure you can dislocate it if you try hard enough, but we don't tolerate any instability in our trialing. And when it comes to preservation of the soft tissue envelope, it's the least invasive method. Results? Well, now in favor of MIS, there's plenty of evidence. There are some studies showing increased complication profile as well, but there's a lot of inconsistency in the literature as well. And majority of that literature is in relation to the mini-posterior or mini-incision posterior approach, including some meta-analyses. The problem is when you bucket all the MIS in one category, the literature is inconsistent for that reason, because you can't compare, you're not comparing apples with apples. And also comparative standardization amongst techniques is very difficult. In regards to supracapsular approaches, SuperPath is probably the most studied. And whilst there's still scarcity of literature in regards to hard evidence, like joint replacement registry data, there's still plenty of studies showing good results in support of SuperPath. I've done just under 1,400 cases, and fortunately, we've had a pretty low complication profile, and the rigid rate of less than 2%. Jimmy Chow, who taught me how to do this, also published his results earlier on, along with our results here in Australia, and Wayne Gott's results in Canada, and many others who've found favorable results, not just in regards to perioperative complication and length of stay and short-term recovery, but also costs and 30-day readmission rates, etc. And just like an explosion of data with the anterior approach in the last 10 years or so, SuperPath, we've also had a lot of studies coming out in the last 5 years in favor of SuperPath in relation to those indices mentioned in the last point there, including some meta-analyses in the last few years comparing it to DAA and posterior approach and other conventional approaches. Ultimately, though, the differences are in the short term, there's no bad technique, just badly done techniques. And the right technique is what works best in your hands for your patients. A hip replacement is a winner operation because it doesn't matter how you do it. At the end of the day, as long as it's done well, you'll have a good result. And that's really the take-home message. I thank you for your attention.
Good afternoon, good morning, good evening to all faculties and participants wherever you are. I hope you are all safe and healthy. Thank you for having me today. We will discuss about the treatment of the dysplastic acetabulum, especially for shallow one. Which one is preferred, acetabuloplasty, PISA technique, or combined? Now, if we take a look to these two pelvic AP view radiograph, presumably, can we achieve an adequate good coverage and stability if we want to perform total hip arthroplasty in this patient? Three key issues we have to address in dysplastic hip are where and how the acetabular cup position is going to be, bone stock deficiency, and the third thing is use of highly porous metal. Ideally, we want to achieve the restoration of the normal hip center with positioning of the cup in anatomic position level of true notch to reduce the stresses and increase the implant longevity. This can be achieved by good lateral coverage, adequate medialization, press fit of the cups, restoration of the offset, good inclination approximately 40 degrees, anteversion approximately 15 degrees, depend to the approach. In order to achieve stable joint, a hemispherical shape is very important factors for an acetabulum component to get the press fit stability. This press fit stability means that is stable in the rim and also stable in the dome. This is the bilateral dysplastic acetabular with the same severity right and left. So in the left side, we do the acetabuloplasty. But in the right side, we will do the PISA rimming technique. Here, we can see the four quadrants of acetabulum. We start from posterior inferior up to superior anterior. Yes. Posterior inferior, medial, and superior anterior. So we perform, in this case, is PISA technique on the right side. And you can see more center rotation in the true notch is achieved compared to the acetabuloplasty. In other hand, performing acetabuloplasty, step one in obtaining sufficient support is to use smaller acetabular component. And the second, adequate support is believed about 70% of the cementless acetabular hemisphere be covered with the intact viable host bone. 30% of the lateral portion of the acetabular component need not be covered with the bone. This remaining 30% can be covered with the particulate bone graft, preferably autologous, but acceptably allograft, to have good acetabular inclination and stable cell. This is the case acetabuloplasty using femoral head autograft. This is 50 years female with a systemic lupus erythematosus on steroid medication with the right dysplastic hip. The result of total hip arthroplasty show good acetabular inclination and anteversion. Unfortunately, 3 months later, due to the autograft lysis, make malposition of the acetabular component, resulting in dislocation. So it means acetabulomplasty is not recommended for patients with biological problems. This is 40 years old male with a 2 cm leg length discrepancy with the right dysplastic acetabular. Here we can see a PISA techniques for acetabular rimming. PISA stand for posterior inferior superior anteriors. We rim from posterior inferiors medially up to the superior anterior with the vertical rimmings. This is the pre and post-op pictures. We successfully restore the acetabular offset and femoral offset. Sometimes we have to combine PISA and acetabulomplasty, such as this case. The previous surgeon failed to restore the center of rotation of the acetabulum, restore acetabular offset, and medullarize the components. End up in implant failures and dislocation. We revise the acetabular component, remove the acetabular component, and then we do the PISA rimming technique, and then combine it with the allograft acetabulomplasty. Acetabular offset was restored. And this the immediate secondary follow-up and 3-month follow-ups. Previously, the patient is very difficult to do the mobilization. This is the primary difficult total hip replacement case. We perform subtrochanteric osteotomy, PISA technique, combined with the acetabulomplasty. The outcome is quite satisfying, as the majority of the Indonesian who are Muslim need sitting atahiyat position to pray or salat. So for the take-home message, diverse anatomy, younger age, bone stock deficiency spectrum of the dysplastic acetabulum make the total hip arthroplasty a challenging and demanding technique to perform. Dealing with the dysplastic acetabular, we should try to perform PISA technique first to achieve stable and adequate good coverage. If it is not adequate, we can combine it with acetabulomplasty. Thank you for the attention.
Good morning. I am Professor C.S. Yadav from Delhi, and I am thankful to the Abbas for giving me this opportunity. And topic is very interesting: management of fracture in upper end of femur in elderly. And I am working as a chairman head in one of the corporate hospital known for the arthroplasty. Now, if fracture is with osteoarthritis, with tumor or chondrolysis like this, then there is no confusion. Straight away, go for total hip arthroplasty. And when there is a fracture, neck of femur between the above the age of 60 and fracture IT above the age of 70, there is always dilemma what to do, whether to do internal fixation and or to do arthroplasty. Then question comes, which arthroplasty, hemi or total? So I will discuss all these things. And there are various modalities of treatment for the fracture upper end of femur. I will discuss all these things. Now, whether to sacrifice the joint and save the joint, this depends on the fracture pattern, fracture geometry, whether fracture is old and fresh, physiological age of the patient, anesthesia level, cognitive function, and most important clinical thing is pre-fracture activity. When patient has good pre-fracture activity, then we should think about the total hip arthroplasty. Now, few points about the undisplaced fracture neck of femur. If they are treated by internal fixation, rate of non-union AVN is very high, and overall conversion to the total hip arthroplasty is around 8%. If they are treated non-surgically, then later on the treatment is required in more than 50% cases. So even if it is undisplaced, go for the surgery. If it is displaced fracture neck of fever, failure rate of internal fixation is all very high in comparison to undisplaced. Even hemiarthroplasty failure rate is very high. And overall conversion rate to THR is very high. And most of the patient, they require conversion into the total hip replacement around the age of 5 years. And now question is which arthroplasty in fracture upper end of fever, uni, bi and THA. I will discuss one by one. So overall criteria depends on processes should outlive the patient. That is most important. And hip score should be good and it should provide early rehabilitation. Now question is why unipolar? It I do not do in my practice. It can be offered at the primary healthcare center where no other alternatives available. It has many problems like acetabular erosion, thigh pain, and overall you cannot adjust the limb length and offset. So bipolar, it has all the advantage over the unipolar, and even revision rate is much less than the unipolar, and like acetabular erosion and thigh pain is, groin pain is also not seen in the bipolar in early stage. Now question is why not bipolar? Why total hip arthroplasty? Because bipolar still has scope for the acetabular erosion, and hip score is better is total hip arthroplasty than the bipolar. Now question is why THR? Because THR is definitive procedure. It gives guarantee of processes which outlive the patient, and there is a no risk of early groin pain. And what I think, if patient will survive more than 2 years and patient has outdoor activity, then I always opt for THR, not hemiarthroplasty. If you go through the various meta-analysis, the failure and reoperation rate is minimum in total hip arthroplasty in comparison to the internal fixation and hemiarthroplasty. So now which type of THR? It doesn't matter depending on the patient age and overall bone quality. So depends surgeon to surgeon as well. Sometimes patient, usually most of the time conventional stem is required for the fracture neck of femur. For the fracture intertrochanteric, long stem may be required, and dual mobility when there is a high risk. In these patients, there is a high risk, especially in the fracture IT. Then you may go for dual mobility, but usually I use 36 or 32 millimeter head, and it gives quite good stability. Additional fixation may be required. So overall thing is that patient should walk from the second day, whatever joint you use. That is most important. I will not go into the detail of pros and cons of cemented or uncemented THR because of shortage of time. But when there is a severe patient having severe comorbidity, do cementing with the gun, do cementing with the manual method, not by the gun, to prevent the monomer release. And if you go through the posterior approach and do extended posterior myocapsular repair, dislocation rate is as less as any approach. Total hip arthroplasty is a challenge in the fracture IT, and challenge is at every step, like to prevent the dislocation, to restore the length, to restore the offset and version of the stem. So it has to be very tricky. Identification of entry point is required. These are the various tips by the help of image intensifier. And control of version is also very tricky. So you should be very good at eyeballing, use the position of the table and patient, position of the foot and femoral condyle. They may guide you for your anti-version. Do repair of the abductor. So good positioning of the pelvis, good position of the table, and should know the exact position. And these repair and reconstructions are also needed. These are various cases. Like here, you can see the fracture IT failed, THR was done, dislocated, then it was revised. So you can see now finally this fracture is uniting. Another case, fracture IT failed fixation and THR was done. This stem was in 20-degree retroversion. So I revised it, it was done somewhere else. And another case. So overall messages, modality of treatment depend on the type of the fracture and pre-fracture activity. Arthroplasty is in IT fracture is very tricky, and failure of internal precision hemiarthroplasty is very high. So I prefer THR, and overall prosthesis should outlive the patient. And extreme is low demand patient, cemented bipolar is good options. Thank you.
Hi, my name is Omar Bernie, and I'm going to be talking to you today about anterior total hip arthroplasty off the table. So, brief introduction: anterior hip replacement is a well-accepted procedure that offers improvement in short-term outcome studies as well as pain relief as compared to traditional posterior hip replacement. Most significant obstacle in adoption of this procedure has generally been the steep learning curve, primarily in the early adoption period. And then, of course, the need for specialty equipments and implants. The non-academic setting in which I operate is also a challenge, as it provides for inconsistent and often poorly trained surgical support teams as opposed to the academic setting. The various advantages as listed here, the studies will reflect that these advantages can be, of course, controversial in nature, and you can find studies that support both pro and con. These are the advantages that I highlight. The purpose of our study was to show that the procedure is easily transferable, reproducible, and predictable. This was done by several techniques, but highlighted here are some of the more important ones that I'd like to highlight through this presentation. The most important of which was the elimination of the specialty table that is often used for this anterior hip procedure, and then of course many of the specialty retractors that were simplified in our methodology. So here's an overview of the retractors. Briefly, you can see we have a combination of Homans, Cobras, angled Gelpies, and some very simplified L-shaped and what I refer to as a Z-shaped retractor. This is the patient's initial setup. This is a radiolucent table. The patient's waist is placed at the break of the table. The ipsilateral arm is draped across. The contralateral arm is accessible to anesthesia services. An arm board is placed at the contralateral side to widen the bed to allow for abduction of the contralateral extremity during preparation of the femoral canal. Another view of the initial setup. Surgical incisions fairly standard, 2 centimeters lateral, 2 centimeters distal to the anterior superior iliac spine. Superficial dissection, as we know, between tensa fasciolata and sartorius, protecting lateral cutaneous nerve. There's the fascia being elevated such to protect the nerve. One of the highlights of this procedure is an in situ excision of the femoral neck. We perform a napkin ring osteotomy. Thereby, there is never a dislocation maneuver performed on the hip. Acetabular preparation, as many of us have experienced, the anterior approach allows for wonderful exposure of the acetabulum. And then, of course, implantation is confirmed with fluoroscopic guidance as one of the bigger benefits of the anterior approach, especially on a radiolucent table. We then deliver the proximal femur into the surgical wound. This can be done by placing the ipsilateral extremity in a figure 4 position and dropping the leg of the table. No other break of the table or specialty maneuver in the table is necessary. The contralateral extremity is abducted at this point in time. Femoral preparation then becomes quite easy and straightforward. You can see here that we're using a double curved broach handle, but given the nature of the deliverance of the proximal femur, one could often use straight and non-curved broaching equipment. In this procedure, we adopted to cement, and you can see here we've used a straight implanter to implant the femoral stem in place, and cementation can be undertaken. Final confirmation of positioning and trialing, and then our final product. So in our unpublished data, we've performed 2,154 patients via this anterior approach over the course of approximately 10 years. You can see here the breakdown between the males and females, age ranges, and this was all performed by myself as a single surgeon in a non-academic setting, primary diagnoses of osteoarthritis, inflammatory arthritis, and hip fractures. Both cemented and uncemented stents can be used. Here's our results. We've had a significant improvement in the HARE-PIP score comparable to what is reflected in the literature, as well as the PROMS data to include the WHO score. Complication rates are minimal, less than 1% transfusion rates, less than 1% deep infection rates. We had some early proximal femur fractures that was primarily due to a double tapered short wedge type stem, which we have since migrated away from. Early dislocations primarily due to anesthesia techniques and over relaxation of muscles that was requested. We have since backed off of this. A few late dislocations, and most importantly, the lateral cutaneous nerve palsy, which is consistent with the data for anterior hip replacements in the literature. So in conclusion, this is a very predictable procedure. This can be easily portable. I've personally performed this procedure in Pakistan in a charity hospital setting, and was in fact able to teach the resident and trainee surgeons at that facility with minimal difficulty. Very few of my retractors had to be transported from my base setting in the United States to Pakistan to perform this procedure, and I was able to easily treat the patients there. Thank you.
Thank you. Thank you very much, everybody. I think we had a very fruitful session. The first talk was by Jim Sullivan on the direct anterior approach. And then last talk again was on the anterior approach by Omar Birney. I open the house if there are any questions from the audience or if any of the faculty want to comment before we actually take questions from the audience. Jim, yes. Yeah. Tell us something. Tell us something about your direct anterior approach, and how do you compare that with what Omar has just said?
Well, I think the approaches, they're very similar, actually. It's just the difference is how you position the leg to get access to the femur. That's the main difference. And it's just a matter that, I learned the approach with the table, and I find it very straightforward. I find it easy to teach the registrars that approach. And but if I had to go to off table, I could go to off table. I think it's they're not that different. Would you agree, Dr. Birney?
Yeah, no, I agree. The reason why I started off the table, I think, in most cases in community settings, obviously the table is an investment. And often the smaller hospitals are unable to acquire those specialty tables and inclusive of the retractor. So frankly, I started my journey in anterior hips off the table, primarily for that reason. It's become quite a success story. And as I've talked about in my presentation, I've made it quite a portable procedure by that regards. So I'm not limited by the specialty table from that perspective. But I agree with you that the procedure is basically one and the same.
I think the biggest value that I've found having done it is the ability to get intraoperative imaging, as I mentioned in the talk, and it's just very reassuring to check where your implants are before you sign off. You don't tend to do that when you're doing. You wouldn't finish a fracture without checking where things are. So hip replacement, you want to last 25 years or more. It's nice to know that it's as accurate as it can be.
Right. The only other thing I would like to point out, completely agree with you, Dr. Sullivan. The only thing I'd like to point out is some of my colleagues who do the anterior approach on the table don't really go through a range of motion final testing. They rely purely on the image, which obviously some of us traditionalists were always taught to go through a final range of motion. And so if your foot is locked into a boot, which is usually the case on a specialty table, it's usually a little bit harder to break it out of the boot and do a range of motion test, whereas off the table, obviously the foot is readily available. So that's the only other implication that I would say would be one of the advantages that I found in off the table.
So can I ask you, with the SuperPath, it's another different approach with very not much visual access to the femur, would appear. Can you just talk us through the learning curve and to get on top of that approach before you'd feel confident.
Yeah, thanks, Jim. Can you hear me all right?
Yeah.
Yep. Most people that come to visit after they've seen one, they think, "Oh wow, we didn't realize you could see so much." So the visualization actually is pretty good for the surgeon. Obviously, the assistant can't see much, and so in regards to the femur, you get a pretty 360 view of the femoral calca. You obviously can't feel the lesser trochanter or see it. You can feel the greater trochanter. We don't normally use it as a reference because no one knows how thick the muscle envelope or the abductor insertion on top of it is. But you get a pretty good view of the femur. So that's not an issue. I was a posterior press surgeon. I toured with the idea of starting anterior, did some in my fellowship, but never really got around doing it. So when I saw SuperPath, I was actually quite surprised. I thought, oh, great, let's try it. And in regards to the learning curve, unless if you take your time, it's not really that much. And the thing is, it's like a posterior approach. So if one feels that they're not comfortable or they're stuck somewhere, all you got to do is just release the piriformis or the conjoint or the gemmelli or a little bit of the capsule, and you can incrementally increase it all the way to a posterior approach. So it's pretty. You won't get stuck anywhere. It's very easily expansile. My first complication was a stem subsidence, and she subsided about a good 1.5 to 2 centimeters, which I actually treated non-operatively, and she's now 7 years, and she doesn't feel a leg length discrepancy. But and that was case number 50-something. So I was pretty lucky in the first 50-odd cases. So I think the learning curve's not. I don't know if there is a learning curve unless someone's trying to go through it quickly.
Dr. Yadev, with that. Sorry, Min.
Go ahead.
Dr. Yadev, some of those fractures you were showing, which you converted to total hip replacement, there wasn't a lot of use of intramedullary fixation in the subtrochanterics or high subtrochanterics. Is that sort of an issue with equipment, or what's your approach to these? What's your approach to these high subtrochanteric fractures?
For the subtrochanteric fracture, basically, if it is a very elderly age group, and usually most of the time he can walk with the help of PFN. If I am able to make him walk with the help of PFN, then you can go for the PFN in subtrochanteric fracture. In intertrochanteric, it is always elderly. I will go for the arthroplasty. Intertrochanteric, it's a neck of femur, elderly, I will always go for the arthroplasty. Depending on the circumstances, it may be bipolar. But in subtrochanteric, there may be option for the internal fixation as well. Because after the internal fixation, it may allow full weight bearing.
Thank you.
Nah, yang itu kan karena di sini harusnya. Nah, biasanya kita sendiri bisa.
I don't think I've seen anything from the auditorium on my Slido. Have you got any more comments to make?
Ya, tapi biasanya bisa. Aku. Ini kan apa?
I think we should be asking Ismail about his PISA technique.
Ini itu kan.
We can elaborate a bit more on that technique. Ismail?
Yes. Can you hear me?
Yes, we can.
Okay. What's the question?
I was hoping if you could elaborate more on your PISA technique.
Oh, yeah, okay. So the PISA is actually like I mentioned in one of the cases in previously, we always do the acetabuloplasty, but some of the cases, especially who has a problem with the biological factors, so the incorporation of the allograft or autograft is the problem. So that's why if we do it PISA as much as possible, we routinely using PISA technique that the starting point is from PISA. It stands for the posterior inferior superior anterior. So it means the vertical rimming is started from posterior inferior and then gradually up to the medially and superior anterior. So in this case, with actually this is the medialization procedures. So we expect in this case we can get the acetabular in the true nodes and also restoring the acetabular offset better compared to the acetabuloplasty.
So do you use a smaller size reamer and just place it first posterior, inferior, and then the middle, and then go anterior and superior?
Yes, correct. The smallest reamer, that one number of 38. Yeah, 38.
Right, and once you've done that, then you take a bigger reamer and make it hemispherical.
Yes, after we achieve, we get the most medial. So with the tricks, with the parameters, we can get the paprika sign or subchondral bones. Yeah. So after that, we do it with a reamer that set up based on the inclination and anteversion that we would like to achieve. So it depends to the approach. For instance, if like me, if most of the time using anterolateral approach, 10 degree of anteversion. But if you do it in posterior approach, usually the anteversion is 20 until 30 degree for the rimming, the exact rimming of acetabular component.
Because it was very, very interesting to see you allow your patients to sit down on the floor with their hips and knees fully flexed in the prayer position.
Yes, that's our goal, because Indonesia is a Muslim country, so most of always demand by our patient is can see or he do the atahiyat position, praying position. Usually I allow them for after 3 months. After 3 months they can do regular or perfect position of salat, praying position.
That is very, very interesting, because the same is the demand by our patients here in Pakistan. But I am never allowed my patients to do that. I don't allow them to deep squat with their joint, hip, especially hip arthroplasty at all.
Yes, yeah. Most of them, we have done the study. I think more than 60%. They can do a come back or return to the perfect position, atahiyat position. But the rest, maybe because of I believe there are many factors they can do the atahiyat praying position, like severe obese, if the patient severe obese, and also there is also problem with the muscle problem, or they also some of them they have the psychological problem. Psychological, they're not confident. That usually they cannot do the. But if the patient, especially for young, like I present in the case is a very young patient. They usually more than 90%. If young patient, young adult, they can do the atahiyat praying position.
Dr. Sullivan, do you want to add anything to that?
Ismail, do you, in situations where you don't have enough coverage of the cup, even when you've medialized as much as you have with the PISA technique, do you use cotiloplasties at all to try and get more superior support of the cup?
Yeah, we try as much possible. So with this technique, we try to restore the acetabular offset in the original in the true node or in the teardrop, in the teardrop level. So we did not want some of them, if the more severe of the dysplastic. So we try a little bit higher up, to contain the acetabular, especially if the smallest cup that we have could not contain that problem. Especially if we notice in our practice, in our patient, that if the inclination, or original acetabular inclination is more than 60 degrees, and also less than half portion of the medial, the bone stock.
Smile, I'm sorry to cut you off,
combine it.
But I'm sorry to cut you off, but we have to finish the session because the next talk is going to start in a few moments now.
Okay.
Thank you. I thank you all. I thank all the participants for their very, very interesting talks. Thank all my colleagues who have presented, and Dr. Sullivan as well for their participation and moderating of the session with me. Thank you very much.
Thank you.
Good morning, dear audience. I'm Guoqiang Zhang from 301 Hospital in Beijing, China. My topic is posterior capsule reconstruction using mesh for reinforcing the stability after total hip arthroplasty. As we all know, there are three main factors of instability after total hip arthroplasty: patient-related factors, iatrogenic-related factors, and prosthetic-related factors. Among these factors, approach may be the one which is the most concerned. This table is just show the dislocation rate of different approach total hip arthroplasty. From the result, we found the dislocation rate of posterior total hip arthroplasty is highest regardless of the repair. What's the intrinsic factors of high dislocation rate in posterior approach total hip arthroplasty? Firstly, let us review the anatomy of hip. This is the ligament of the femoral head, a structure linking femoral head and the acetabulum as a hinge. So, hip joint is a kind of soft hinge joint. However, this structure is resected during total hip arthroplasty. The second important anatomic structure is capsule. In fact, posterior capsule consists of many different fibers and ligament, including ischiofemoral ligament and the zona orbicularis and the spiral fibers. It plays an important role on stability of hip. However, the posterior capsule is also damaged during total hip arthroplasty. This is a cadaver study published in Journal of Arthroplasty. It evaluates the effect of capsule and short external rotators on hip joint stability in different approach, respectively. The result showed the capsule had a more important role on hip joint stability than short external rotators, not only anterior approach, but also posterior approach. So during the hip moving from extension to flexion, the capsule will create a hook force and keep the joint stability. Unfortunately, post-approach total hip arthroplasty changed some important features from natural hip, such as the loss of the feature of hinge joint, posterior capsule resected, and couldn't repair directly. The size of femoral head is smaller. As a result, the dislocation rate is higher. How to take remedial measures for the intrinsic factors? As for the prosthetics, there was a good solution. That is dual mobility design. But for the technique, what can we do? We designed a new method to increase the stability of the hip joint, reconstruction of posterior capsule using a mesh. Firstly, a mesh can be prepared to a V-type for reconstructing the posterior capsule. The right picture just shows the mesh has already been sutured to the capsule. From the video, we can see the remnant capsule is too short to fix the grid trochanterus. So the mesh can link remnant capsule and the grid trochanter. This video just shows the mesh that has already fixed to the capsule can link to the grid trochanter. These are intra-operation pictures. They show use ethibond suture to fix mesh to grid trochanter. These intraoperative pictures show the mesh has been fixed to the grid trochanter completely. After that, piriformis was also fixed to the grid trochanter after mesh fixing. After finishing reconstruction, we can test the stability of the hip. We can see it is very stable in full range of motion. From this video, we can see the mesh structure is very similar to the capsule in natural hip. We can see this mesh structure increase the stability of the hip. This is a typical cases. This is a necrosis of femoral head combined with polio. So she belongs to the high risk case. After implanting the prosthesis, we reconstructed the capsule by using mesh. This is the post-operative X-ray and the walking gait 3 days post-operation. Take-home message. This is a new and a simple method to reconstruct a capsule. It increasing stability of total hip arthroplasty is reliable and valuable. By now, we have performed 15 cases with high dislocation risks, such as femoral neck fracture, muscle weak around hip. There is no dislocation occurred at 1 year follow-up. So this is a very good and a simple method during operation. Thank you very much.
Hello and good afternoon, evening or morning, wherever you may be. And could I start by thanking the organisers of APAS? I know a lot of work's gone into getting this meeting to this stage. My brief is to talk about dual mobility articulations in total hip replacements, when and why. Please see my disclosures. Give you a quick overview of what I'm going to say. Dual mobility articulations offer more stability due to the largest possible effective head size being able to be achieved for any given cup size. I think it's reasonable to say that the use in high instability risk patients is justified, and we should consider more its use in patients with abnormal spine and pelvic motion parameters. We should also be aware of the potential new, if you like, complications, especially with modular shell inserts, which have less clinical history. So there's a kind of a changing face of failure mode in total hip replacements, with fracture and dislocation remaining the most common causes of revision on most joint replacement registries, with wear-induced lysis markedly reduced since the introduction of highly cross-linked polyethylene. Dislocation is often associated with component malposition, but we're getting a better understanding now of how to identify those patients where accurate component position alone does not guarantee stability. Dual mobility designs offer a further increase in jump height and allow the largest possible effective head size for any given cup size, therefore theoretically reducing the risk of all parts of the instability spectrum, of which dislocation is the endpoint. Dual mobility articulations have a long history of use in France. There's been an increasing use in non-French-speaking countries in the last 5 years, and that's demonstrated well by numbers on joint replacement registries, and certainly sentiments changing significantly at large orthopaedic forums, particularly the AAOS. But of course, with any change comes the risk of unknown consequences. We need to be aware of the risks of intraprosthetic dislocations, excessive wear of the large polyethylene ball, or hopefully not too bad with the introduction of highly cross-linked poly. Prosthetic femoral neck impingement has been reported recently, and we also got to consider the adverse taper conditions that may occur when you insert a cobalt-chrome liner into a titanium shell. So we've got to balance this known risk of instability in predictable scenarios versus the unknown risk of the consequence or the unintended consequence of change. And I think the British Journal summarised this in an editorial a few years ago, saying it's our responsibility to embrace dual mobility technology and apply it effectively. And the need for more data should not delay its responsible introduction. I think it's a very fair summary. So the classic indications for the use of large head size or dual mobilities, I think in our teaching has been, when you have a primary diagnosis of femoral neck fracture or avascular necrosis, if you've got known abductor deficiency or neurological conditions, Parkinson's, CVA, etc. But I'm actually going to add sort of another one in here that we need to think more about, and that's the patients who are on this instability spectrum risk, if you like, based upon preoperative assessment of spinal parameters and pelvic mobility parameters. And there's been some recent reports where 80% of cases revised for dislocation had one or more spinal pelvic mobility risk factors. So we're going to add that to the classical teaching. So to try and find those, identify those patients with spine and pelvic mobility parameters, putting them at risk of instability, you need to measure something. And I'll show you what I measure as a routine. I'll do 2 functional lateral x-rays of the pelvis and spine. And that'll that'll be done in the standing and the flex-seated posture. And that will allow calculation of lumbar flexion and standing pelvic tilt. I get a CT acetabulum that gives me the supine pelvic tilt and the pelvic incidence, and also allows me to do some accurately introduce the acetabular component. So, we've got to have some published measurement thresholds to work on. So I think people who are at risk of instability due to abnormal spinal pelvis are those who have abnormal pelvic mobility, and the literature defines this as if you have a standard flex-seated pelvic tilt change of 20 degrees in the anterior direction, or when you go from supine to stand of 13 degrees in the posterior direction. And the abnormal spinal parameters of a stiff lumbar spine, an imbalanced lumbar spine, or a standing pelvic tilt of greater than 10 degrees posteriorly as a well-published surrogate for the stiff spine. So here's a patient who fits this category of having abnormal pelvic mobility parameters with a relatively normal spine, or a spine that doesn't fit the abnormal guidelines. So here we have a situation, we can run this video and we can see here that with significant postural change here, that the functional change in the acetabular component, particularly version, and this risk of impingement that occurs because of that. So we need to identify these people beforehand. And here's a view of this sort of anteriorly, showing the significant change in the functional component position. And I'm going to be talking more about that later on this afternoon. If we look at the patients in the yellow here with the abnormal spinal parameters, so stiff spine, imbalanced spine, here's an example of someone with that. So we can see the pelvic mobility parameters in that box up the top in black, they're kind of normal. But you've got a very stiff spine lumbar flexion of 10 degrees and an imbalanced spine as well. So we can see in this scenario here, if we run this patient's demonstrating a risk of bony impingement anteriorly in flexion. So these people have to be identified. So those patients with abnormal spines and pelvic mobility, they're the ones where you must have really ludicrous or ridiculous on-table stability without compromise. So they're the patients I'll do the full trial options in every single time. We looked at 229 patients in a group of surgeons in Australia that had a dual mobility articulation used when they had one or more of those spinal pelvic risk factors. These are people who are known and have a published high risk of instability. We followed them for a mean of 13 months. So in 229 patients, 11 surgeons had one or more of abnormal spinal pelvic motion parameters. There were no revisions for instability when a dual mobility was used after this method of identification. So in summary, dual mobility articulations offer more construct stability due to largest possible head size. I think their use in high instability risk patients is justified, and you should consider its use in patients with abnormal spinal pelvic motion parameters. But be aware of potential new complications, especially those with the modular shell inserts, which have a much less of a clinical history. Thank you very much.
Thank you to all participants and faculties for having me again. This time we are discussing total hip replacement in acetabular fractures, when and how to do it. These cases, neglected acetabular fracture, both column and T-type fracture in elderly, acetabular fracture associated with the femoral head fracture in elderly. The question is, can we achieve an anatomical reduction and stable fixation in these acetabular fracture cases? Our treatment goal in acetabular fractures is mainly focused on two things: anatomical reduction of the articular surface, and the second thing, joint stability to prevent post-traumatic osteoarthritis. In other hand, total hip replacement goal is to achieve restoration of the hip biomechanics. Restore acetabular offset, we have restore femoral offset. In order to achieve stable joint, hemispherical shape is very important factor for acetabular component to get press fit stability. The press fit stability means that it's stable in the rim and also in the domes. This case, 16-month neglected non-union of the left anterior column posterior hemitransverse fractures with the leg length discrepancy 4 cm. So in this case, we do the simultaneously open reduction and total hip arthroplasty. Open reduction and total arthroplasty. The first thing to do, we do the neck cuts, and then with the posterior column plating, and follow with the femoral head autograft, and we do the reverse rimming, and follow with the cementless total hip arthroplasty. Unfortunately, this patient complicated with the temporary peroneal nerve palsy or partial drop foots. However, the patient recovered completely after 3-month follow-ups. This case of the elderly acetabular fractures, ABC types. In this case, we do with the posterior column plating, iliac wing fracture plating, and also with a massive bone graft to fill the fact in the dome, and also to reconstruct the anterior columns, and follow with the cementless total hip arthroplasty. Early fracture fixation is very important in geriatric to get lesser mortality and fewer complications due to advantages of the early mobilization. However, we cannot do open reduction intervention in complex fracture pattern with the dome comminution femoral head injury. This is an example of the simple acetabular fractures, but it has concomitant femoral head fractures. So we have to perform total hip arthroplasty. This is a sample of the complex acetabular fracture that was treated with the internal fixation and total hip arthroplasty. The key management in this case is to achieve a stable joint using the A-stability construct concept. An A construct which we have to achieve stability in all three planes: anterior plate, posterior plate, horizontal trabecular metal, cell as the internal plate. In general, press-fit cementless constructs are preferred. It is seen a third plate screw were always placed. The cell was implanted where it would get maximum bony contacts between the two columns and the acetabular dome. Fracture should be fixated whenever possible to achieve good bone contacts, and anatomical reduction was not necessary. If the fracture pattern is severely comminuted, we have to use the femoral head autograft to reconstruct the acetabulum. This is another case, acetabular fracture in elderly, 81 years old, transverse and postural wall fracture. So in this case, we have to do neck cut and then doing the postural column plating and follow with the femoral head autograft, doing the reverse rimming, and then we do the cementless total hip arthroplasty. So this 40-month follow-up, the patient could do the household daily activity, daily living. Total hip arthroplasty show lower mortality rate and lower revision rate than an open reduction and internal fixation in acetabular fracture cases. Total hip arthroplasty for acetabular fractures in general show 87% implant survivorships. Cementless cup show better survivorship compared to the cemented cup. On the other hand, there is no significant difference between cementless and cemented femoral stem. In summary, early total hip arthroplasty is indicated for neglected complex associated type fractures, pre-existing systematic arthritis, elderly with the severe comminution, complex fracture with the dome comminution, concomitant femoral head and neck femoral fractures, and severe osteoporosis. Outcome for the total hip arthroplasty in acetabular fractures, good functional outcome and survivorship, but lower than primary total hip arthroplasty, especially in young active patients. Thank you for the attention.
Good morning. I would like to present cementless femoral stem in elderly hip fracture. Most report and meta-analysis, they prefer cemented stem in femoral neck fracture in elderly patients. The one most concerned, the reoperation in cementless cases because of the fracture. But after we consider overall result, it's not different in the long term. The two major concerns of the cementless stem in elderly patients, first is the dorsal. Mostly the dorsal associated with subsidence in cementless stem, and the other one is fracture. We would like to share our experience with HA-coated collarless stem. We have experienced more than 1,000 cases, and half of the cases is hip fracture in the elderly patient. We have reoperation 4 cases, PJI 2 cases, osteolysis 1 case, and subsidence 1 case. We also have 2 cases of fracture. Stem subsidence, one of the most concerned complications of cementless stem. Proximal femoral morphology with dorsal is not recommended for cementless stem fixation because it might be a predisposing factor to stem subsidence. When stem subsidence, they create limb length discrepancy and lack of joint stability. Majority of stem subsidence will occur within 2 months after surgery. If the subsidence is more than 3 mm, it would be clinically significant. We have one study we like to know the factor related to stem subsidence, age, sex, door type of the proximal femur or canal field ratio that have associated with stem subsidence or not. First, we calibration of magnification error with known femoral head size. And then we measure limb length. And then we measure stem subsidence. Finally, we record canal field ratio. We start at the lesser to canter area, 2 cm above, 2 cm below, and at the tip of the stem. We study subsidence of the cementless femoral stem in all door type. We want to find out factor that related to subsidence at 2-year follow-up. What about age, gender, door type, and canal field ratio? We published our study in Journal of Orthopaedic in 2019. We used multivariate regression analysis for our study. We found that door type, age, gender, and cow-car crack had not significant on stem subsidence. And if we create more canal field ratio at the subtrochanteric area, has significantly less subsidence. Door C have more subsidence than A and B. But we also found subsidence in all door type of the proximal femur. In conclusion of our study, the proximal femoral morphology or door type had less significantly associated with subsidence of the HA-coated taper stem. Stem have subsidence in all type of door. 3 mm subsidence can occur in all type of the door type. It's not related to age, sex, and canal field ratio. But the door C have more cases. Most common of the subsidence occur in the first 3 months, but stable position can be achieved with good clinical result because of the most of the case is a minimally subsidence less than 3 mm. If we have the subgroup analysis only the elderly patient, we found that the door C of the proximal femur in elderly hip fracture is less than half of the patient. More than half of the patient have the door A and B that is suitable for the cementless stem. Most of the cases have the minimal subsidence less than 3 mm in all group of the patient. If we can feel canal ratio nearly 90% of the patient, all the patients don't have any clinical problems. Small cow-car crack did not associate with subsidence. We have 2 cases of the fracture. From our study with the HA-coated femoral stem with collarless, most of the cases can achieve canal field ratio more than 80%. 1/5 or 1/5 of the stem will subsidence in all door type, but less than 3 mm and don't have any clinical significance. Small cow-car crack can occur and can manage with widening. Fracture is still the problem of the cementless fixation, and the reason of the revision they are different from registry to registry. They have 17% in the UK registry, just 9% in Australia registry, but our experience is less than 1% from our study. This is an example of the case of the fracture we cannot detect during we perform direct anterior approach. The patient developed fracture 4 weeks after surgery, and the patient refused to do the re-surgery. We observed the patient. And finally, it's healed in stable position, but they create 1.5 centimeter shortening of the leg. In conclusion, cementless stem in elderly femoral hip fracture. First, the door C is not majority of the patient. The majority of the proximal femur is door A and B in hip fracture in elderly. If we have the good placement of the fixation, it means more than 80% of the canal field ratio. The patient will have the good clinical results. Cow-car crack can be reduced by improved surgical technique. And if it occurs in perioperative, we can wire it. So in conclusion, in our experience, cementless stem can be used in elderly femoral hip fracture. Thank you for your attention. And I hope this meeting will be the most successful of the virtual meeting this year.
Thanks very much to all our speakers. Dr. Zhang, are you there on the podium?
Yes.
Yeah. From your talk, were you not using this routinely for your posterior repair? You were just selecting what you consider your very high-risk cases?
Sorry?
For your posterior capsule reconstruction, were you planning to use this routinely or just in the very high-risk cases?
Not usually. Usually. I just for the patient with high risk of dislocation rate, just like femoral neck fracture in elderly patient, and some other neuromuscular disease, just like polio and Parkinson disease, just like that.
Thank you. Andrew, I'm very familiar with the preoperative planning, the OPS with the CT and lateral x-rays. If you don't have access to CT, what sort of information can you get by just getting some lateral x-rays, standing, getting out of a chair, which might alert you to increased risk of spinopelvic problems for hip replacement?
Thanks, Jim. Look, the whole story really started, the spinopelvic story started with the observation that people with spine fusions had a higher incidence of dislocation after total hip replacement. So first thing is, history of a spine fusion is a good hint. Secondly, yeah, sure, there are some hints that you can get on a standing lateral view. And, you don't need necessarily need the CT scan to find who's at risk of this. But I think with the CT scan and the flex-seated view, you get a more detailed assessment. So my view is, there's no such thing as being half pregnant. You do it properly or you don't. So, but for those who are happy to be half pregnant, sure, you could look at the standing lateral and a flex-seated lateral and do the measurements yourself if you wish. If your lumbar flexion is, or your lumbar flexion, say, less than 20 degrees, then you've got a stiff spine and you need to be treated accordingly.
Thank you. Dr. Chotana Putti, from your talk, could we conclude that you would use a cementless collarless stem in all cases of fractured neck of femur? With that what you were saying?
Yes. We usually perform the anterolateral approach with or HA taper stem collarless for all femoral hip fracture. Yes.
Are you aware of some of the emerging literature that the periprosthetic fracture risk and subsidence risk is lower with collars? You haven't considered comparing that as well or looking at that?
Yeah, for our start to use the stem, we have set up for the cemented stem for that, and then after the couple of years, we did not do any backup for the cemented stem.
Okay. Have you got any comments to make?
I think it was overall a very nice session. Dual mobility has been increasingly used. Obviously, the French have been using it for over 2 decades now, but the British and the Australian and the other registries and the countries have shown that the numbers have been increasing in the last 5 years. Here in Pakistan as well, we have really looked into it, and we are using it in increasing numbers, especially patients who have got complex problems, patients with ankylosing spondylitis, and patients who have got previously neglected or untreated complex hip problems who come to us. So I have been using here in Pakistan as well. And I think the talk by Dushaman about the pelvic spinopelvic problems is really very, very pertinent. And I'm sure we're going to hear more about it in the next sessions as well.
Let me ask Andrew, you have any study about dual mobility for the hip fracture patient? Do you think it's have a benefit?
No, look, I'm sure. My presentation there was about, when, what's the indication 2021. I think, the avascular necrosis, the hip fracture patient, the neurological patient, the abductor deficient, they're kind of the known high-risk people. And I think the dual mobility is really, you've got to think dual mobility in those situations. And so there, I think we've got to take lead from the French that in those identifiable groups, we really need to think about using the dual mobility. My talk on the last half of my talk on the spinopelvic assessment, I think that's more the kind of modern thought process on it. And I'd like to create some discussion in this group, actually, that, what do you think where do you think we'll settle in terms, percentage of people, that'll have a dual mobility, even for arthritis, for fracture, or for avascular necrosis. I'll start the bidding by saying I think we're going to settle about 15 to 20%, and I know we're going to have talks on this and debates on this, but I'd love to chuck that around. The four on the panel here. What do you think is the number that we're going to set on, a percentage that we'll settle on as a satisfactory usage of dual mobility?
Well, I can kick that off, Andrew. I mean, I would tend to use dual mobility in a lot of my fracture cases, fractured neck of femur, just as a precautionary, particularly in the elderly. I'm a little bit more nervous in a younger patient about it, but I think the worry about the wear patterns is probably starting to be resolved, I think. For my routine cases, I do the preoperative optimized positioning system. And if the patient's got a very long sweep in the arc, so they're at risk anteriorly, at risk posteriorly, in those cases, I'll also use it.
Sure. So I'd say question, I think that's for you.
About 10%, maybe a bit less.
Yeah, okay. But let's get the original question about the fracture. I think dual mobility. We talked about unipolars, bipolars, total hip replacements for fracture. I think a total hip replacement with a dual mobility articulation is an excellent treatment option for a fractured neck of femur.
Yeah, I agree.
And then
have you got any comments?
And do you have any comment about exposure? When we do the hip fracture, different of the surgeon, they do some anterior, some posterior. So do you have any comment between dual mobility for more prefer to the posterior approach or less prefer for the anterior approach for that? Do you have any idea for that?
No, look, I don't. I try to. If the question was to myself, I separate those. Anterior approach has its pros and cons. Posterior approach has its pros and cons. Instability occurs anteriorly and posteriorly. I think, and if you're at risk of an instability, you've got a patient who's at high risk of instability, either anteriorly or posteriorly. Dual mobility is a good option. They're separate questions to me, if you like, separate answers as well.
Yeah, in Pakistan, we really do not see a lot of primary OA of the hip. What we are seeing most of the time is secondary osteoarthritis. As I said earlier, we see a lot of some ankylosing spondylitis, but we also see a lot of AVN in the very young population. And these are the real challenge for us. When the metal-on-metal resurfacing was in vogue, we did quite a lot of metal-on-metal resurfacing in that patient age group in the very early 20s and early 30s. But now I think probably be going on to the dual mobility rather than because these are high demand individuals, and the revision. Interestingly, I was just going through the registries, and the revision rate for the dual mobility is slightly inferior to the conventional cemented or uncemented total hip replacement. I don't know why, though the dislocation rate definitely is lower. Any comment on that?
No, look, I think, the registry data has pros and cons, and I think they're being used in different patient populations. I think we've got to be very careful about, how we go interpreting registry data on dual mobility at the moment. I think really importantly, I think we need to be aware of the fact that we're using a lot of modular dual mobilities, a lot of the long-term histories on the monoblock, and maybe we finish there. Thanks, guys.
Thank you very much.
Just on your vision there, there's a fair bit of flaring from the light on the wound.
Yeah, what we'll do, we'll swap to the in-light camera once we're ready to go for surgeries. Is that better?
Yeah, that's better. That's better, yeah.
I think Tom's not been able to get the picture or sound from into the auditorium yet.
No, it's just us, I think.
Yeah.
You happy to wait a little bit?
Yeah, I guess so. I've only been talking for about 5 minutes and then you told me no one's heard a thing.
If you want us to break the feed at any point, you've got communication with Tom, which is separate to us. So you can just indicate to him that he can feed back to us.
Okay, no worries. Thank you. Hopefully that won't be needed. An hour.
Indeed.
Yeah. Hi, Ismail. How are you?
Hi, I'm good.
Thank you for moderating.
Yes, thank you. So this you will like to do it in bitraction and supine, right?
Yeah, supine with the Hannah table.
Okay.
So yeah, and with X-ray.
Okay. Okay. And how much traction will you perform? I mean,
hopefully not too much. So
yeah,
I guess I was taught it's not so much a traction table, but a positioning table. So we do have a little bit of traction on the table on the leg while we do the acetabulum, but hopefully we don't require too much to open that space up for us.
So you will check it out with the C-arm, II, under II, and how much traction that adequate for you for exposing?
Yeah. Normally what happens is we'll give it 2 or 3 turns, and then as long as I see the space into the acetabulum, then that's normally enough.
That's the eyeballing, yeah? You don't have to measure how much distance in the joint.
On the traction?
Yes, on the traction. No. And yeah.
It's more me being able to see into the acetabulum, pulling the femur out of the way slightly.
But you always doing routinely with the traction, with the table traction. Yeah. Do you also do it without traction? Without table traction?
No, I always do it on table. On table. Yeah.
Yeah. And is there any contraindication? Like, for instance, I will do this with a direct enter approach. In other case, I would like don't do. Yeah, I don't do with the direct enter approach.
Yeah. So look, I have to confess, I'm new to the direct anterior approach, so I'm quite conservative with who I do them in. I certainly, like, I have a DDH next week. I'll do a posterior approach. So difficult patient, I might still do posterior or anterolateral. Certainly if I have to get to the posterior wall or do bone grafting to the acetabulum, I'm more comfortable doing it through one of the more traditional approaches.
Okay. And for the neck fracture, femoral neck fracture?
No, I have femoral neck fracture. I don't do many now anyway, but I do it through an anterolateral approach.
Okay. So you have the special. Yeah. I think later you can give us the tricks. What is the patient selection that could be performed with the direct enter approach?
So what I would say, so again, as I say, I'm still very much in my infancy. I would say pick patients, particularly female patients, because male patients that are muscular are harder. I don't do anyone with protrusio. If they've got a very horizontal iliac wing, I'll be very careful. Very high offset also, or varus neck, I'm a bit more cautious. Apart from that, though, I think it's achievable in pretty much every other patient. And then, of course, if they're post-traumatic, I'll tend not to. If they've got plates and screws, previous approach, I'll go through the previous approach. And if they need bone grafting or something more complex to the acetabulum, I'm still more comfortable doing it through an open approach.
Okay. So far
there's also those cases with the large fatty apron, which where the apron's going to sit on the wound area. That's ones to probably avoid as well.
Yeah. But thus far, I've tended to avoid them in big muscular males. Anyone has protrusio, things like that.
Yeah, I have a question about the cup position before your operation. As we know, the direct anterior approach is just to perform the operation on supine position. A posterior approach just do it by with the decubators position. So for the cup position, what different from between this different position?
I don't think the cup position is different. I think it's the same, whatever approach you do. So, I don't think your cup position should be different whether you do an anterior or posterior approach. It should be pretty similar. I wonder whether we should wait till we get into the audience to discuss cup positioning. Are you happy with that?
But some papers just show when the position changed, maybe the pelvic is changed. So maybe this changing of pelvis maybe affect the position of the cup.
Yeah, sure. I understand you're talking about spinopelvic mobility, but what I reference in those slides, you'll see we reference our acetabular positioning off the anterior pelvic plane, and I reference that back to the patient's native anatomy. So this patient's native anatomy is 30 degrees of anteversion, 53 degrees of inclination. So what I'll be aiming for actually is I'm actually going to try and match this 30 degrees of anteversion for two reasons. One, actually, if you can see on the lateral spinopelvic x-rays, she's got normal spine alignment, but she's stiff. Her sacral slope doesn't change very much between standing and sitting. So her cup doesn't functionally antevert as she goes into a seated position. So I'm going to antevert a little bit more than normal. Secondly, I don't like the anterior cup being uncovered anteriorly because of the risk of psoas irritation. So I like to sit my rim just inside that bony rim. So I've got two reasons to just antevert the cup a little bit. I know her native anteversion to the anterior pelvic plane is 30 degrees. So that's what I'm going to aim for. I won't see 30 degrees here because I have no way to measure it. But if I feel the anterior bone, I'll be getting an x-ray to have a look as well. That's what I'm aiming for.
Okay.
Jim, do you know, are we in the room yet? No.
I think so. Just waiting for Tom to come back.
Yeah, okay.
That preoperative plan you had on those slides, I'm trying to get it up. What does that reference? It gives you predictive cup positioning and femoral sizing, leg length offset?
Yes. And so it is actually, it's less sophisticated than the current thing in that it's still not looking at spinopelvic motion yet. But what it does is, the reason I started using that is that I think femoral version and position has a huge bearing on your impingement-free range of motion. And so with a double tapered wedge stem, I'm not sure that you can alter the femoral position very much once you've got your neck cut and entry hole into the canal. So what this algorithm does is actually plan the femur first.
I think we're live now.
Okay.
We're live, so.
All right. Sorry, everyone. Welcome. So, Jim, I might start the surgery since we've lost already 10 minutes, if you're happy.
Yeah, no, that's a good idea. Yep. Tom, is that other screen up? Okay, I can advance the slide. So this is an 87-year-old married female, lives in, you can read all that, the community ambulator, 7-year history of left hip pain.
Sorry, Jim, are you right for me to start the surgery? If
Please.
you put up both screens, I'll start.
Okay.
You right? Can they see?
Both screens are up. So it's had the other side done. Leg length discrepancy of 6 millimeters, positive Trendelenburg, preoperative range of motion. There are the films. That's the standing and seated x-rays to try and get some prediction of how much sacral or pelvic tilt there is in those two positions. And that's the plan that David uses, predicting of cup orientation, femoral size, leg length and offset. So he's going to aim for a cup anteversion of 30 degrees, inclination of 40 degrees, and predictive stem anteversion of 20 degrees.
Gelpy, thanks.
So, David, just sliding over the front of tensor fascia lata.
Yeah, so my skin incision was a couple of fingers breadth lateral and inferior to the anterior superior iliac spine. I was trying to say a little bit more lateral just so that I have less chance of damaging the lateral femoral cutaneous nerve. I've just incised the fascia over the tensor fascia lata, and now I'm developing the plane between the rectus and the gluteus. So we've got to find the ascending branch which is just coming up now. So the ascending branch of the lateral circumflex artery just here. I don't know if, can you see that? I'm just going to replace my retractor here under the rectus. So normally you obviously have to get this artery here, the ascending branch. It's quite a big branch, will bleed a lot. So normally if you start a bit more inferior and work superior, I've got the artery just here. So I diathermy it rather than ligate it.
Generally, if the artery is roughly at the junction of the proximal 2/3 and bottom 1/3 of the wound, you know you're in the incision's in roughly the right spot.
Yeah, correct. So, and if you start inferior, you can normally come up onto it. The junction about 1/3 to 2/3. So now you can see here's my lateralis, the gluteal will be back here, rectus there, and there's some fat here over the anterior capsule, which we're just going to take off. Can you guys see?
Yeah, the vision's quite good.
Dr. David?
This is the fat pad on top of the anterior capsule.
Do you preserve the anterior capsule during operation?
Sorry, say that again. I couldn't hear the question.
Yeah, do you preserve?
No, I don't. I don't remove it, no. I'll show you. I do a capsulotomy.
So you preserve and...
I preserve, yeah.
Yeah, preserve.
Okay.
So here you can see the anterior capsule now. Here. Here I can feel my ASIS is up here. Sorry. ASIS is up here. Here's my anterior capsule. Here's the medial neck. And here's the superior lateral neck. So now here's my vastus lateralis is just down here. All right. So I'm going to incise the capsule in line with the neck. And then inframedially.
With the L-shape. The incision is L-shape for the capsulotomy.
And then inverted T.
Inverted
along
T.
the intertrochanteric line.
Okay.
Then once I've done the superior capsule here, goes inside.
We're just getting a bit of it's getting a bit of head obstruction.
Sorry. So once I've done that super, I put the retractor inside there, and I'm just onto the saddle there. That should be enough. Okay. And then this retractor goes actually into the head. And then what I'm going to do now is release this.
So when you say into the head, it's not over the pelvic brim. It's just into the femoral head.
No, it's into the head. So it's lifting my capsule here, the inframedial capsule. So we're going to externally rotate the leg now. Thank you, 40 degrees. And here, it's a bit hard to see. So I'm releasing my inframedial capsule all the way down to my iliopsoas. And I can see now my iliopsoas there.
You release the iliopsoas a little bit.
What's that?
For the iliopsoas. Do you do the some release?
Do I do the
some release for the iliopsoas?
I couldn't hear. Actually, I can't hear the question.
David, he's asking whether you release iliopsoas.
No. So there's the iliopsoas.
It's just the
yeah, that's the end of my release once I get to iliopsoas. That's capsule still though. Okay, good. All right. And then I do have to take this superior capsule slightly off this superior acetabulum. All right. So this posterior superior capsule, I'm just taking it off this acetabulum, this superior capsule. Okay. We've probably got enough there, don't we? All right.
No.
So that's my capsulotomy and initial releases. All right. Once we've done that, then we actually come in now with our X-ray. So back to neutral, please, with the 0 neutral rotation on the leg, please. No traction on the leg. This is how we do our leg length and offset. So we actually use an overlay technique with the transparency in the eyes. So we'll take a picture there. And again, back towards you a little bit. And just again, thanks. Okay, save that one for me. Certainly using the X-ray was one of the learning parts of the operation for me, but now that I've started to get used to it, it really is one of the nice parts of the anterior approaches to use X-ray for your positioning and leg length and everything. So now Meredith is actually going to draw a transparency of the neck, and we've used that osteotome as a radiological marker. Okay, yeah. So we've kept the capsule here because it really allows us to put the Gelpi in there, and it really acts as a retractor. So if you excise the capsule, you've got nothing to put the Gelpi on. So that's why we leave the capsule there. So now I can see my femoral neck. And you can see here, I don't know, Nigel, can you show them, switch to the, that's it. So here you can see Meredith is drawing an outline of the native hip, no traction, neutral rotation. She's got the osteotome there as a radiological marker. And we're going to use this transparency to measure or gauge our offset and leg length after the hip goes in compared to what we were prior to that. All right. So she's actually got a transparency on top of the image. There you go. So it's a clear transparency, and that's going to be for referencing later. So there, I reference my neck cut off the saddle here. Here's my saddle. Thank you. And I know off the planning that we had that my neck cut, have you got the ruler there? Is 9 mil from the saddle, which is the saddle is this curvature near the piriform fossa. I use that point because one, it's accessible. Two, it's not affected by rotation of the hip. And so it's an easy landmark, I think, to get your thing. And then what I do is I mark where I would be 45-degree cut that would come out the fossa, and I know that I've got to be 9 mils below that. So I actually don't do a step cut. I just angle my cut slightly differently, or make it a more of an acute angle on the cut to allow me. So I'm not making a step cut, basically. Okay. Okay, Saul, thanks. Okay, Saul. So we're back to neutral rotation. Thank you. Just suck in the medial side there. So now we're going to do our neck cut. Okay, traction. So 3 turns of traction for us. Okay. Thank you. So we put a bit of traction and external rotation on our leg there. And you can see here's my cut neck with the head. Here's my distal part of the femur. And so it just gives us a bit of a window or room to put our corkscrew in. Oh. Oh, I've got a cut on my glove. I just need a new glove, Lynn. Thank you. And the T-handle. Oh, you got it out. Thank you. So there's the femoral head. It's quite small. Okay. So now reposition my Gelpi again, just inside the capsule.
What's your tricks to why you easy to take out the femoral head?
Say that again.
Tricks. Yeah, the tricks to you. I see your whenever you take out the femoral head out. Yeah.
Yeah. So I put the T handle on, and then I rotate it superior so that you can get your diathermy in to release that inferior capsule, posterior inferior capsule, and then you can lever it out.
That maneuver, yeah, the trick, yeah, the trick easily remove or take out the femoral head.
Sorry, say that again.
Yeah, that's
so
your
I
trick.
put the corkscrew in. It has a big lever arm on it. So then I lever the head superior, and that exposes that postero inferior capsule, which you can release with the diathermy. I think we've lost our transmission. We'll keep.
No, we can still see you.
You can still see me. I can only see a cat.
Screen's frozen. No, that's okay.
We're back.
Yeah, we can see perfectly. It's good.
What are you releasing now, David?
So here I'm just excising a little triangle of inferior capsule, and then now I'm taking out the labrum. So Dr. Lennox has got that curved retractor between labrum and capsule. Here I'm taking out the anterior labrum and superior, and I'll work my way around, take all that labrum out. Okay, and then here's my little fat pad in the fovea, which we'll take out as well. It's quite a sclerotic acetabulum, isn't it? All right, so that's the
David,
fat in the fovea. And then I'm going to get this posterior labrum as well. I'll hold this while you adjust it. I'll hold this if you want to adjust it with two hands. Oh. Can you see that?
Yeah. A little bit dark.
All right, so that's it. Except I won't be able to operate like that.
Yeah, that's the very important thing to take out all of the soft tissue surrounding the fovea centralis to have get a good rimming. Yeah.
Yeah. Can you just suck the smoke for me, Haig? Thank you. Yeah. So I don't know, Jim. You obviously did when I was your fellow. You did a lot of posterior approaches. You changed the anterior approach, obviously since then. Do you think you've changed your cup position since you changed approach? Or is it basically the same? So. It's the same,
pretty
isn't
much
it?
the same. Yeah. I mean, I think what you said earlier, I mean, I look at the towel.
Yeah.
I also make sure that the cup's covered anterior. That's probably something I'm a bit more obsessed with going through the front because of that iliopsoas irritation.
Yeah. All right. So now it's hard for you to see, but I can actually see pretty much the whole acetabulum and I can feel the front there. I can feel my bony rim anteriorly. And so I'm going to sit my cup just under that little rim. All right. So we're ready to ream. So I've taken the labrum out, a little bit of inferior capsule, just cut a little triangle out. The rest of the capsule's there. So now I do use an offset reamer. I don't know. Nigel, do you want to change the camera again for us? Yeah, so it is an offset reamer. Just allows you to get it in a little bit easier. And you can see I don't put any retractors in there apart from the Gelpie. It's a bit of a double-edged sword. If you have the retractors in there, you might get a better view, but it also tends to not give you as much maneuverability of your reamer handle as you're reaming, all right? So I put my reamer in. Again, so you can feel the bone there. If I antivert the cup a long way, I can feel the bone and I can see where it is such that I come to the rim, which is about there. All right.
What size of the cup do you use for the first reamer?
Say that again.
Yeah, what size of the cup?
This is 47. This is 47, and I planned for a 50 cup. So I under ream by 1. Okay, next reamer. And I've gone straight to 47 because I know I don't have to medialize too much. I don't have to, pretty much I'm putting the cup where it is. So now this is a 49 reamer. So again, here if I antivert it a long way, I can feel the bony rim. So I bring it down so that it's fairly level with it. I can see the posterior wall. Okay. Just got a bit at the back there. So I can see I've just got a little bit of sclerotic bone at the back there. So I'm just going to ream a little bit at the back there. Okay. So now I do trial, especially since I've been doing anterior, I haven't quite been as confident. So this is a 49 trial, true 49 for a true 50 cup. So I've under reamed by 1, which is fairly standard bone. Thank you. Okay, so we are going to come in with our II now. So it's a part of the operation I had to get used to, but now that I'm starting to get used to it, it is actually a nice part of the operation is to be able to check. So if we could change the camera again, to the II for us? Could you change it to there for us, Nigel? And zoom in a bit, maybe. Can you zoom in? All right, so I can see that my cup has certainly bottomed out. I'm probably about 45, I guess, is what I'm aiming for. And it certainly does look a bit more anteverted than what I normally would. What do you reckon? Yeah. And I can feel the bone there and the edge of the cup, and I'm right on it. So that's what I'm aiming for. I don't want the cup uncovered. So I'm probably, as I say, I don't know how many degrees it is, but if my planning is correct, it's probably about 30 degrees of anteversion. All right.
How many degrees for the anteversion?
50 cup. So that's a 49 trial, and I'm going to put a 50 cup in. Yep. I'll take the local now, things.
The anteversion setup, how many? How many degrees for anteversion?
Sorry, I couldn't. What was the question?
The anteversion setup for the acetabular component. How many degrees?
How much did I under-ream?
No, how many degree? How many degree for the anteversion?
Well, I think it's probably 30 degrees.
30?
30.
Oh.
I'm happy to be criticized. What would you put it in?
Yeah, I mean, because anterior, this one anterior, right? So we afraid of the dislocate to the anterior. So why you put it on the 30 degree? Usually that 30 degree for posterior approach, right?
Yeah. So as I said, my two things why I've gone 30 degrees here or just under the anterior rim is that one, I don't want any exposed cup anteriorly to cause psoas irritation. Two, when I look at her spinopelvic x-rays, she appears to have a stiff spine. So when she goes into the seated position from the standing position, her pelvis doesn't tilt posteriorly very much. So she appears to impinge anteriorly a little bit in the seated position. And so I've made the cup a little bit more anteverted than perhaps usual to try and prevent this anterior impingement in the seated position. So I'm trying to accommodate for her abnormal spinopelvic mobility or spinopelvic mechanics.
Okay.
Or Jim, do you want to bring up the x-rays of the spine on the PowerPoint? So this is just local anesthetic with saline, and I do put 3 grams of tranexamic acid in it as well. And I'm trying to infiltrate all around the acetabulum, posterior capsule. Is that it, Lynn? Okay, can you give it a wash for me, Haig? One of the things that I really had to get used to when I changed to the anterior approach was putting my fingers inside the wound and bone a little bit more than I'm used to. I think because it is more minimally invasive, you do have to use other sensors to check your positioning. So I certainly would use my fingers a little bit more to feel around the bone, etc., than I normally would. And of course, as I say, you've got the X-ray as well. So this is a, hang on. Yeah, so this is it's a hemispherical cup. The true size is 50, even with the porous coating. It's a multi-bearing cup, so it actually can take poly, ceramic, as well as dual mobility all in the one cup. All right. and it's 50. So we reamed a 49, trialed with a 49, and now we're putting in a 50.
Could you say me again the starting reaming reaming size?
Ream to 49.
Yeah.
Trialed with a 49 and put in a 50. I just need the.
So directly 49. I mean, what size do you start for reaming? I mean,
what did I start
46? With? Yeah, you start with what size of reaming?
49 ream. I started with a 47.
47.
Let's see what.
So
do you usually use? Yeah.
Sorry.
Do you usually use 1 millimeter bigger cup than the final trial?
Normally I use patients? 1 if the bone is fairly normal, I'll use 1. That's down. It's not stable.
Okay.
Okay, it's not quite stable, so I'm actually going to ream a little bit deeper with my 49.
Okay.
It's a 49. Thank you. Yeah. Just give it a wash for me. So I've just reamed a bit deep. I did still have a couple of millimeters off the floor there. So happy to go a little bit deeper. It wasn't quite stable. Just the screwdriver, thanks. No, still not stable. Just that. It's not quite down. Yep, show us that. All right, so yeah, I can feel my bone there, and it looks out 45 on the X-ray, and it's stable now. Okay. Yep. Yep. Thank you. So it wasn't stable initially, but I still had a few mils of that medial bone that I could sit it down on. I can see through the central hole that I'm central. And as I say, I can just see the bone just sitting against the lip of the anterior cup. All right, so I'm happy with that.
David, do you look at the orientation as opposed to the TAL?
Sorry, say that again.
Do you look at the orientation of the inferior cup with the TAL?
Yeah, well, yeah, kind of. It's perfect, Jim. Right against the TAL.
Lovely to hear.
In line, yeah? Parallel.
In line with the TAL. Yeah, it's in line with the TAL. It's sitting just down the anterior rim of my bone. And I'm using a 36, partly because of her slightly abnormal spinopelvic mobility. I want slightly bigger head. She's 87, so I'm not worried about poly wear. and this is vitamin E poly. If she was younger, I probably would still go 32, but given she's 87, I guess I'm making the compromise between stability and impingement versus wear. Mallet, thanks. Is it down? Yep. So we're fully seated. Okay. So now we do remove a little bit of the traction. This is the scary part of the operation. This is the elevator hook for the femur. It sits behind the femur.
You're afraid of the periprosthetic fracture?
What's that?
The periprosthetic fracture. Avoid. You have to avoid that one.
Yeah, sure. I'll swap sides with you, Haig, if that's all right. So you do have to be careful. You can see, if you just go to the other camera again, Nigel. So, sorry. So I'm always testing how loose or hard that, maybe if Haig does it with his hands, I'll get out of the way. If you just test. So we're always testing how loose that hook is as I elevate. You don't want to put too much traction on the femur, and that's when you will break things. Yeah. So we externally rotate the leg. Again, we're always feeling. So this is still quite loose. I can move it. So we can still elevate it even more. Thank you. Then we put a double prong over the medial calcar, and then a single prong retractor goes over the posterolateral aspect of the trochanter. I've got it here.
Do you do the postural capsule release?
Yeah, so that's what I'm about to do now. So I've got quite a thick capsule here. So here is the posterior capsule, right? I've actually got quite a lot of redundant capsule here. So I'm going to excise some of that. And then the capsule we need to get is this. I'll just excise a little bit here. What we need to be able to do is deliver this femur with the trochanter. We've got to get the trochanter in front of our acetabular or cup. Oh. All right. We need to get the trochanter in front of our acetabular cup before we bring our leg into adduction extension. So here you can see this posterior superior capsule is what I'm going to release. So I start just near that piriform fossa trochanter, aiming up towards the acetabulum. It's quite a thick capsule, isn't it? Was it capsule? Yeah. So I'm just going to replace this retractor. So this is going up in behind the trochanter, trying to elevate that trochanter up. I then will manually pull on the hook myself, and I can actually feel that my trochanter is actually in front of my cup already. So we've probably done enough release, but I will just release just a touch more off this posterior part of the trochanter here. So that our rotators are down further inferior, and I'm just releasing this capsule off that posterior superior trochanter, just laying it a bit bare so that we know it will sublux in front of the acetabulum. So now I can feel that trochanter is in front of my cup, and now we release the traction. Okay, we release the traction, release the elevation of the hook, and now we slowly, under vision, bring the leg down. So we've extended, we've adducted, and externally rotated. Okay, and now you can still see I still got some play here in the femur, but my trochanter is in front of my cup, so I'm not going to risk fracturing the trochanter. I can actually elevate that femur a little bit more, but I've probably got enough now. Can you see that? I've got enough now. Here is my cut femoral neck. Here is my trochanter back here. And so I think I've got enough access now. And here, yeah, you can see the rotator, external rotators.
Okay. Do you usually release the piriformis? Some certain side, if you don't release the piriformis, maybe the femur is very difficult to explore.
Sorry, say that again.
Yeah, do you usually release the piriformis?
No, I don't. Now, having said that, I've never really done a very tight hip. I understand the piriformis can be a secondary release if you really can't deliver the femur, but I personally haven't had to do it. I don't know, has Dr. Lennox ever done a piriformis release? No. Yeah, not purposely. So here you can see it here. Here's our piriformis here. Gemelli. Yeah, it's off the back there, but you can see our rotators there.
The white appearance.
Yeah, all right.
Yeah, but sometimes it's very difficult to expose if the piriformis leaves.
Yeah. Look, I have read, Dr. Kamath is a friend of mine, and he certainly talks about the piriformis being a secondary release if you need to deliver the femur.
Yeah.
But I haven't had to do it myself.
Okay.
Because your patient selection, it's your choice, the patient selection.
The stem, did you say? Nigel, can that speaker be turned up a bit? Did you say what stem am I using? It's a taper lock. So we planned for a 9. I opened up with the smallest one, which is the 4, and I've gone straight to the 7.
So, David, when you're doing a posterior approach, you usually bias the broach posterolaterally. What do you just go straight down the middle, or are you mindful to put it not in varus, not in valgus?
Yeah, so what I do, so you can see on that formus planning, it actually gives me a cross-section of where through the neck cut, and it gives me where the stem should be, what it should look like basically on the cut neck. So I'm trying to reproduce that. It is a bit more posterior, and I do work laterally. So I should have shown you I do get the nibbler and nibble out that hard bone posterolaterally, and then I am working the broach lateral and posterior, but still trying to follow the natural canal. So I am working the broach lateral. Yeah, I am working the broach lateral and posterior. But as you know, what's nice about being able to get an X-ray is that if it's no good, I'll know before I close up. Does that make sense?
Yep. It does.
That's about right, isn't it? So that's a 9.
What's you up to now? It's a 9.
That's a 9, which is what we planned for. And that feels pretty stable, not rotating. And what I'm trying, I don't know if you've got the Formus plan up there, but what I'm trying to reproduce is the picture that they've given me on the neck cut. All right. So now we're going to trial high offset. I did plan a 0, but I'm going to trial with a -3 because I like the reduction to be nice and soft. And I know I can adjust it after. So we put the head on. Okay, we'll tract her out. We'll take our hook out. Okay, leg back up. So I put my fingers in here. Obviously, my capsule is not tagged, so I do have to hold the capsule out of the way with my fingers. One hand on the head, and then the other hand maneuvers the foot. Wow, we're long. Feels too long. Yeah. No. So we are too tight. No, it's too tight. So it's too tight, so we're not going to reduce it. I obviously have, my neck cut must be a little bit high. It is probably a touch high. Yeah. So let's go, that's a -3, is that right? Let's try a -6 head. Yeah. Will it externally rotate a little bit? Yep, that's good. I don't think I can get it off. Have you got a Bristow, thanks? Mallet? I don't think I can get it off. Huh? Okay. Yeah. Yeah. Okay. Yeah. Come back up.
So you don't need pusher.
Say that again.
You need pusher.
No, I think if you need a push, it's too tight. I wouldn't reduce it.
You push by your finger, eh?
Yeah. Wow, that's still tight. Yeah, no, it's capsule's in the way. Just externally rotate for me. So my capsule's in the way. Yeah.
Is the leg back in the parallel position, back parallel to the other leg?
Okay, just give me, I just need a cocker. I've got a bit of capsule stuck in here. Now, hang on a minute. Yep. Yeah, it's good. Did feel a bit tighter than normal, but the capsule, yeah. So that is a bit tighter than I would normally like. So we might sink the stem down a bit further. Okay, come on in with your eye. So I think I'm still a bit long. And maybe my neck cut is just a bit, we just need to come across to us a little bit. Yeah. That's good. And then up towards the head a little bit, isn't it? Yeah. Yeah. Good. Try that. Okay, so can you change it to the II? Yep. Yep. Can you change it to the II? Yep. So Meredith is now going to put her overlay onto that implant. Yeah. So you can see there, I don't know if you can see, so she is lengthened and offset's about right. So she is a bit long. So I am going to try and put this stem a bit further. All right. Yeah. My plan was to lengthen her 5-6 mils, right? But she's probably a bit more than that. I would say if that osteotome is 10 mil, we're getting close to, yeah. So it's probably a bit more than I'd like. So I'm going to put the stem in a little bit further. All right. So now we're going to do a lateral. So you can see I don't think my stems, well, that's not a great view of it, is not particularly inverus. And then here I get a lateral.
Will you do the
25.
lower your neck cut? Will you do?
No, I'm just going to put the brooch in a bit further.
Oh, okay. You don't afraid of crack, right?
Yeah. So there's my lateral. All right, there's my lateral. And you can see my cup is pretty much lined up with those anterior and posterior rims. All right. Okay, back on out for us, thanks. So I'm relatively happy with the construct. I think it's going to be that stem size, but I do want to, put the stem in a little bit further. So that I'm not lengthening quite as much. And that might mean we go to a -3 head. We'll see how far I get it down. That was -6, yep. Okay, so I put the hook back in. We externally rotate. That's good. Hang on. Go back. We're just in this muscle. Oh, no, go back in.
Wow.
Yeah. 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 It's good. Hang on a minute. So I just want to feel my trochanter is again lateral. Okay, yep. Slowly bring the leg down. Hang on, just stop for a sec. Yep. Okay. Yep. Yep. So again, as I'm taking that leg back down, I just do like to feel that my trochanter is in front of my cup again and didn't get caught in behind. Have I got the clip, Lynn? Thank you. Thank you. And just the brooch handle. Yeah.
David, we've got a question from the floor.
Yeah.
About periprosthetic fracture risk.
Yeah.
And is age a consideration in that, do you think?
Yeah, sure. I've no doubts that older patients are probably more at risk. But what I've done here is that you can see she's a door type B femur. So I was still, even though she's 87, if she was a C, I would have cemented the stem. But because she's a door B, she's still fairly active. I've gone uncemented. I think it's not so much the age, but also the morphology of their femoral bone. Yep.
But the morphology of the bone doesn't change whether you use the anterior approach or not.
The morphology of the... Say that
You'd
again.
You'd still use the anterior approach in an osteopenic. You'd still be happy to use the anterior approach in an osteoporotic person.
I have to admit, I probably wouldn't, but that's because of my learning curve reason. Yeah. But I think if you're careful, it shouldn't be any different, really. If you do the releases adequately and you're not tractioning on the leg too much, you're controlling the leg as it goes down into the floor and into adduction, there really should be no increased risk over your other assistant holding the leg and manipulating it through a posterior approach. Okay. I reckon we go -3, don't we? Stick to -6. Yeah. Yeah.
How much further in did you get the broach, David?
I reckon I got it in 4 mil.
Right.
What do you reckon, Hake? 3. Hake says 3. I say 4.
All right.
But we're going to measure it at the end as well. Okay, I'll just put the stem in before we open the head. So it's a taper lock stem, which is a double tapered wedge with proximal porous coating, closed pore PPS. I like to put the stem in 80% of the way just by hand. If you can't get it in that far by hand, I think it's going to be too tight. Pretty good. So I think we've ended up where we planned for, because I can see that my porous coating is below my net cut there. You can open a -6, thanks. So I think we are about 3-4 mil lower than where I trialled initially. Thank you. So our offset was right. We're a bit long, but I put the stem in a bit further. So I'm actually happy to put that -6 head in. Have we got time? Yeah, not too bad. 6 minutes.
Yeah, 6 minutes. 6 minutes. Yes, according to the papers, the femoral stem is usually easy to be selected, a smaller one. I also seen some surgeons, some cases occurred some subsidence after operation. What opinion do this situation?
Sorry, say that again.
Yes, according to the papers.
Thanks, Meredith. If we could bring that.
Yeah, for femoral stem, it's easy to select a smaller one and easy to subsidence after operation. What opinion do you have?
Sorry, I don't understand.
Subside.
Yeah, subsidence.
Subsidence. Yeah, so that's why you want
especially the younger surgeons. Especially younger surgeons, it's easy to select a smaller one stem.
Hang on a minute. Just give me a cocker. That capsule, bit of traction. Yeah, it's good. Yeah. So now when I shuck the leg, yeah, I'm getting a lot more play there, 3 or 4 mil. Okay, let's come in for a final X-ray. Sorry, say that again. So with a smaller stem,
there is a risk for subsidence.
Yes.
That's good. So if we could just go on to the II screen again. So there's our final implant. Meredith, can you put the overlay on? Can you just back your machine out a little bit just so they can see the other screen? Yeah. You can focus in actually, Nigel. No, just the one where the overlay. Yeah. Yeah. And just back your II out a little bit again. Bit more. Yep. Yeah. And now just focus in a bit further, Nigel. Yeah, that's good. So you can see I have lengthened her, probably a little bit less than I did with my trial. It certainly was easier to reduce and has a lot more shuck on it than I had. My offset is recreated. We've made sure that we've got the same rotation in the hip as we did with our initial X-ray, and the rest of it looks okay. So my cup looks in good position. We know from the lateral that it's fairly contiguous with the patient's anatomy, so that's what we're going to end up with. Hey, do you mind closing for me? I think they want to ask me some questions. So we're just going to close with... David. Sorry?
Very nice.
Oh, thank you. We're just going to... So Dr. Leonard, we just soak the wound now for 3 minutes with dilute betadine before we close. And so I know there's not much time left for questions, but were there any particular pressing questions?
Yes, there is some question, Dr. David. How is the age consideration in the selection of the direct anterior approach? Is this approach is recommended in young patients? This from Dr. Ryan, the question.
Is it contraindicated in young patients? No. So I think your indication for the anterior approach depends on your experience with the approach, your comfort with the approach, and whether you know how far you are into a learning curve, etc. So theoretically, if you're an experienced surgeon who's done lots of them, there are no contraindications unless you need good access to the posterior column or wall for whatever reason, or as Dr. Sullivan said, they have a big pendulous abdomen that they end up sweating on the wound between the big roll of fat and the wound. But otherwise, if you're an experienced surgeon with the approach, there really is no reason why you can't do it in every patient unless you really need access to that posterior column. Then it will be very difficult to get through an anterior approach. I don't, because I'm not that experienced with the anterior approach yet. I'm not that comfortable. So any patient who is very muscular young males, I tend not to do the anterior approach. Patients who have a protrusio, I won't do an anterior approach. Patients who are particularly stiff with a varus neck, I would also be cautious. And I am also a little bit wary of patients who have, you know, the iliac wing that's quite horizontal. It really closes up that space that you have left to work in to do your femur.
Short, how about the
Would
short?
you agree with that, Jim?
How about the short stature patient?
Sorry?
Short stature patient.
Short stature patient?
Yeah.
I don't think it's the stature. I think it's a combination of how muscular they are rather than stature. So actually the short females are probably easier. She's quite a short female. Have we actually got her height there, Sarah? It's written on that yellow sticker. On the front of my notes is her height and weight. So this lady's 154 centimeters and 59 kilos, but her tissues are so pliable. It was quite easy for me to deliver the femur. It was quite easy for me to expose the anatomy because her tissues are quite pliant. If this was a muscular male, it would have been a different story.
Okay.
David, that's been a great live surgical demonstration. We really appreciate it. We got a very good view.
Right.
Thank you very much for taking us through it.
Right.
We're going to have to wind it up, I think.
All right. Thanks very much, Aaron. Thanks, Jim. Thanks, Ismail. Thanks, Professor Jay.
Thank you.
Appreciate it.
Thank you.
So, good afternoon, ladies and gentlemen. This time we're gonna be the hip session number 4. So my name is Ari Thanawali, together with Dr. Kuku from Indonesia. In this session, the title is Sagittal Pelvic Mobility. We have 5 speakers, so we're gonna start from the first speakers.
The total hip arthroplasty in patient with spine hip combined deformity, talking about. So, firstly, I'd like to introduce the hip-spine connection. The kinematics of motion involving the spine, pelvic, hip are highly interrelated. Spine and the pelvis that move together by the connection of sacrum of the pelvis. The coordinated mobility of the spine, pelvis, and hip. So, first talking about the coronal imbalance of the spine, pelvis, hip. So that's case 1. It's 14 years ago. The diagnosis of spinal scoliosis for 1 month. You can see the spine deformity in the trauma department. So back to history, you can see the treatment of the congenital dislocation of the right hip joined by external fixation with flap spread device. And 2 elective procedures were performed in the years of 2009 and 2011, respectively. And see, when it comes to my clinic, can see the spine, the corpus angle is 45 degree, the angle. So, and the imbalance of the spine, hip, pelvis. So, magically, so when you let the girl sit down, the coronal imbalance was removed in that sitting position. So leg length inequality will lead to the spinal procedures in the healthy spine. So we just talk, this case just talking about the spine, the hip, the related, the interrelated condition. So again, see the case, another case, a 21-year lady suffer from DDH of the left hip. And I can see and that's a bending, for assure the assessment of the spinal flexibility. That's good, flexible. So you can see after total hip arthroplasty, the spine deformity disappeared. Yeah, because, he's a flexible spine deformity. Now let's literally talk about the rigid spinal deformity. Yeah, so we can see pelvic obliquity could be removed after total hip arthroplasty in the patients with no structure spinal scoliosis. Yeah, it's very magic. Yeah. So, conclusion, a summary for the coronal imbalance of the spine, pelvic hip. You can see the impact of the lower extremity and the pelvis on spine should be assessed before a spine surgery. So that's very interesting. I see another case. Yeah, the 45 years old lady was a deviation on the left hip. The left leg length, please pay more attention. The left leg length was 30 minutes shorter than the right before operation. But it turned out to be the opposite post-operatively. So, because, the rigid spine deformity, that's 40 years of the long history with the imbalance of the pelvis. So you can see the spinal deformity still remain after selective total hip procedures. So that results the pelvic obliquity could be hardly removed after total hip arthroplasty in the patient with structural spinal deformity, leading to leg length inequality. Please pay more attention. So for recon surgeon or arthroplasty joint surgeon, we have to more attention not only for our hip or leg, but also have pay attention for the spine. So whether it's flexibility or rigid spine deformity, that's interrelated. So again, another case, 51 years old woman diagnosis of structural spinal deformity results from the separate arthritis of the right hip. You can see right hip in her childhood. So right hip, the right leg was lessened after total hip arthroplasty. So what happened? You can imagine it. After operation. So, and again, the summary for coronal imbalance of the spine, pelvis, hip. The rigid spinal deformity could alert the previous status of the leg length inequality after total hip arthroplasty. So from the functional reconstruction strategy for the corona, the imbalance, the central sacrum, the vertical line during the reverse side bending image to be a symmetric access of the chart to make the assessment of length compensation of the lower extremity. Very important. So even our recon surgeon, we have to learn something from a spine surgeon, for bending, to make sure whether flexible or structural spinal deformity. So let's come to the sagittal alignment of spine, pelvis, hip. For you can see this picture show the normal motion from the people standing to sitting involving the pelvis, posterior tilt and flexion. Actually, when the hip only finish a hip flexion on the 55 to 70 degree, and the continual flexion is come from the lordosis of spine and the tilt of the hip, pelvis. So you can see acetabulum is a part of the pelvis. So when the pelvis tilt, the acetabulum tilt as well. So what means, so you can see that's from standing to sitting position, almost 24 degree inversion change. So please remember, that makes sense, significance. So you can see the picture. When the pelvis tilt, the anteversion, the inclination increased. So that changed. So for how to the interrotate the spine and hip, you can see the pictures. If the long fusion of spine, now that's a very common use in the 18th centuries. You can see the long spine fused. So the pelvis hardly tilt posteriorly. So because of fixed spine and pelvis hardly tilt posteriorly. So the acetabular change could not accommodate the necessary hip flexion and internal rotation without an increased risk of the total hip arthroplasty at dislocation. You can see because the long fusion, the not tilt, so you can even the anteversion inclination is fixed. So what happened? You can see. So in that situation, when we meet for long fusion spine patient, we have to reorganize our anteversion inclination. So for my experience, increased acetabulum anteversion is necessary in that situation for total hip arthroplasty. So now next we move to how can we see the surgical strategy for hip involvement spine pelvic deformity for this very severe sagittal imbalance. So also for how to perform all the hip involvement with a concomitant spine deformity. Yeah. So surgery for hip or spine, which first? So for traditional view, the total arthroplasty priority. But that's my recent publication in GBGS, we propose the spine osteotomy first, and then following by total hip arthroplasty. So case, you can see 46 years old, the ankylosing spondylitis. So the total hip was performed first. But dislocation of the hip process occurred after spinal deformity. You can see from lordosis, from the kyphatic to the lordosis. The tilt, the posterior, from the spine, from tilt posterior to anteriorly. So the anteversion decreased. So you can see the case also that the ankylosing spondylitis, you can see so according to, if the perform the hip first, you can see our pre-operative planning for anteversion angle is -3 degree. And also abduction angle is 9 degree. That's a challenging. Yeah. So what happened? So we perform the spine osteotomy first. So then you can see the pre-operative anteversion is moved to 20 degree and abduction is 40. So that's easy for the arthroplasty, and you can see the simply arthroplasty 2 years. And also 37 old suffered ankylosing spondylitis for 16 years. And so according to, if the hip first, the pre-planning is minor 0.8 degree and abduction angle is 14. So, but osteotomy first spine. So you can see we are easily to perform the PT restore 20 degree, PI 40. So that easily to perform the standard total hip arthroplasty. So also 40 years, a lady for DDH and also spinal deformity. That's a challenging case. You can see. So if we perform a hip first, the pre-planning is -7. It's impossible. And the abduction angles 4 degree. But osteotomy first, you can see that's much easier for the total hip arthroplasty. So we can then, so for this condition, the hip, so we have performed a series of hundreds of patients, such a very severe spine deformity, hip deformity. So you can see it's very successful. A serious case, and case. And we have that. So thank you for your attention.
So, good afternoon, evening, morning, wherever you may be again. My topic of my title now is sagittal pelvic mobility and its effect on functional cup position. My disclosures again. So I think it'd be fair to say between the last, say, 4 or 5 years, the term spinopelvic mobility has evolved. And there's been a large volume of publication using terms such as sagittal pelvic mobility, functional cup position, and spinal imbalance. The terminology has created some confusions because people in different parts of the world use different terminology, and certainly hip arthroplasties and spine surgeons have a different way of talking about this subject. For those still confused by it, can I direct you to a sort of, if you like, a multicultural publication from European, US and Asia-Pacific authors, and also refer you to some of the UMEDI presentations I did in the COVID lockdown, which were unsponsored medications on this, unsponsored presentations on this subject. Please search my name in for UMEDI. So I'd like to split this concept of spinopelvic mobility up into 2 areas, pelvic mobility and spine mobility. So pelvic mobility such that the pelvic sagittal orientation changes with different postures, and that lets us understand this concept of functional component position. So that's what I'm talking about this afternoon. And then the spine mobility. And there's been numerous and increasing publications of reports, if you like, showing high dislocation rates with the stiff or the imbalanced spine. So let's consider these separately. This presentation is to do with pelvic mobility. Now, of course, they're related. Okay, so I think for ease of understanding, we're going to talk about them separately, but they are related. So I'm just talking now about those in the red boxes there, abnormal pelvic mobility, and that can be present with a normal spine or with an abnormal spine. So how does sagittal pelvic mobility affect cup position? And what's the origin of this term, functional cup position? Well, let's have a look at these 2 pelvises. You'll see the pelvis on the left is about to move. As the pelvis anteriorly rotates, you can see the functional component, functional orientation of that component changes. And if it posterior rotates, you can see it changing also. So let's put some numbers to that. What's the consequence in terms of numbers? For every 10-degree change in pelvic tilt, you get a 7-degree change in acetabular version and a 3-degree change in acetabular inclination. So here we go. Let's look at these models again. You say our starting position is 40-25 supine, and this patient then might anteriorly rotate, and the finishing position from a functional point of view is 34-11. On the right, with the same starting position of 40-25 with some posterior rotation, you can see a significantly different effect on the functional acetabular component position. Let's have a look at this from the side now. Okay, if the anterior pelvic plane moves from the vertical in the dotted line and rotates anteriorly, starting at 40-25, it'll then finish at 34-11. Again, I'm going to look on the lateral. If the anterior pelvic plane moves from the vertical, rotates posteriorly 20 degrees, we change from 40-25 to 46-39. Now, it's important here to understand there's a huge variation in the size and the direction of pelvic motion in an osteoarthritic hip population. And we published this 4 years ago now. It's this kind of effect, if you like, that's led to many recent publications questioning the concept of a single acetabular safe zone for all patients, and the fact that component orientation should be patient-specific, taking into account patient's individual sagittal pelvic mobility profile. And these titles, what is the safe zone, death of the Winnick safe zone, this is where all this come from. So here, if you like, is a modern view of what the safe zone should be. For patient 1, there is a safe zone. Patient 2 will be different, and patient 3 will be different. So what are the published thresholds for clinically significant abnormal pelvic motion? Well, I think we've all been attracted to over the years this magic of 10 degrees. If you're 10 degrees from a point that you're aiming for, you've done pretty well. So let's look then at what amount of pelvic sagittal motion changes cup and eversion by 10 degrees or more. as I showed in the previous presentation, if you go from a supine posture to a standing posture and you posteriorly rotate 13 degrees, that will change the acetabular version by 10 degrees. If you go from a standing to a flex-seated posture by 20 degrees or more, that will change the acetabular version by 10 degrees. Now, we can talk about why those numbers are different in question time if you wish. So I'm going to give you a mini summary here. We've talked about the consequence of sagittal pelvic mobility, and extremes in these pelvic mobility parameters create an increased risk of functional cup malposition. So then what do I measure to try and work this out? I've talked about this before earlier this afternoon. I'll talk about it again. I'll measure 2 functional lateral x-rays, the pelvis and spine. A standing lateral and a flex-seated lateral allows me to work out lumbar flexion and standing pelvic tilt, and a CT of the acetabulum, from which I can measure pelvic incidence and supine pelvic tilt, and then work out how to accurately insert the cup in that patient-specific way. So the published thresholds for spine mobility are as such, but I'm not going to talk about that now. I'll give that to you for later reference, as my brief in this presentation is abnormal pelvic mobility. I'm going to show you this example again of a patient whose spinal parameters are within the normal range, but this patient has abnormal pelvic mobility parameters. So if we run this again, we can see the significant change in the functional version and inclination of this patient just with a changing posture, creating a risk of component impingement, inflection, which I think makes this very clinically relevant. So, in summary, sagittal pelvic mobility changes functional cup position. There's a large individual patient variation in pelvic mobility in an osteoarthritic population. There's a known high incidence of abnormal pelvic and spine mobility parameters in patients who need to be revised for instability. And finally, if you don't look, you don't see, so I suggest you measure. Thank you very much.
Hi everyone, my name is Seung-jae Lim, working at Samsung Medical Center, Seoul, Korea. Today I'd like to talk about spinopelvic imbalance and role of dual mobility articulation. This is my disclosure. This illustration shows the pelvic tilt and changing acetabular curve orientation in different body positions. The spine pelvis hip complex functions as 2 hinges. For example, if the posterior hinge lost motion because of degeneration or surgical fusion, the anterior hinge, the hip joint, is compensated with excessive motion. So scenario 1 is surgical fusion or increased lordosis patient have excessive anterior tilt of pelvis and therefore risk of anterior impingement in the sitting position. These patients are at high risk of posterior dislocation from standing to sitting, bending at the waist or hyperflexion of the hip. Scenario 2 is degenerative kyphosis. Patients have excessive posterior tilt of pelvis and therefore risk of posterior impingement in the standing position. These patients are at high risk of anterior dislocation while walking or standing. I'd like to share my recent experience about related instability of total rib caused by stiffness. Scenario 1 is 76-year-old female. She underwent 4-5 fusion in 2011. 8 years later, she complained of severe back pain and adjacent segment degeneration was found. Standing lateral leg shows loss of lordosis and posterior tilt of pelvis. In 2020, long-level fusion and iliac screw insertion was performed. However, T11 compression fracture was found at post of 3 weeks. Fusion was extended to T8. Post of 2 months, sagittal balance was restored even though T8 compression fracture was newly developed. However, during admission, sagittal balance posterior dislocation was found while sitting to chair. Cross reduction was successfully performed. Unfortunately, 10 days later, another dislocation was developed developed, and she decided to undergo revision of total hip arthroplasty. Dual mobility articulation was used without revision of femoral stem, and this is post-op 3-day X-ray. These are post-op 2 months X-rays, and curve was well fixed. And this is a picture of patient walking. Scenario 2 is 79-year-old female. She underwent total arthroplasty 15 years ago and complained of progressive severe cracking and pain on walking. Lateral radiograph shows degenerative lumbar kyphosis and unusual posterior tilt of pelvis. Posterior impingement was detected in the cross-table lateral radiograph. Axial CT scan shows 40 degrees anteversion of the acetabular cup. A small amount of osteolysis was also found. Arthroscopic exam was performed and showed severe metallosis. And interestingly, ceramic liner chipping, which is indicative of femoral head subluxation, was found. This is immediate post-op X-ray. Unfortunately, next day, while from sitting to standing, anterior dislocation was found. Cross reduction was successfully performed, but she wanted to undergo revision surgery of the hip. Dual mobility articulation curve was used without revision of femoral stem. Clicking and pain on walking was disappeared, and there is no posterior impingement in the cross-table lateral X-ray. These are recent follow-up pictures of the patient. She's happy now. In 2019, Larry Dwyer and John Callahan, in their editorial of Journal of Arthroplasty, declared death of Levenick safe zone and proposed the concept of functional stability and patient-specific safe zones. In summary, spinopelvic stiffness or surgical fusion of spine is fourth causative category for dislocations following total arthroplasty. And for this patient, consider the use of dual mobility articulation. This wonderful messages was described by pioneering hip surgeon Lawrence Dorr. Thank you for your attention.
My name is Yoon-Soo Park from Seoul, South Korea. This is my disclosure. Spine pelvis hip motion during the daily activity changes acetabular anteversion and inclination. From lying to standing and from standing to sitting, acetabular anteversion gradually increases. When a person sits from standing, the hip joint does not flex entirely by 80 degrees. Instead, the pelvis tilts posteriorly 25 and hip flexes only 55. In turn, anti-inclination, the sagittal opening of acetabulum increases by 25 degrees. This coordinated spinopelvic motion improves the clearance of femoral head and neck, therefore preventing the impingement and dislocation of THA. But if the one segment gets stiff, the other part should be more mobile. If the spine gets stiff, more hip flexion is needed while sitting and more hip extension while standing. In this condition, there is high chance of impingement and dislocation. Abnormal spinopelvic motion can be classified as hypermobility, kyphosis, and stiffness. Hypermobile pelvis can be seen in younger females and does not always consider pathogenic. True pathogenic conditions are kyphosis and spinopelvic stiffness, and the spinopelvic stiffness consists of stuck standing and stuck sitting patterns. The kyphosis pattern occurs in a patient with a kyphotic spine and a mobile pelvis. As the pelvis is tilted posteriorly to get balanced in a standing position, acetabular anteversion increases, thereby increasing the chance of posterior impingement and anterior dislocation. Stuck standing stiffness is a result of rigid degeneration of lumbar spine or spinal fusion surgery. As the pelvis is fixed anteriorly and does not tilt posteriorly while sitting, there is higher possibility of anterior impingement and posterior dislocation. Stuck sitting stiffness is a result of degenerative flat back or a long level spinal fusion. As the pelvis is fixed posteriorly and does not tilt anteriorly while standing, there is a higher chance of posterior impingement and anterior dislocation. To find out abnormal spinopelvic motion in a patient undergoing THA, standing and sitting lateral spine pelvis hip X-ray are required, especially for revision THA and patient with spine disease or spinal fusion surgery. Pathologic stiffness with a pelvic motion less than 5 degrees is a dangerous condition which has the most high risk for impingement and dislocation. Target position for a normal patient is 35 to 45 with inclination and 15 to 25 with anteversion in the coronal plane. However, these angles should be tailored according to the spinopelvic motion of each patient. For patient having stuck sitting stiffness or kyphosis, less inclination and anteversion are recommended, and those with the stuck standing stiffness, more inclination and anteversion should be considered. To reduce the incidence of dislocation in these situations, the use of dual mobility curve is gaining more popularity. The dual mobility concept was first introduced in THA by French in 1974. It has a large mobile polyethylene component, constrained with the femoral head and non-constrained with the outer shell. This device provides great range of motion and is expected to reduce dislocation. Modular dual mobility system has an additional metallic insert between the poly component and the outer shell, which enables multiple screw holes for fixation. This allows the MDM implants to be used more safely in the revision surgeries. To find out the effectiveness of dual mobility articulation in treating troublesome dislocation, we did a study including a series of revision THA using the MDM system performed for recurrent dislocation. From September 2015 and April 2019, total of 32 revision THAs were included in the study. The mean age at revision was 69 years, and the female patients were 72%. The late dislocation occurred more than 1 year after previous THA was 81%. At the time of revision, 53% had degenerative kyphosis and 13% had spinal fusion. Anterolateral approach was the usual approach, and most surgeries were isolated to cover revision. Cancellous bone graft was used in 41%, and the dome screws were applied in 91%. After 3 years of follow-up, no dislocation, intraprosthetic dislocation, or septic loosening was found. Only one acetabular revision was required for periprosthetic infection. The implant survivorship with an endpoint revision for any reason was 96.3% at 3 years. Here are some cases. This case was an 87-year-old woman who underwent THA for osteoarthritis. Lumbar radiograph showed degenerative flat back and scoliosis. Right hip was first dislocated after 15 years. An X-ray showed anterior dislocation. Manual reduction was done, but the patient experienced recurrent dislocation and sensitive instability. Isolated cover revision was performed using the MDM implants, and the patient experienced no more dislocation. Second case was an 84-year-old man with right hip THA for AVN. The patient had surgically fused spine from lower thoracic to the lumbar levels. After 19 years from the initial surgery, the patient had posterior dislocation while sitting. Isolated cup revision was performed using MDM device and the hip was stable thereafter. Take-home message is for patient with abnormal spinopelvic motion, we can consider using the dual mobility articulation. The modular dual mobility system was effective in treating recurrent dislocation despite a large percentage of spinopelvic abnormality. No redislocation, intraprosthetic dislocation, or aseptic cup loosening was found after mean follow-up of 3 years. Thank you for your attention.
Dear colleagues, this is Yixing Zhou from Beijing Jishuitan Hospital. In the next few minutes, I'd like to share you our experience with a patient-specific safe zone for total hip replacement. As we all know, traditional safe zone does not predict dislocation after a total hip replacement. Dr. Larry Dorr actually has sentenced the traditional safe zone to death, and he has proposed a functional safe zone. He believes it is superior to Levin neck safe zone for total hip replacement. Study 1. We've developed an algorithm to convert CSI into a coronal plane. We had a very interesting finding. So averagely, there's only 64% of Levin neck safe zone landed within the coronal functional safe zone. And also, we tried to identify if there's any sweet point of the acetabular positions existed that can universally fulfill the requirement of all 100 patients. These are combination of pelvic incidence and pelvic motion. There is no sweet point could fulfill the limits of CSI index for all the 100 patients. There's no sweet point for any subgroups of either pelvic motion and pelvic incidence. All these results actually told us the patient cup orientation should be individualized and patient-specific. Study 2, we've developed an algorithm to calculate patient-specific safe zone. So based on sagittal postural change of pelvis in standing, sitting, and squatting, we calculated the patient-specific safe zone, which are green dots in this picture. These green dots actually meet the requirement of impingement-free and edge-loading-free. We routinely took lateral view of spinal pelvic X-ray when the patient stands, sits, and squats. Then we calculate cup orientation, which meets the requirement of impingement-free when the stands, sits, and squats. We had pretty good sensitivity and specificity. We also had interesting finding. The area on all these curves are the area of patient-specific safe zone for acetabular components. If the stem antiversion is less than 10 degrees and larger than 20 degrees, the area of specific safe zone, it drops significantly, which told us the stem antiversion is very important to optimize and maximize cup safe zone. It is also understandable the patient-specific safe zone is influenced by range of motion post-operatively. Study 3 is about application and the preliminary result of patient-specific safe zone. So in the late half year, in 2019, we did 92 cases of primary total hips assisted by Mako and patient-specific safe zone. As a control group, there's 41 cases of primary total hips, which were done freehandedly. We had positive results. So these are our post-operative anterior index, so which is better in Mako plus patient-specific safe zone group compared to traditional tool group. So also the combined sagittal index is better in patient-specific safe zone group compared to traditional tool group. There are more cups landed in the CSI safe zone with PSSZ, so which means patient-specific safe zone group compared to traditional safe zone group. There's only 70% of cups landed in CSI safe zone group. This is a case of hip dislocation after total hip replacement. So intraoperatively, with a robot, we confirmed the cup is male-oriented and also the stem is retroverted. But more than that, please look into the x-rays. The pelvis didn't move, no matter when the patient stood or sit. So this is a type of sit-like walking. If I retain the femoral stem, there's no safe zone available at all. Then I had to revise the stem and put a new stem with 15 degrees of anti-version. There were only five green dots available. Then I used a robot to ream the acetabulum, then executed the cup insertion. This is the post-op X-ray. So there's almost 1 year post-op. The hip is pretty stable. So these are our take-home messages. Cup position should be functional and personalized. Spinal pelvic motion influences the cup orientation. Patient-specific safe zone executed by a robot is a promising solution. I thank you for your kind attention.
So thank you for all 5 speakers. So now going to be question and answer. So Google, please, you have some questions to all speakers.
Thank you to all the speakers. Maybe I will read out the questions coming from the audience first in the Slido. Maybe to Professor Dr. Yan Wang. Okay. How do you think if there is any relationship between the coronal imbalance with the dislocations after total hip arthroplasty? Is there any relations, or what's your view on this? Or maybe from the other speakers, this is questions from the audience. Maybe Andrew, any view on this? Any relations between the coronal imbalance with the dislocation after total hip?
Sure. Okay. If you have to, my view is, if you have to rate the relative importance of sagittal deformity or coronal deformity to the incidence of hip instability, sagittal deformities has a much more significant influence. That's as a starter. Yep, I think coronal imbalance, fixed coronal imbalance can be problematic. I'll say we don't see it that often. And I think the effects of coronal, if you like, malorientation are less severe than the effects of sagittal malorientation. Only other point I'd make on that is, if we start to try to manipulate coronal deformities by altering leg lengths, certainly you can't shorten leg lengths without significant compromise, and there's a limit to what you can achieve in terms of increasing leg length. So I think, it's a difficult problem. It's unfortunately it's not a common problem, but I don't know of any association between coronal imbalance, if you like, or coronal deformity and dislocation.
Yeah, I want to hear your view. You know that we all agree that spine examinations or spine X-ray is a must before any THR. Especially when this is obvious deformity. But what's your view when the patients come with less obvious deformity, spinal deformity? Do you all agree to do screening, and with what kind of spine radiology do you routinely use X-ray or also the CT scan? Maybe you can start from Dr. Sung.
Oh, you asked me? Actually, my name is Sung Jen, not Sung.
Okay. Oh, sorry. Apologize.
Please tell me, Dr. Lim. Yeah, Dr. Lim.
Okay. Dr. Lim.
Okay. So I routinely check the the whole spine, AP and lateral X-ray, and the lower extremity X-ray. And recently, our hospital introduced the EOS system. You know EOS?
Mm-hmm. Yes.
So now I'm routinely check the EOS for every total hip arthroplasty patient. Mm-hmm.
How about the others?
Yeah. How about the other, Dr. Park and Dr. Zhu, maybe?
Oh, me. Yeah, Sungjae and I work in the same hospital, so we do EOS for patients.
I see.
Yep. Yes, pre-op screening.
So the EOS is an expensive instrument, right? So some hospital they don't have that. So if we don't have this kind of a new instrument, what would you recommend? Take the lateral X-ray in sitting or in the standing position?
Yeah, I recommend spine X-ray, whole lumbar thoracic spine X-ray in sitting and standing is a routine, I think.
Mm-hmm.
If we don't have EOS.
Yeah. Andrew, so what would you suggest? The same things?
Yeah. No, as a routine, it's a routine part of my practice would be a standing lateral, a flex-seated lateral, not a relaxed-seated lateral. And the reason for that is you can only fully understand lumbar spine flexion if you have a flex-seated lateral. If we take the original, where all this story started some years ago was the observation that the stiff or the fused spine has a higher dislocation rate. So I think you've got to know what the lumbar flexion is. And the only way to do that is to measure it. I think these surrogates for lumbar spine stiffness by measuring pelvic parameters, such as sacral slope change, I think, it's being half pregnant. I think you need to understand whether the spine is stiff, and the only way to understand it is to measure it. And the best way to measure it without an EOS is to do standing lateral and a flex-seated lateral.
You see, you do the same things?
Yeah, almost the same.
I see. Mm-hmm.
And we do EOS.
I see.
Just as Dr. Park does.
Yes. I heard from Dr. Wang. He said that currently we fix the spine first before the hip. So, when we learn in the past, mostly hip and spine problem, when they come, right, we suggest to manage the hip first. So what would you recommend for the trend change? I would ask all the speaker, anyone can talk first.
We're all too polite.
Please go ahead, Andrew.
No, we're all too polite. I've spoken enough. I'll have something to say, but please, someone else first.
So I would like to try. So if the spine deformity is so significant and the patient is willing to undergo corrective surgery, so I will let the patient to receive a spine surgery first. So otherwise, I will do the hips first. And since I have to do many revisions, so if the cup become well positioned after a further corrective spinal surgery, so I won't hesitate to do a minor revision, just to remove the cup and well position a new cup. So I would like to do it two-stagely.
Look, I think this decision and this conversation about hip or spine first has really taken, it's a lot more mature conversation. It probably wasn't even a conversation maybe a decade ago. I think that most situations, for the audience here who are doing primary hip replacements, most situations you're going to choose to do the primary hip first. That's a predictable operation with a good outcome, which will often help coexisting spinal symptoms. So that's the sort of introduction comment. But I think now we've got to understand that if you've got someone with a severe sagittal spinal deformity, it's not unreasonable to have a conversation with your spinal colleague before proceeding with a total hip replacement. That would be where we're settling now. It's a conversation that hip arthroplasty surgeons must have with spinal surgeons in 2021 when you're dealing with a severe sagittal spinal deformity, particularly in a younger person.
My comment?
Dr. Park.
Yeah.
Yes, Dr. Park, please.
Usually for older people with hip and spine problems, I do hip first because usually patients' problem for old flat back or degenerative problems, it's a huge operation than arthroplasty. So I think most of patients complain the hip pain more than the spine deformity. So I do the hip with the dual mobility. So a second operation of spine operation is his or her choice. But I don't know if they really want spine surgery later. So I do hip first with the dual mobility with existing deformity or any problems.
So, Dr. Lim, how about you?
Yes. Actually, Dr. Park and me working in the same hospital, and we regularly have a conference. So my answer is the same. Yeah. So we routinely check the spine X-ray, and some patient, if we do total arthroplasty with dual mobility articulation, the spine back pain is improved, and they get better after hip surgery. So we do hip first. Yeah. Okay. Same opinion with Professor Park.
Okay. That's good. Again, I think we still can have one more question. These questions come from Dr. Arjun from Nepal. What are the tactics in intraoperative evaluations of cup position in relation to spine deformity, whether it is likely to get dislocated post-op? So I think Dr. Arjun asking if we don't have Mako or something, is there any tips from you all to evaluate intraoperatively for cups positions in spine deformity? Maybe we can start from Andrew.
Look, it is difficult. Certainly in my practice now, I will have a patient-specific plan, and I will have technology to help me achieve that plan. If you don't have that, if you have a situation where you feel that someone has got a spine deformity, you don't have any objective data, anything to measure, then I'd agree with Dr. Park in those scenarios. That's probably where you'd use a dual mobility. You might also, use other techniques that you have to help in the unstable scenario. You certainly don't want to make them shorter, so you might choose to make them 2 or 3 millimeters longer. You might choose to increase their offset, and you, as I said, choose a dual mobility. So if you've got any indication on their history or any imaging you've got, they're the practical things that you've got up your sleeve if you don't have any fancy kind of PSI guides or robots or something like that.
How about in Korea, Dr. Lim or Dr. Park? You always use technology or any tips?
As I mentioned, we did the robotic surgery, but it's not a routine procedure now. And for a problem spine with existing deformity, we do some modification of ideal angle, as I told you, with a fixed anterior tilt or posterior tilt. But that is not usually satisfactory. So we do very severe stiffness. We do dual mobility routinely.
Okay, thank you. Dr. Tanafali, I think we are running out of time. Okay.
Yes. I would like to thank all the speakers and also my co-moderators. So I need to end up this session. Thank you very much.
Thank you.
Thank you.
I'm going to start to convince you that using dual mobility in routine is a good option. I have a couple of conflict of interest not related with this talk. The first thing when you think about using a concept is to understand where it's coming from, and we do have a long, history with dual mobility, especially in France. The concept was designed a while ago by Professor Gilles Bousquet, not far from Lyon, where I'm working. And it was actually a combination of the benefit of three concepts: the low friction arthroplasty from John Charnley, the big femoral head from Mackie, and the bipolar concept from Christiansen. The idea was to improve the head-neck ratio, and doing that to increase the jump distance. The benefit is, of course, to decrease the dislocation rate. The first design are very different from the one we are using currently. And there was obviously some mistakes, and the historical series have showed that there was some dislocation, intraprosthetic dislocation and loosening. But actually, these potential issues actually have been, all of them, I think, fixed with the new generation. The first one is the intraprosthetic dislocation. You can see that since 2000, so more than 20 years, this intraprosthetic dislocation issue, in my opinion, disappeared because there's been some improvement in the liners density, liners design, dual mobility cup coating, and also the understanding of what's the appropriate stem you can use with dual mobility. Also regarding the fixation, initially some problem with secondary fixation due to poor quality coating, but now with the bilayer coating and the add of porous titanium or hydroxyapatite, the secondary fixation is now extremely efficient. The long-term results have been extensively published, not only in France, but you also have a lot of publications from the States and other countries. And with the modern design, you can see that the outcome are excellent, with almost 100% survival rate at 10 years and no more issue with aseptic loosening or problem of intraprosthetic dislocation. The present is massive use in Europe. 20% of the cups in primary hips are dual mobility cups, with several designs available between anatomic and hemispherical. And now with the modularity, it's helping the technique. You can add some screws, you can use it in the revision setting, and also you can make the decision introp between a standard cup or a dual mobility cup. Of course, you have to be cautious with the setting of the liner and where you're positioning the screws. There were a lot of publications showing that with standard polyethylene, the problem of wear is actually not really a concern. And now with the new poly, the crosslink poly and the new generation, definitely there will be some improvement, even if you're using the dual mobility for younger patients. You have to understand that you have to use the proper head, and ceramic head is definitely the concept to use when you're considering dual mobility if you want to avoid problem with the third articulation, just like in this case. Adding the possibility to use a cemented dual mobility can be very useful also in the revision setting. And this is an approach we use in challenging cases, just such as these ones. And also whatever the approach you're using, if it's a direct anterior or if it's a posterior approach, a lot of publications showing that you can use this dual mobility concept, whatever the approach you're using. Today, my indications: over 75 years old, high risk of instability, spine fusion history, revision case, femur neck fracture, posterior or anterior approach. I'm using a dual mobility cup in all these indications. And I also extend my indication for high risk patients. The consequence, you can see in France, 34% of the primary hips are dual mobility cup. And we have perfectly managed to control the dislocation rate using this strategy without increasing the complications. Consequences are also economical with a good, benefit in using Markov model, considering, the cost for the healthcare system using dual mobility. And also in revision, you can see that almost 60% of the caps are dual mobility caps. And you can see here the survival rate at 12 years, 96% in this recent study we published. So also a great strategy. In the future with robotic, we might understand even better how to position the caps and how to use them. So in conclusion, why I am in favor of routine use of dual mobility, there is a long history. Mistakes from the past are well understood. Intraprosthetic dislocation is not an issue anymore. To me, there is no debate regarding the efficiency to control the dislocation risk. It can be used safely with any surgical approach, and there is strong benefit for primary and revision hip replacement for the patients because there is no restrictions in mobility. For the surgeon, there is no more dislocation, and for the society because you're saving costs. Thanks a lot for your attention.
Yeah, there is some confusion of slide presentation. We are so sorry. Anyway, next topic is from Beijing. Dr. Yixin Zhou will talk about the routine using dual mobility is not necessary. Please.
Thank you, Dr. Park. Dr. Lustig's presentation is so elegant and convincing. I won't deny dual mobility reduces dislocation. Neither will I deny the trend that more and more dual mobility have been utilized in our practice. But my opinion is the dual mobility should not be routinely used because the decreased dislocation with DM does not come for free. So there are some concerns with dual mobility. Some of them are quite unique to this design. So one of them is intraprosthetic dislocation, as known as IPD. Still, the incidence of IPD is still around 1%. Historically, this rate is pretty much higher. Then also, the increased wear of polyethylene may lead to loosening of femoral or acetabular component. Growing pain and the source impingement is still a concern since larger femoral head may irritate soft tissue around the hip. Metal ion releasing is still an issue, and there's a personal communication between us and Dr. Craig Della Valle. There's a number reported in the previous American Hip Society meeting. So more than 5% metal liners had been male-seated intraoperatively, and this may lead to metal ion issue. So as we all know, corrosion
we cannot hear Dr. Zhou's voice. Dr. Zhou Yixin, where are you?
So significantly improved the functional outcome at 1 year. Okay, so I had some problem with my connection. Should I go back or just go ahead? Okay, so with respect to 32 millimeter femoral head, larger femoral heads should limit the benefits in both presence of optimal and the non-optimal cup position. Okay. Sorry.
You show me the slide.
So,
okay.
Can you see my slide? So I think dual mobility should be indicated for high-risk patients like cognitive impairment, compromised abductors, revision surgery, or lumbar spine disease. So there's more concerns with younger patients with dual mobility, less concern for long-term risks in older patients. So individual risk assessment is required. So dual mobility is not necessarily cost saving. So DMTHA was no longer cost saving when the annual increment probability of revision for any unforeseen failure mechanism exceeds 0.3%. So dual mobility should not be routinely used. Thank you.
Thank you. Two speakers. Can I ask Dr. Sebastian Lusty?
Sure.
Yeah. In your conclusion, you still have a limited indication because in a high-risk patient, so you are not always doing primary total hip with dual mobility. Is that right? You have some specific indication?
Yeah, correct. I think the discussion is about what is a high-risk patient. And in my mind, because, with, degenerative evolution of the low back spine, to me, patient over 70 is a high-risk patient. So I consider dual mobility for all my patients over 70 because I'm not concerned about the polyethylene wear anymore. And doing that, it's still a significant part of my patient. So I do a routine use of dual mobility for my patient over 70. For the younger patients, the long-term follow-up, of course, is more concerned, and I will move towards different bearings with a higher long-term survival rates. But I also would like really to make a difference between modular, dual mobility and monolithic dual mobility, because I think there is sometimes a misunderstanding of, both concepts are quite different. And I think the modularity has been designed to help, the surgical technique because it's easier to control the impaction. You can add screws, so that's easier. But all the long-term publications are with monolithic, dual mobility. And there is, using that, there is no concern with screws or liner setting or, potential issue with the fritting corrosion. So I really like to make this point. So routine use with monolithic dual mobility cup is, in my opinion, is not a concern.
Okay. Dr. Zhou?
Yes.
Can you hear? Yeah.
Yeah.
How much percentages do you do dual mobility in your practice for primary cases?
To be honest, very rarely. So dual mobility has been recently introduced into my country. So we don't have much experience with that.
Okay. Past experience from France, they have been using more than 40 years. So far, there is no big complication or side effects except intraprosthetic dislocation or some cup loosening because it was monolithic. But nowadays we have modular system with the screw fixations. So cup loosening is not a big problem anymore. So that's why in Europe and in United States, as I know, in 2017, in American Joint Registry, they have a 10% dual mobility use in primary cases. Andrew, can you hear me? Andrew Shimmin?
I can.
How is it?
How is it?
How is it in Australia? In Australian Registry, how much use in?
I think the key there in the Australian Registry is the increased use. And in our last registry report, there was a significantly increased use. Now, I apologise that I can't give you an exact number. but certainly in the last 12, sort of in the year 2000 and where are we now? 21. In the year of 2019, there was significantly more than the previous year. So that's what I'll tell you. Increasing use.
Yeah, everywhere, globally, the rate is increasing every year.
Yeah. So if I may, Dr. Park, I would like to ask Dr. Lustig. So as I know, so at least in some area in France, and some surgeons still reserve dual mobility for elderly patients and patients with high risk of dislocation. Is that true?
Yeah, correct. You have two options. You have surgeons who are using 100% dual mobility cups. Most of them are using posterolateral approach as they want to control the dislocation rate. But I think it's probably something to advise is more what you're mentioning is having indication, limited to patient at risk. And again, the problem is the definition of what's a patient at risk. And I would say the discussion will be how old, is a patient when he's coming at risk. So, and usually in France, over 70 years old, you have a really high percentage of surgeons using dual mobility cup for these patients. Whatever the medical history, if there are, neurological issues or not, if you are over 70 years old, you will get a dual mobility cup. And honestly, we haven't seen any increase in the complication rates, especially with the improvement of the quality of the polyethylene or, the design of the cups. So today you have seen the numbers. It's 200,000 dual mobility cups per year in Europe. And we have several countries with registries, and today the numbers are pretty good.
Yeah, probably we have different patients. In my country, the average age to receive a total hip is about 51. So this is a pretty much younger age.
Absolutely, you're right. It's the mid age for us is 69.
Okay.
69.
Yeah.
So that's really different. You're right.
Mm-hmm. Mm-hmm. Yeah, there's a difference. And we have enough discussion, so we need to vote for routine utilization of dual mobility is necessary or is not necessary. Audience can vote.
Good luck, Sebastian.
Can I vote?
Can we see the result in the screen?
I think the sample size is not big enough. Is going to be Sebastian's response.
Okay.
No, I didn't respond.
Can we see the screen about the result?
I think Sebastian just voted.
Okay. I don't know. Technically, we can see the result or not. This time, the Australian system is very new to us. So, Slido or something.
Slido, yeah.
To that. Is it popular in Australia?
Yeah. We're equally unfamiliar, but I'm sure 12 months' time we'll be a lot more familiar.
Can you help us? Some person in the monitor room?
8 voted and 75% against the routine use of dual mobility and 25% for the routine use of dual mobility.
Okay.
So I'd say 8 people is suggesting that a lot of people are struggling with Slido, Dr. Park.
Yeah.
Okay. So, the two speakers actually shares the similar concept. So we still have some indication, but we have to see the long-term concern or side effects. So we are increasingly used dual mobility for problem cases, femur neck fracture, all personal spine problems, but still we are cautious to use to all patients for primary total. Thank you. We are closing this session.
Thank you.
Well done, gents. Well done. Rami, Andrew Shimon. Are you able to hear me?
Andrew, I can hear you nice and clear. Welcome.
Wonderful. We can hear you nice and clearly. Rami, look, thank you very much. All's going very smoothly. And just to introduce what's going to happen, Rami, you're going to show us a cementless total hip replacement with a posterior approach, having done the planning with the Current Insight planning platform. So, Rami, also, could I welcome Craig Waller and Yi Xing? We'll all be kind of chatting amongst ourselves and chatting to you and asking you questions along the way. So, why don't you kind of introduce what you're about to do and we'll get underway, and then we'll start chatting, yeah?
Thanks, Andrew. Welcome, everybody. This is an 81-year-old lady. We're going to share with you her total hip arthroplasty. Fortunately, she's already had one on the other side. She's come back after a year, I think it was last year. She's come back to have her other side done with ongoing pain and disability. We'll show you the x-rays in a little while. This is a standard posterior approach. We're going to be using cementless implants. The particular implant is Paragon with a global cup. We're going to use also the OPS alignment system, which helps us with preoperative planning, but also helps us intraoperatively to try and reproduce the positioning of the cup. We can also use a PSI instrument, which we'll demonstrate. This is really using technology to try to assist with a better outcome, and we'll be discussing the pros and cons as we go along. I'm going to start with the posterior approach. I want to introduce my team. Dr. Amit Bobaid is our fellow from Mumbai. Bhagesh Patel is my long-time assistant. Bella Movia is the scrub sister. Terry Tay is the anaesthetist. We've got our other assistants and our V team and camera team here. So we'll make a start with the posterior approach. Many of you would be familiar with this. There's nothing too fancy about this. I've got a position, lateral decubitus position. We're going to use a leg length device to assist. We're going to use some lasers to assist. And we'll discuss as we get to each of those points the reasoning why, but it's all about really giving the surgeon a little bit more information during the procedure so you can make the right decisions. In positioning, I've got to say, I've been doing the posterior approach for a good 25 years now. For the last 24 years and 6 months, I've done it the same way. It's really only in the last 6 months I started using the OPS system. I don't have the experience that Andrew Shimon has with it, and that'll be obvious when he starts talking about his experience with it, having really developed its ingenious means of giving us information, and we'll talk more about that as we go. The reason I changed to it after many years of using the other device is very basic. I templated off standard analog x-rays for a long time, very reliable. Then something happened. Technology brought in digital radiology and imaging. And suddenly I couldn't rely on the sizing anymore. I would template for a size and find I'm 2 or 3 out. It became very, very difficult to trust your templating system preoperatively. This offers an intraoperative, a preoperative, and a means of templating by digital technology that's certainly more accurate than the current radiographs and imaging that we're currently getting for the standard templates that were designed for the analog x-rays. But with that in mind, while I continue with this standard posterior approach, taking off the external rotators, splitting through the gluteus, etc., I have a great moderating team with Andrew Shimon, who's been very involved with the OPS system, extraordinary surgeon from down in Melbourne. I've got Craig Waller, extraordinary surgeon with significant experience in Sydney, and also co-designer on the Paragon stem. So I do have to mention a conflict of interest in that I'm a co-designer on the Paragon stem. And Ishin Jiao, a very established and excellent surgeon from Beijing Jishutan Hospital. So with that, Andrew, maybe if you get, while I continue with this, if you go to the split screen so they can still watch the surgery, but introduce the patient and the means of preoperative templating that we've used using the OPS system, then we can discuss it.
Okay. So, guys, would you mind if we could make sure that the delegates have my screen with the preoperative plan? Steve, can you confirm that that's the case, that the delegates can see the screen that I'll be talking to?
Not yet.
Thank you. So Rami's doing the surgery on an 81-year-old lady, and I'll just give you a quick overview of what he's what he's planned to do. So if you can follow my mouse here there's 3 tabs. There's a dynamics page,
That's actually
a cup page, and a stem page. So he's done some templating here, and he thinks it's a 52 cup. He's using a Paragon size 2 stem, and we will get Craig involved in some of the design philosophy of that stem. He's got a standard offset, a ceramic head, 36. So there's that's his plan. Along the top here, he's got a summary of the spine and pelvic parameters. So, I mean, this is going to be fascinating.
Self-retainer as well.
Because, this patient's got a significantly sagittally imbalanced spine, which is why that's in red. And, we've just had a discussion about dual mobilities, and it'd be great fun to talk to Rami and as to whether he's going to use a dual mobility or not. And see, so there's a summary of the spinopelvic mobilities. This is the planned cup position, and you see how Rami's going to achieve that. Summary of leg length. The idea is to make this person 5 mils longer, and to change the offset by 1. And that's going to be a feature of the implant. So this is the planning. Now,
can you bring the camera?
Why don't we now, before we go too far, I'll just show you the cup planning page. And so you can see how the precision at which Rami can aim to try and achieve what this plan, and now there's the stem planning page, and so you'll see that if we put this in osteotomy plan, this is what the brooch is going to look like if Rami is going to try and achieve the stem version. Now you can see there's some bit of complexity going on here, because this person's native stem version is 1 degree. So you can see already before he starts this case, he's got a whole heap more information than he had when he was using his digital, his sort of plain films on the screen. So what about Rami, how you going in there? You want to talk to us? Well, we can have Rami, you going good there?
Yeah, you can come back when you, whenever you're ready.
Why don't you,
once you've
come back, talk to us now. Where are you up to? And we've just had an introduction into your plan.
Excellent.
You could just tell us where you're up to.
So at the moment, I'm putting my Langenbeck under the gluteus medius and minimus, basically exposing the external rotators. I'm trying to get the camera in a better position so you can actually see the external rotators. John, can we show that? We're seeing it.
While we're organising that,
hey John,
Craig and using,
come back
Craig
a little
using,
bit.
Can you tell us which is your favourite
go
approach?
Over there, because we need to be able to see that.
I do both, but I'm more comfortable doing the posterior approach, same as Rami.
Okay.
Yeah, I do
your favourite approach.
Posterior lateral.
Okay, so it would seem here that we're going to have a posterior approach flavour.
Yeah.
And what about you guys? You guys into planning, Craig, and using? Are you into this sort of planning, or are you still templating?
No, like Rami, I've switched over to this in the last year or so, and I've been really happy with it. This OPS system just gives you a good idea. Look where you put your cup is, gives you a good idea on the sizes, and helps you with the anti-version of the cup.
Yeah, okay. And are you a planner, or are you working out of the time?
Yeah, so currently I routinely use robot to do my hip surgeries, primary or revision. Andrew, may I ask, so what's the accuracy of pre-op planning of the femoral side? So is the stem version accurate pre-operatively?
So, in terms of once you've decided what you want to achieve in cup size is shown with this planning is really very, very accurate. Of course, you can in the planning say, for example, let's mess around here. For example, we can, although this person's had a Paragon stem on one side, this is what we plan, or Rami's plan that wants it to look like. But we can put a different stem in here, and if we wish, it's not going to let me do that, but you can put a whole lot of other stems in there. You can look at the bone density here, so you can see this is a fully coated stem. I'm sure Craig's going to tell us more about that. And you can see green bone is good bone, and so there's a lot of good bone to interface between, certainly in the proximal part, a good bone to interface with the ingross surface. In terms of the version using...
You zoom in.
See the version here. This patient's native version is -3. If the brooch looks like that, then that's achieving a stem version of 1 degree. And again, there's been some good studies done on this, just presentation quality studies, not publication quality studies. So to show that the eye can see that the brooch looks like that, and if the brooch looks like that, then that will be equate to the correct version. In this situation, certainly there's no impingement, so there's no reason to change this person's native version. So, Rami, where you're with us, why don't you come back to us now and tell us where you're at?
Good. Okay, so we've taken away the external rotators, which Amit's holding here. So I got piriformis and the obturator internus. I've just divided the capsule, which is here. We're just going to put a suture in that and reflect that. But you know what, we're talking about accuracy before. I was pretty happy with the accuracy of the analog x-rays in templating my implant sizes, and we were always within 1 size, maybe occasionally 2. I just found when we went to digital x-rays, it was so unreliable what 100% true size actually meant. And it varied from practice to practice. And then suddenly I found I was templating for a size 6 and putting in a size 8 or a size 9, and it was unsatisfactory. So that's when I started looking for a system that allowed me to template digitally, and using this particular implant, the same company had the same system. So I started to use it and suddenly found, hey, this is actually a very effective means of doing preoperative templating in your workup. And then also you start to realize it actually offers a whole lot more. And it's that extra bit which is worth discussing. Initially, you know, I've got to admit, Andrew, it does my head in to actually look at all those figures, spinopelvic balance, lumbar lordosis, pelvic tilt. But, you know, if you start using it on every case, you start to learn over a period of time. And I would advise that it's worthwhile doing because most of the time you don't need all that information, but every now and then you're getting a patient who impinges and may dislocate posteriorly or comes close to the rim. That's the patient you may want to reconsider for either antiverting more or doing a dual mobility. So I think there's some valid reasons to use it there.
So, Rami, you make a good point there about these sorts of tools being good sort of learning and teaching tools. And if I can just, guys, if we could just go back to have the planning on the screen, and I'll run through. Okay, so here, for example, is the
wider shot, John.
See there's the preoperative picture for this left hip, and there is the current one. Right? You can see I'm going along the bottom here. You can see this is the standing view, and you can see that this is the standing pelvic tilt, and this is the standing sacral slope, and this is the flex seated view. And so you can start to get an understanding of these measurements, and so then you can go up and say, well, look, these are these numbers. Sorry, I'm up here in the summary of the spinopelvic parameters. So this patient has a supine to stand of -9, and anything that's in black is, if you like, not so much normal, but inside the parameters. Anything in red is an adverse parameter. So, for example, PIL mismatch of greater than 20 is a known risk factor. Lumbar flexion, if that was 20, that would turn red. You know, standing pelvic tilt, if that was -10, it would be red. So rather than you have to measure all these things yourself all the time, the software is doing this for you. So I think this is a really good case here, Rami, because he's got some decisions to make about how he's going to put this cup in and what articulation he's going to use. Yeah. Summary is great, a really good teaching tool here. Why don't we come back to you, Rami, and let us know where you're at.
So look, it's interesting that these lasers, right? So firstly, I've put in a pin into the iliac crest. That's not anything different to what I normally do for leg length. I've used the Tunley or the Burns device for a long time to assess leg length and offset, and I use it routinely. With the OPS system, you've got a little bit of extra added value in that it puts a laser into it that allows you to fix the position of the pelvis before the dislocation. And I kind of always wondered, if you've got a really stiff hip when you forcefully dislocate, does it move the position of the pelvis? Because before all this, I tended to take the position of the pelvis, set my arm in the same position, and basically put the acetabular component in, saying, okay, well, I know reference to the position of the patient on the table, this is about 15 or 20 degrees of anteversion. But I always questioned whether the pelvis possibly moves. So by actually putting your laser on a mark, dislocating and reassessing, you can work out if the pelvis has actually moved at the time. So I don't know if
Rami, just tell me, so you've got that in. Yeah, just tell me, where do you put that pin? You put that in the iliac crest, yeah?
Yeah, so that's in the iliac crest, approximately 3 centimetres behind the ASIS. It's a thick part of the
Can I ask you, Yizing and Craig, do you put an extra incisional pin in like that for leg length? Is that your methodology also?
Yeah, I use the IntelliJoint system. So that's 2 pins in the iliac crest and another.
Sorry, so I'll just interrupt for a minute. So there's a laser mark on the wall, and that's the position of the pelvis before we do the dislocation. So now we'll go and dislocate and then reassess whether it's moved at all following that. Sorry, you can guys keep going.
So yes.
The IntelliJoint system, it's 2 pins in the pelvis and 1 in the greater trochanter. And, it gives you an idea of the cup position, abduction angle, anteversion, and also the leg lengths.
Okay, great. And using
leg length and offset.
Are you using some sort of extra incisional, locating device, pin device using, or are you not?
Previously I did, but now I use robot. I don't have to.
Okay, surely. And just to fill the picture here, I'm using a similar technique to Rami, but I'll put that my reference pin, if you like, into the ischium, and I use that as a way of retracting the posterior capsular structures. So there's a lot of choice, but having some reference, and you'll see Rami will use that laser again shortly when he's preparing the acetabulum.
Yeah. So I've now.
All right, Rami. So let me see where you're at.
I've dislocated the femoral head, just exposing the neck there. At this point, because it's dislocated, it's just more information to you as a surgeon to put the laser back in and work out, have we changed the pelvis dramatically? And Steen, can we look at the laser? Look, there's been a bit of a change in that it's actually, if anything, it's flexed up, probably about 5 degrees, nothing too dramatic. So that just gives you a bit of information with the position of the leg in flexion, the whole pelvis has moved, okay? And that's a reference point to you if you're not actually using these sort of technologies, that you do get movement more than expected just by you manipulating the patient.
All right.
Well,
so
Rami, the screen says the stem anteversion will be 1 degree. Would you accept that? Are you satisfied with 1 degree anteversion?
On the stem?
Yeah.
So, on the stem. So when I come to broach the stem, you'll see I'll actually forcefully antevert it, probably about another 5 degrees on that.
Okay.
So do you... The starting point, that where we'll take it from there. So it's just more information for you to digest and then to come up with a solution intraoperatively.
Mm-hmm.
So using just there, so you can see if we go back to the planning page,
the Harding-Burns device.
Go back to that planning page, if that's okay. We're back on the planning page, Steve. So you can see the native version up to -3, and Rami's going to sort of change that to 1 degree. I think that's a really interesting question about, do you want to change nature too much when, if we go down here, if we put these components in,
tighten that up.
And we can run this simulator here, which shows even if we leave the stem version at 1 degree, certainly much less, there's still no impingement. So where there are some people where you actually got to change the stem version to avoid implant impingement. But in this situation, Yingxiao, it's a great question. Great question. But in fact, it's not that vital in this person for Rami to change it too much.
Yeah. I see.
All right, so there's now we can just, again, if you follow my screen, I'm going to put the femur on here, and you can see in this situation, although this person's got an imbalanced spine,
now show me
there's not much of a penalty going on here. which is good to know. Craig, what's your view on getting Rami to change the version at all?
Shimo, just interrupt for a minute. So we've got the standard cutting guide that you can use, which I've been using for years. But since I started using this system, I've gone to the PSI, and I found it actually, with the standard cutting guide, it's a question of how much or what positional alignment, particularly in a large patient, do you have it to make that necessary neck osteotomy. But with this, I find you've predetermined on the software program your level of neck osteotomy, which I believe on here on the program is about 22 millimeters. Is that correct? Yep. So this actually places it without any concern in the right position for that 22 millimeter neck osteotomy.
If we just go to the screen again, gentlemen, you can see up where my mouse is that's the planned osteotomy. And so certainly while you're getting confidence with this, you do stick your finger down with both anterior and posterior approaches to make sure that you are at the level that you're being told. And we've actually published some stuff on the accuracy of that sort of 3D printed guide. Tell me, Craig, getting you involved in this, are you using that 3D printed guide the same as Rami?
Yeah, I use the same system. Yeah, same system.
Can you give me your thoughts?
Useful. Well, just on the version thing, it's very unusual to have to change the version in the hip. Most of the plans come up without any impingement at all. And it's not that easy to change the version with the Paragon because it fits in the neck so nicely. But in this case, with Rami, I would agree. I would try and force it a few degrees rather than a bit retroverted.
Nice to know, though, that in this situation, there's no great penalty. Any impingement penalty.
Correct. It's very comforting.
So Shimo, just a look there. This is our neck resection, and you can see it fits quite nicely around the head. It's a pretty good grip. There's only one position it can go in, and it makes the cut at the right predetermined level. It's a helping hand. It doesn't have to be used, but it's an option that, like many things, you can choose to use it or not use it.
Yeah. One of the important things that Rami hasn't alluded to is not just about the height of the cut, but it's the angle of the cut. And the angle of that cut is made precisely for the stem that he's chosen to use. So as he puts the broach down, the broach has to be parallel to the cut because the cut's on a predetermined angle for the stem. Therefore, Rami's got a really good guide that he's not in varus or valgus. And again, that's another help to make sure he's getting the size right. All right. Using, tell me, the robot, what have you got there to help you, cut the neck? Does the robot help you at all with the neck cut?
Good.
Mako doesn't just give you a line. It helps you to determine the height of the neck resection. But in my practice, I found my stem NT version is quite a variable. So it's in the quite wider range of motion. Yeah.
Yes.
All of some things.
Now, Craig, I know there's several of the people watching here looking at the right hip, which Rami did last year, and because of the, I think it's about 145 degree neck shaft angle, if you like, or CCD angle in this patient, and the neck shaft angle on this implant is about 130 degrees. You've got quite a lot of the coating sitting out of the femur in that lateral area by the trochanter. Does that concern you? And are you confident that
this is a very unusual case. So in most cases, the coating sits flush with the cut on the femoral neck. But Rami was unable to do that in this case because to get the right length and to adjust for the difference in the neck angle, he set the implant up high. He's usually a slightly bigger implant. He set it up high. So I don't think it's a problem. It looks a bit unusual on the X-ray. It doesn't look like the normal X-rays, but I don't think it's a problem, and I think he's handled it well. It looks like he's lengthened the leg a little bit, but he'll even it up with this side. But otherwise, to get the length, you'd have to dramatically increase the offset, and that would be undesirable.
Yeah. Rami, could you show us, please, get as good a picture you can of the exposure of the cut neck so that we can equate what you're doing with that brooch in terms of version to what plan that we can see on the screen?
Yeah. So just a comment on the positioning of the femoral component we were just discussing. Some of that is smoke and mirrors, I got to tell you, because you know that when you're actually putting the femoral component in, you can see the calcar and you know you're fully seating that. But because of the valgus angle, if you look at the calcar implant apposition, there's bone right up to the end of the surface preparation. It's only on the trochanteric side where there's some proud surface preparation that may not be in contact with bone. But on the load-bearing side, medially, you're going to have full contact there. You just got to look closer at the x-ray. But it's always in a valgus neck. Your first impression is going to be, hello, what's going on here? Which is probably why it's a good case to show, because your standard coxa-vara, they're all routine x-rays that we see, but you've got to get used to seeing in a coxa-valga like this what the appearance afterwards will be.
Yeah.
Now, I don't know if you can see it down there. Diathermy, please.
We haven't got a great view. Rami, what I was hoping
to improve it in a minute.
Yeah. Just get that
Because
angle that you're looking
straight
at.
down at the acetabulum with the transverse acetabular ligament there. I've just got a bleeder I've got to take care of.
Yeah, sorry. I see you're on the cup there. Yeah, sorry. Just a question to Craig and to Yizing. Do you go straight to the cup, or do you prepare the femur first?
Straight to the cup. Straight to the cup.
Straight to the cup. Yizing?
I do femur first.
Yeah. Okay. I'm on your side on that one. Yeah. Okay. So Rami, caught me a bit short here. I've just got a small screen of his surgery. So Rami, can you talk to me about tactics you're getting there to get a good acetabular view?
So the acetabulum here, we can, hang on. Oh yeah, there it is. Okay. Touch. So I can see the TAL quite nicely. Mind you, with what I'm using here, it's not as critical, the TAL anymore, because we're using the level of technology that actually allows us to determine the position of the acetabular component with very fine levels of degrees for inclination and version. I've got to basically remove the whole ligamentous teres here so I can see the edges of the bone quiz. We are going to use a PSI device that will fit into that space, which you can see there. You got a good look there? You can see that.
It's pretty good. Yeah, it's pretty good.
Yeah.
So Rami's
there's the position. That's the position of the leg. Obviously, that's the transverse acetabular ligament across here. Suck there. And out. So that's the transverse acetabular ligament. There's the fossa. Now let's have a look at that device.
Yeah. So what Rami's going to put in now, guys, you can see on the plan, the optimum cup position plan here is 4219. Rami's going to put in a 3D printed guide specific to that patient where it will sit in and it will lock in. He's then going to place a laser on that.
Can you see that?
Point to a yeah, wonderfully. All right.
It's going to sit into that.
That's the practice
that we've created by taking out the fat pad and the ligament. And then once it sits in, that's going to give us a guide and tell us where the predicted version of our new cup should be in reference to the acetabulum. We don't take any of the osteophytes out. We'll leave everything as is, put that straight in. Okay, so that's the plan.
So this is without a robot, this is our the technological aid to try and achieve that 4219, and we published on the accuracy of this some 3 or 4 years ago, and I think it's 92% within 10 degrees of the patient specific target.
Okay.
Rather than Rami, where you go.
It's sitting in there. It's sitting in the fossa. It's a triflange extension, so it's got a leg on the anterior wall, a leg on the posterior wall here, a leg inferiorly, and it's just sitting in that position, telling us that's the version we should be aiming for. Now, let's zoom out a little bit.
Yeah, we get a wider view, that'd be good.
So now this is attached through a C-arm to a laser. The laser device, zoom out a bit more, please, is here. That's pointing up to the ceiling. Now we've got to find it. Unfortunately, we're using what they tell me is 1 millisieve lasers because we can't have the stronger ones because they're blind pilots, so we're not allowed. So we have to dim the lights to actually find them. But Sarah, who cooks the best chocolate cannoli, will find the light for me. You got it? Can we show that to the group? So it's now pointing towards a section of the ceiling, which we then earmark with a second laser that's sitting on the side. So flick cameras to identify that. Yep, so can you see the 2 dots there? One's my dot. That's telling me if I put the cup in that position, that is the predicted position as per the preoperative plan. And then we put a fixed laser on it. So that marks the spot. I take mine away. And that's what I'll be aiming for to get the acetabular component in. Questions?
Rami, may I ask, is the inclination and anteversion referenced to APP or just the supine? So it's a table plane. So with that software that Andrew showed you, we basically take supine CT and then standing, flex seated, and leg step up X-rays. And from that, we form a functional position for the acetabular component. So it's not a fixed position. So we know the fixed position may be 40-20 or 42-18 or whatever. And then you look at the functional position as that pelvis moves through the predicted range of motion based on those radiographs. And that way you've got an assessment that if they've got a stiffer spine, there may be negative movement that actually will impact on you and cause the risk of dislocation. If you've got a flexible spine, you can virtually put that acetabular socket wherever you like within reason. So that's why I find it's actually helpful to get that functional assessment of the acetabular component. So that's why
we could just
yeah. So that's why.
Sorry.
Oh, yeah. Please go ahead. Andrew.
You go. No, you please go ahead.
Okay, thank you. So that's why SCREAM shows supine cup anteversion, supine cup inclination. So there's no role for APP here, right?
Correct.
Well, the supine position is the position we've got the patient flat. I mean, the patient is in the lateral decubitus, but it's assessed based on them lying flat. But then ultimately, they're going to be standing, they're going to be seated, they're going to be moving. So that's why the functional assessment is also helpful.
You can see those numbers 42-19. Now we could choose to have that standing if you wish. You could have that. But this is chosen to give a supine because we're used to looking at supine post-op pictures. But you could choose whatever you wish. If we go down here to this live view where my mouse is now, Steve, could we make sure that the plan's on the screen? I have a look here at these numbers as they change. So even though the supine's 42-19, if you see here, as this patient's standing up, when he's fully standing, he's 45-26, and when he's sitting, so you've got the full functional range there. So it's kind of it's done the work for you. It's in this situation with this imbalanced spine that there hasn't been a huge sort of penalty in that there's no impingement, but you can see the functional orientation is certainly changing significantly, but not in a detrimental way. So the supine is 42-19.
So I'll cut in for a minute because I want to show you this is the beauty of this particular system to any surgeon, and that is you can do all that preoperative planning and then completely ignore it and get on with your operation here because we haven't done anything different to a standard posterior approach bar put in a couple of posts and look at some lasers to date. So now, I use an offset reamer as a routine, by the way. It just makes it easier so you don't have to have a bigger incision and takes the tension off the anterior aspects of the tissues. So I now put this in, and without looking at lasers or anything, I'll put it where I think I would normally ream for this patient. At that point, with this system, you can then put the laser on the top of your reamer, and let's take a wider view. Let's pull out and show a wider view. Bella, can you put the laser on the tip of the reamer there? Wider. Or show me the, that's it. So take it off, put it on, Bella. So this is just a fixture that goes on a standard reamer. It's got a laser on the tip. And then I can have a look. Am I anywhere near where the predicted value is? So let's take a look at the ceiling there. Steen? Ceiling shot. So what I want to show is this is where I'd normally put it. The predicted is in a little bit more extension. I can move my laser to that, but I'm not far off. And this gives me confidence, okay, in this particular patient, I'm in the ballpark, and that's where I'm going to ream, okay?
Yeah.
So back to the position.
Rami, can you just comment on how you use that picture that's on the screen at the moment, which is depicting the cup in that patient's pelvis and how it would look in the desired 42-19 orientation? Do you refer to that at this stage when you've got the reamer in, or are you just waiting to look at that afterwards? Can you talk to us about that?
When I've got the trial in, that's when I'll refer to it. So I have a look at it beforehand, and then I'll do the standard reaming until I've got the fit I expect to put a trial in. And when I'm ready to do the trial, that's when I'll have a look, and that'll give me an idea if my version matches what that picture is showing.
Craig, have you got anything to add with your experience? I mean, can you tell us about the confidence you get from the different modalities? At the moment, we've got this 3D printed guide with a laser. We've got that picture on the screen there showing the yellow cup and how it should look. What do you like in terms of how do you find, or which do you find the best value?
Yeah, I've got a lot of confidence in this OPS system, but I don't use the PSI device that goes into the acetabulum. I do use the PSI device for the neck cut, but I don't use the one that goes into the acetabulum. What I mostly refer to is the X-ray picture, and I think you've got that on a screen somewhere, of what the cup's going to look at like in the pelvis. And I look at that when I'm reaming, and certainly when I put when I'm putting the cup in. And you just look at the operation, look at the picture. You can spin the picture around 3D. The rep's always got it on an iPad, and it gives me great confidence.
So, Craig, you can't see that picture. So I'm worried that if you can see it, no one can see it. Steve, can everyone see that? So, Craig, can you see that picture or not?
No, not at the moment. Oh, I can see Rami.
I've reamed now. Shimo?
Oh, yeah, I can see that picture, yes. Exactly.
I've reamed now to a 51 millimetre, and I'm getting good traction with the 51 millimetre reamer, and that's we've kind of predicted 52. So that's
yes, we have this 52.
I'm very happy. So I'm going to trial a 52 now and see how it sits, and if it sits well enough for the cup.
All right. Rami, if you wouldn't mind, once you get the trial in, could you get a close-up view?
Yeah.
And so we can see how that view marries with that kind of predicted view that we've got on the OPS plan.
Yep, we'll do that. And the other thing is, I've got the reamer now. Before I actually hit it in, again, I can put a laser on the end of this and try to match it up with the predicted value, which means I need to antivert a little bit more, and now I'm in the ballpark. So again, that laser is helping me position more accurately, even if it's just 5 degrees, to match the predicted level. Once I'm in, that's solid. So I'm happy with that. That's the one we'll be going. Now, let's get a close-up. Zoom in here.
All right, can we get in a bit more there and have a look at that trial? Right,
let's zoom into the cup. Yeah, zoom right in here. Yep. John?
Yeah, we're getting there. We're getting there.
We're getting there.
Okay. Oh, we're getting
there.
All right.
A little bit more, John, if you can. Zoom in. Zoom in.
Yeah, good. All right. Good. Okay. So if we now look at the yellow picture on the plan and look at Rami's trial, and you can see that marries. So he's going to be pretty confident with that, yeah?
So what this does, it gives you several levels of confidence that you're basically matching what you planned before surgery, one with the laser positioning, and two with a bony prominence, or whether the cup is proud based on your trial fit.
Mm-hmm.
And it's stable. Okay, so that's what we'll be going with. Okay, so we can open 52.
Okay. So, Yijing, could I ask you with your plans that you have for the robot, did you find that useful as well? That sort of feedback you get from your predicted appearances. Do you find that reassuring and useful also?
Yeah, that's true. That's true.
Yeah. And I think, you know, if we think of
Harrison.
If we look at, you know, with dislocations and fracturing being the most common problems in hip replacements, you can see how this technology is going to help us deal with the instability side. And when Rami's doing the cup, doing the stem, we'll go back and talk about maybe how this technology is helping with stem selection, such that we can reduce the fracture rate risk associated with that. So it's not just toys for boys and girls. It's actual, you know, really trying to deal with, you know, the two largest remaining problems really, in terms of, you know, registry data saying fracture and dislocation. And in addition to that, you know, I think getting biomechanics correct must give us some optimism that we might get a bit, you know, better function as well. All right, so Rami, where are we at? We've got the real cup here. Talk to us about this cup.
So the cup's a basic hemispherical cup with a HA porous coating, 3 screws. I generally don't use screws unless there's an issue, so it's very rare to actually put a screw in. I basically spin it into the position so that the screws are posterior to superior lateral, just in case. But like I said, then we have the added benefit again of having the laser pointer, again pointing to the position on the ceiling. And again, more often than not, I have to correct the position from where I think it needs to go. So again, now I've matched the position on the ceiling by antiverting it probably another 5 degrees, and then I can put it in.
All right. Just quickly, Craig and Yijing, do you routinely use screws in a cup fixation or no? Using
almost never.
Not routine.
No.
Okay.
Yeah.
All right. Okay. Now listen, I'm going to start a discussion while Rami's doing that. You know, we've had a session on dual mobility. We've had Sebastian talk about his routine use of dual mobility in people over 75 in France. And we've got an 81-year-old lady here now, and we also have had some chats on dual mobility about, you know, risk factors with spinopelvic abnormalities, and we've got a lady here with an imbalanced spine. So we've also got a lady here who's had a perfectly successful operation on the other side with a 36 head. So Rami, can you talk to me? What are you going to do here, and how are you resisting, you know, the pressure of my conversation, I suppose, which is, you know, talking about dual mobility?
Yeah, look, I don't feel any pressure at all, actually, Andrew. I've been using fixed bearing for like 25 years. I don't have a high dislocation rate. I'm going to show 2 interesting cases in the panel of experts session on the last Saturday, just to address issues of spine. But look, in your average patient, or the majority of patients that we have, I don't believe you actually need a dual mobility cup, but that's my opinion.
Okay, that's great. That's great. And
we've actually reviewed, just to let you know, we've actually reviewed 500 patients. When we used to use 28 millimeter balls, and the dislocation rate was 0.08, so it's not big enough to justify a big change, particularly as the majority of patients I actually use C on C, whereas here I'm actually using C on P because of her age.
Sure. Okay, and now to Yijing and Craig, what articulation are you going to use here?
I'm going to use a dual mobility.
Okay, and Yijing?
So currently I'm using ceramic on poly.
Okay.
Okay, the posterior.
All right.
So Rami, so may I ask, have you ever physically marked the light spot on the ceiling or wall, or you have very good memory, you just memorize where the light spot is?
That's a very good question. Yes, it is marked by a second laser. So if we shoot up at the ceiling there, you'll see the laser mark is still there, actually. So we have
no.
sitting outside the operative field that maintains that position.
Yeah, how stupid I am.
Is not that good.
I forgot that. Yeah. So I pictured, Yeah.
Take it round.
Don't be hard on yourself, Gigi. That's fine.
Yeah. So actually, I pictured somebody had to mark the light spot.
Now we mark it with a laser. You can't paint the ceiling. It would look a bit odd.
Okay.
Bring it back a little bit and rotate a bit.
All right.
Yep. All right. Show me that calcar. That is good.
Where are we at now, mate? Where are you at now? You got the.
Now, can we see? So, Jamie, I need your camera to come in over my shoulder. You need to be able to show that. Down, down, down.
That's what we want. All right. Now, would you mind, Rami?
So this is from over my shoulder. You can see here, obviously, the trochanter here, calcar on that side. Basically, the leg is straight up and down. I'm going to base the cut's already made. I'm using
Could you just show us the calcar a bit? Could you show us the calcar a bit better? Just get something down under that so we can get that tissue out there. That's better. That's better.
You see that?
Good. All right. Yeah. So now you're looking at that. Let me go back to the stem picture for you here.
It's a very good point you make, Andrew, and that is you just said, can you show me so we can see? Now, as we go to DAAs, smaller incisions, we can't show our trainees what we're doing, and you kind of wonder how they're going to learn when they can't actually see the technique. And I've done a big incision in here. It's still hard to show you exactly what I want to show you.
All right. So, Rami, talk to me. Are you looking at that screen now on that plan? You see the profile, that middle screen. Do you look at that now before you use your cookie cutter?
So I know from that plan I need to antivert a little bit more. So, but you've got very little. This is a small femur. You can see we've templated a 2. And in fact, on the other side, I've put in a 3. So I've played around to see if a 3 will work. And I've already determined that a 3 can work if I need to. So I'm going to aim to get a 2 in. This isn't a fit and fill stem. It's whatever feels stable. So if I get a 2 broach in there and it's stable, that's what I'm going with. If not, I'm happy to go to a 3 because I've pre-templated up to that and it'll take it without putting any concern on the cortex. So we're now going to go
Can I just show? Yeah. Can I just show here on the plan, Steve? Could we go back to the plan while you're doing that? I want to show you how we can change the size. So at the moment it's a size 2. You see over here, I can change stem size here. So what I'll do is I'm going to go down a stem size. And now it's sort of early. Oh, here we go. That's wonderful, isn't it? Let's see how we go. Bear with me. Yeah, that was a bad strategy. It's a bad strategy.
Can we go to the top camera now? Top camera.
Go back to the surgery while I sort this little NDN problem out.
Good.
Thank you.
Go back to that. Grab that, just so they can see. Good. So this is a size 2. This is what we predicted. I then have a look to see if I can rock it. There's a little bit of movement, but not too much. But it's not at a level that I'm actually satisfied with. So I'm going to go to a size 3, which is the same as the other side. Just a 3. Go back to the 2. You can see there I tried to go to the 3, but it's a big jump, and usually it's the shoulder. So sometimes it's best not to force it. And that's a 2. Yeah. So that's sitting down to our osteotomy level. We can show that. Now we predicted a standard offset rather than a lateral offset. So this is a dual offset stem. We're going to put in the standard here. Come out with that.
Guys, Rami, I'm just going to do some live changes here.
Yep,
so I'm back live. So let's. I'm going to change this to a size 3. So
no, we're on a 2 now. So grab that.
Yeah, but I'm just about to sort of simulate fracturing a femur here. I've gone
don't do that.
right up to the I've gone right up to a size 6, and now you can see how I'm changing the stem size on the column on the left, and you can see how that vision is directly changing on the plan. And you can see now, Rami, what do you got in now, a 2 or a 3, sorry?
I got a 2 in there, and the 2 feels good. So I'm going to show you. Let's do a close-up of that, please, Langenbeck, please. Bigesh. Yep, got it. So I got my true acetabulum. No, we need a better shot than that. John, I need you to give us a close-up, maybe. Yeah. No, I'm not seeing the head at all here. Yeah, okay, now we're seeing it. Good. So you can appreciate there that we've got a pretty nice equatorial plane around our reduction here. And that's in the 20-20-20 position, 20 internal rotation, 20 flexion, 20 adduction. And now I'm going to assess leg length, offset, and range of motion. Come out. So you can get a wide view now. Really wide. So I'm going to take it through a range deflection beyond 90 degrees, adduction, internal rotation, up to 45 degrees and beyond, and that's very stable. So that's at 50 degrees of internal rotation. Let's come down to the reduction, to the femoral head, please. So you can see there, that's pretty, there's no anterior impingement, and it's not going to dislocate posteriorly. So at this point, you can use a DM. I have no problem with that, but I don't use a DM.
All right. So Rami, I just want to go to the impingement. I want to go to the impingement plan here. So guys on the screen, Steve, if we could share that screen, you can see there is this simulation of that trial reduction. So Rami's given us the on-table feedback, but this plan has told us and predicted that anyway. So he's got the stem in the position that he wanted. He's got the cup in the position he wanted. No impingement of bone on bone or implant on implant was predicted, and that has been sort of confirmed, if you like, with the trial reduction.
And
Rami, just let me go back.
It's telling us offset's been reproduced, but we've added about 5-6 millimeters of leg length using this Burns device. It's hard to show you,
Rami, and your plan was to measure the length of the M5. And the plan, in fact, suggested that you, with those implants, if I go back to a size 2, and we go back to a size 2, you can see that offset is in fact bang on. So you're within a millimetre. So what you've achieved now is what you set out to plan.
Correct. Now we'll dislocate the trial and we'll put the true stem in. So open the stem.
Okay, I'm just going to...
If it's correct, open it.
Craig, tell me about the stem that Rami's using.
It's a biplanar wedge, after the success of I think the first one was the Zweimiller in about 1979, and then the Karai, of course, introduced in 1986. It's a very successful design. It's fully HA coated except for the polished tip. So it's similar again to the Karai. It's got a couple of unique features. It's got some tension cut grooves on the lateral side.
Impactor.
To try and avoid the problem of trochanteric osteolysis, because those trabeculae on the lateral side of the femur load in tension rather than compression. So the reverse cut grooves are an attempt to load those trabeculae and prevent osteolysis. On the medial side, of course, they've just got the usual compression grooves. The tip is curved in, so it never impinges on the head as well. Lateral endosteal cortex, and it's polished so you don't get any ingrowth in that area. So this stem is fairly varus tolerant as well. That's why we designed it.
Good. Rami, sorry, I can't see your surgery. Is the stem in yet? I'm sorry, Rami.
No. We're about to put the
stem in. Could you show us the stem? Could you show us those features that Craig talked about?
Yeah.
Show us the lateral side. Can we see that? Yeah.
Fully coated, HA porous. It's got splines on each side, which give you really the best counter torque stability, which we've shown in RSA study, as well as step cuts in order to provide stability against subsidence. and a polished tip medialized so we don't get contact with the lateral
Can
cortex.
you show those lateral step cuts, the reverse step cuts, Rami?
Yeah, they're highlighted there.
Yeah, they are.
Yeah, good. Just again, go back to the plan while Rami's sitting in. Rami, could you show us, please, as you insert that, how the coding is parallel to the cut? We can't quite see that. I think it's a good. Are you able to show that to us?
Sorry, say again.
Could you show us, get a view with the camera there such that we can see that the coating is parallel to the angle
I'll show you that.
cut?
That's a very good point.
Yeah.
All right, so let's see. Grab that. Sorry, Bhagesh. Just don't. Now, can we go really down on that? Because this is a very important point. Can you see here? There's the bone. You can't see the coating here. I can see a mill of the coating here on the calcar side, but this coating is completely covered, but the x-ray will look just the same. And you've got bone coming all the way up, covering the full coating here. But because it's sitting above the, there's a space back
I'm with
here.
you.
Can you see that?
With you. Yeah.
Right.
I
So
understand
that's just to
it.
show you.
Absolutely.
It's something that is a radiographic phenomenon, but we know that you sync it to the line of the osteotomy.
Yeah.
And that's
Yeah. I understand. This is a unique case, but just my point being that if the coating is parallel all the way up, that cut, you know that you've got the implant down the middle, not in varus, not in valgus.
Okay,
and I think for the head, for anterior guys, that's really helpful. Okay, head's going on.
Now I've used a poly liner. I use ceramic on ceramic for everyone up to the age of 75. After that physiological age, in her, I used a poly on the other side. I use a ceramic head, which is basically a delta ceramic. This is a +0. So I use C-on-P as a routine for those over the age of 75.
Can we get the Beijing opinion on bearing surface in an 81-year-old? Would that be possible using?
I mean,
ceramic on poly.
Yep. Good.
Okay. And Craig, you've put a dual mobility in, I think, Craig. Yeah.
I would have used a dual mobility here, yeah. Just for the stability.
Again, if
dislocation
we can
rate is
zoom
0.
in there, please.
Yeah.
Anybody else? It's a very stable hip, but I just like the dislocation rate of 0.
Retractor.
Yeah. And Yijing, head size, routine head size, you 32, 36, where are you at?
Yeah, we the maximum is 36. We don't have 40 millimeters femoral head. So probably I shall use more DM.
Okay. So right, yeah. So
can you see here?
We're bringing you around.
We've just zoomed in here, Andrew, to show you the final reduction. And this is in the 20-20-20 position. So it looks like a stable reduction. And it's coapted quite nicely for combined version coming out. Do a final range of motion assessment, full flexion to 100 degrees, internal rotation to 50 degrees easy. I can't feel impingement anteriorly, and there's certainly stability. External rotation, I like it to drop about 20 degrees. Any more than that, your offset hasn't been reproduced. And then the standard shuck test to make sure that it's stable, and it is. And then we prepare for closure, which is a bony closure of the capsule and the external rotators. Feel the sciatic nerve to make sure that it's soft. And a final look with a Burns device, really just to capture that what we planned was to actually increase length by 5 to 6 millimeters, which we have, and we've increased offset probably by 2 millimeters. And that's a look at it there. Where the gillies is where we planned it. So we've got about 6 millimeters plus 2 of offset. So that kind of reproduced the plan, and there's a functionally stable hip replacement. Questions?
Rami, in the schedule, which I know that you have spent a lot of time on, you allowed yourself 1 hour for this surgery.
No, that's because I knew you'd be talking, so...
No. But I held you up by 2 minutes at the start. and you have taken exactly 1 hour. So thank you very much.
Pleasure.
We've got now 15 minutes. I am going to see if we've had a little bit of what's the word? Lack of success with the Slido.
Have you got questions from the audience, or?
I'm refreshing Slido as we speak, so bear with me. But Craig, and using while we're here still, can you tell us about your closure posteriorly? You through bone tunnels like Rami's doing, or soft tissue. What are you doing?
I attach it to the tendons, right, as close to the bone as I can, but not through the bone.
So I see Rami's making some bone holes. What about you using?
I do just as Craig do. So I don't drill holes to attach external rotators.
All right. So Rami and I are the hole drillers, and Yizing and Craig are not. All right. We saw a presentation earlier on today about it sort of augmenting the posterior structures. Sometimes when you've got, you probably more notice it posteriorly. Sometimes when you've got someone with a external rotation deformity, and you've achieved your offset that you wanted, you may have even increased it, and you've got that defect that you can't quite get your soft tissues back to the trochanter. What do you do in that scenario? Are you attracted to what we saw earlier today with that sort of augmenting with a meshes, or don't we know enough about that yet?
No. I just attach my external rotator tendons to the lower edge of gluteus medius. So I just suture them. Yeah.
Okay. And Craig, what do you do in that scenario? You just do your best effort and go home?
I just do my best effort and go home. Exactly. But I use a lot of dual mobilities, so it's not an issue because they're not going to dislocate anyway. You got a real bit of French in you, haven't you? Eh? I do. I've been converted. Yeah.
Yeah. I like them. Now tell me. Now, as we've got a couple of posterior approach guys here, and while Rami's showing up, let's talk about. This planning is giving us some big insight here. And do you? What's your routine? Bog standard post-operative orders in terms of stability precautions? Are they kind of out the window for everyone now, or do we still have some precautions? And if you do, how do you decide who gets those precautions? So maybe to Craig first.
They're out the window because as I said, I use a lot of dual mobility. So I go home, I sleep at night, I don't worry about dislocation. So I don't specify any precautions at all. They can bend forwards, they can cross their legs, sit in low chairs, use a normal toilet seat.
Okay. What about yourself?
Yeah, basically so if I have done a good job intraoperatively, so I will give no limitation about the range of motion to my patients. But until 1 month post-op, I won't encourage my patients to squat, cross leg. So I just say nothing. But when 1 month post-op, when the patient come to visit me, I will encourage each of them to squat, to cross leg. So I have pretty good results.
Okay. Craig, I want to keep provoking you.
Yes.
So we've now got some planning here. I want you to imagine here now that there's a person with a stiff spine, an imbalanced spine, and a stand to sit of 26. And it's very difficult. In fact, you cannot plan an operation to avoid bone-on-bone impingement. You've put in your dual mobility. Can I convince you that these sorts of planning strategies might give you some information to maybe show some precautions on someone or not?
Well, I've never had one dislocate, and I find this program, the OPS program, very comforting. It'll show you where you might get some impingement, but if you do get impingement, the big heads don't tend to dislocate.
Okay. Yeah. Okay. All right. No, but I think, again, we've more information is never harmful. And if you consider where we, may have been, 5-10 years ago, compared to what this sort of information we have now, we've got a lot more sort of at our fingertips.
I agree. I think this functional cup position is really very helpful and very comforting, rather than just putting the usual 42-20 every case. Well, I find it very helpful.
Look, the issue of cost always does come up, and to get these images, if we could just go back to the planning screen in a bit more full, to achieve these sorts of 3D images, you've got to have a CT scan, and that comes at a cost, and you've got more lateral X-rays, and it's whether or not these extra imaging and planning is justified, and I think that it would seem that if you are on podiums or reading journals, that some sort of enabling technology is going to be the way that we can reduce avoidable complications. So we've got to somehow manage to achieve these plans, but in an affordable way. Guys, anything else to add? Rami, you've got anything to add, like to say? It's all gone pretty smoothly, and I thank you very much.
Can I just, we haven't had the collar discussion yet. Andrew, can I ask you, are you a collar guy, non-collar guy sometimes? Eugene?
No.
Collars?
Yeah, no, nice question. Look, yeah. No, it's good. The collar pushing just came up, earlier. I'm a non-collared guy. I'm confused by the collar guy, collar argument, because we were led to believe, certainly with the Karai stem, that it was a stem that didn't have any problems anyway. And so we've then changed it to a collared variety for some reason, which I'm yet to understand. I could justify a use of a collar if I had to use a cementless fixation, say for a femoral fracture, if a cemented stem fell on the floor, and I had to use a cementless stem, I can see the benefit of using a collar in a type C femur. I can pay that, but in general, no, I'm not. What about Yizing? Where's Yizing on that, and where are you on that, Craig?
No, I don't use any collared stem. I don't think it's necessary. So even there's number shoes with a collar, the survivorship is a slightly higher than a non-collared stem. But in our practice, we haven't seen that.
Craig, where's the argument for the collar coming from?
Well, it comes from Annecy, because when you go to Annecy and you do the Karai course, you notice they're all using collars, and you ask them, why do you use a collar? And they say, because it doesn't hurt. There's no downside. So I came back and I started using a few collars, and I have to say that it definitely does prevent any subsidence in type C type femurs. And so it's kind of comforting in those type of femurs. In 90% of cases, it's not necessary, but there's the odd case, door type C femur, or let's say a situation where you put a 5 broach down, and you think, okay, I'll go to it's not quite super tight, and you think I'll put a 6 down, but you only get it 3/4 of the way down, and you are worried you're going to fracture, so you have to go back to a 5. In that situation, a collar is very comforting, and they don't.
And I think, Craig, no, I think you've hit on something there. In those stem designs, those Karai types, there can be a significant jump in dimensions from certain sizes, and you can get stuck. And I can imagine that's where the collared arguments come from that scenario where you've got to go back a size because you can't. Yeah, as you said, you can't get. That's.
You can pack a little bit of bone around it, but having a collar is very comforting. You just know that you're not going to have somebody walk in 6 weeks with a centimetre ligament discrepancy that you didn't have on the table.
Hey, Shimo, I've unscrubbed. Can you hear me?
Yes, can. I can.
Any questions from our audiences at all?
No, look, I have Slido in action, and I'm going to be so embarrassed if I've done it wrong. But I'm in the hip auditorium, and I've refreshed a question and answer. So please, if you're out there and you have asked a question, it's not that we haven't been trying. So no is the answer.
Okay, all right.
Look, I think we're pretty good. Rami, you were too efficient.
The last thing I guess I want to say is this is a good way to transition into technology because you don't have to use the full gamut of the information provided to you. It's a good way to do some digital templating. It's a good way to use some intra-operative devices to optimize positioning of particularly the cup. It's a good way to decrease your risk of not getting the right version. We know Luinex information is only partly useful. This optimizes by bringing in functional positioning of the acetabulum. And I think if you want to do something a little bit extra for your patients, then this is a good platform really to step into something that has a high level of technology input to hip arthroplasty.
Yeah, I just add to that too, Rami and Craig, and using. I show these planning to patients just prior to their surgery, and they do get a great deal of confidence out of seeing that this amount of strategy has gone on, and to see how, you know, there are a lot of choices that we have and how we make them, and to see that there's some sort of, you know, some science going into what we're doing. So that's another thing to help, help patients get confidence in what you're doing.
That's a good idea. I haven't showed them the patients yet, but it's a good idea.
No, they do like it, Craig, and it does require a bit of organising to have, and even if the timing's not right, then you can show them maybe a plan, a generic plan.
Yeah.
And when they ask about cementless, when they ask about bearing surfaces and surgical approaches, there's a whole lot of stuff that this can help you discuss it with them. Now, we've been given the wind up. Rami, could I say thank you to you? Could I congratulate you? It's incredibly difficult to do what you've just done. You got to concentrate on doing the case. You did a marvellous job. Thank you, Craig.
Thanks, guys. Thanks for the backup.
Thank you, Rami.
Thanks all.
Bye bye.
Thanks, guys. Good job.
Bye bye. Bye bye.
See you guys.
Good afternoon, good morning, and welcome to everybody for a afternoon session on difficult primary hip replacements. My name is Dermot Colopy. I'm a hip and knee surgeon here in Perth, Western Australia. My co-moderator is Sebastian Lustig, a hip surgeon specialist from Lyon in France. We have a panel of 5 surgeons from China, from Korea, from Japan, and from India, who are going to share their insights into techniques and avoiding complications, difficult primary hip replacement. We have 5 surgeons, as I said. I have a good friend, Rajiv Sharma from Delhi. I have Professor Yunsu Park from Seoul, Korea. I have Dr. Yunsu Chen from Shanghai, followed by Professor Sugimoto from Tokyo, and lastly, Dr. Maria from Delhi, who will talk for us. So the talks will roll in sequence, and we will take questions at the end of the 5 talks, if that's satisfactory. Please use your poll app, the Slido app, to direct questions to us, and we'll try to answer them at the end for you. So can I introduce Rajiv Sharma? Rajiv?
Good evening, friends. Thanks, Rami and Nico, for the invite to this exciting virtual meeting. I'll be speaking on performing a successful hip arthroplasty. A successful hip arthroplasty is a surgery with a well-placed components, well-fixed components, and looking after all the preoperative issues of the patient. What is to be seen in a preoperative X-ray is the acetabular evaluation, the femoral evaluation, pelvic obliquity, limb length discrepancy, and also if there is any unusual finding in the preoperative X-ray, like you see here in this patient, the vascular markings are looking calcified. The acetabular evaluation, the margins to be seen, peripheral osteophytes to be seen, whether any protrusion in the acetabulum, cyst, or any dysplasia present. In the femoral evaluation, you must see that what is going to be the neck cut level, what is going to be the canal diameter, especially the farthest point of the femoral canal, distance of the narrowest part of the canal from the tip of the trochanter, the horizontal offset and the vertical offset to be seen, femoral bowing or any other deformity of the bone. Templating and evaluation is important, the acetabular cup position and the size of the component, similarly for the femur. The cup position is usually about 45 degree or 40 degree of abduction and around 30 degree of anteversion in most of my patients. The influence of components on dislocation, the anteversion is one of the most important factor. The important assessment of the patient should be the spine assessment, the femoral bowing by using a large film of the patient, any osteoarthritis of the same side or the opposite side. The position of the patient on the table is important. Secured stabilization of the pelvis, abduction should be possible, adduction should be possible, posterior support on the sacrum and anterior support on the pubic bone should be there. It should be so stable that during the surgery, patient position should not be moved. The draping should be impermeable. Perineal area should be protected well. Whole of the lower limb should be prepared well. The gluteal bursa is important because the gluteal bursitis could be an important issue post-operative. The exposure, I usually take the posterior exposure around 10 centimeter incision. It is a very easy approach and it's an extensile approach. You cut the gluteal bursa and then the rotators and the capsule to be cut in one line. In the same line, the gluteus maximus tendon should be having a stitch suture and it should be sutured back at the end of the surgery. By this, you see that the dislocation of the femoral head is very easy and without any problem, even in a very, very osteoporotic bone. The measurement of the vertical and horizontal offset is very important. One must see making the 3 holes at the trochanter, at the lesser trochanter, and at the center of the femoral head. Use the cautery to measure, and this is the most accurate measurement to assess the offset of the patient per operative. The neck cut, I usually take the trial implant and make a marking on the neck and cutting the neck, taking care that I don't damage the trochanter and I don't damage possibly the sciatic nerve posteriorly. The acetabular exposure is very, very important. One pin on the superior part of the acetabulum, one Homans retractor on the anterior superior part of the acetabulum, which is the strongest part, and one just below the TL. And the positioning of the pin is the most important thing, and one must be careful that the pin is not palpable into the acetabular cavity. The reaming of the acetabulum should be started after you remove the osteophytes. Start with the small reamer, ream medial wall first, then use the progressive reamers to ream periphery, ream up to 2 millimeter less than the size of the cup in a porotic bone and 1 millimeter less in a stronger bone. Final reaming and cup placement is also very important. One must see that reaming should expose the cancellous bone. One must increase the size of the acetabular reamers from the small to the bigger size. One must not over-ream a thin wall, and one must assess before surgery whether the anterior wall is thin or the medial wall is thin. And then if the middle wall is thin, you can use the cancellous bone. Do the reverse reamer and fix this cancellous graft, and then after impact the final cup. The cup impaction should be done strongly. One must take care that you are not damaging the pelvic bone, causing a fracture, but it should be held very strongly into the host bone, and one must be able to rock the cup little bit, and it should not wobble in the cavity, and it should be parallel to the transverse ligament. And if you do that, then it is very easy to fix it well and have a well-positioned cup, which will not move and which will also help us giving the immediate post-operative weight bearing to the patient. I normally use the 2 screws, one 25 millimeter and other around 30 millimeter size. 2 long screws should be avoided, and one must ensure that the cup position is seen carefully and assessed well, especially in relation to the TL. Osteophyte removal is important to avoid the impinging. I usually use the high-speed burr for this purpose. Femoral canal preparation should start from the cleaning of the piriformis fossa, cut extra neck if you need to. Use a starter reamer to gain lateral entry into the canal to avoid the varus. The canal and the trochanteric area geometry is very important. As you see in these three representative X-rays, the canal where the entry is going to be, you must be able to assess even before surgery. How much implant should sink in is very important to be seen, and the same should be replicated in the final implantation. The coverage of the femoral head should be seen with the idea of looking at the combined anteversion. The soft tissue tension is important to be seen. That the tension is not the tension is not too much, and also that hip should not be lax, while at the same time maintain the horizontal and the vertical offset. Capsule and the rotator's closure is very important, especially in the posterior approach. And if it is sutured back to the bone, it usually gives very good postoperative results and reasonable security to the mobilization of the patient. The function of the gluteus medius usually is very good, as you see here. The patient is able to walk on the second day of the surgery, usually with some amount of the support, and which patient can leave as per his own capacity, physical capacity, in about 15 days time to 3 weeks time. A good planning and execution usually gives a good result. That's what you see here, the bilateral osteoarthritis and the patient walking well with well-positioned cups, ceramic and poly in a young patient of around 26 years. Achieving a satisfying result is not difficult. Having the meticulous preoperative workup, correct component positioning, correct component fixation, and correct soft tissue tensioning, and of course, uncompromising aseptic precautions. Thanks so much.
Good afternoon, ladies and gentlemen. My name is Yoon-Soo Park from Seoul, South Korea. This is my disclosure. I would like to focus on higher degree DDH. In higher degree DDH, we see difficulties in identification and preparation of true acetabulum and in preparation of narrow deformed femoral canal, and also in reduction of dislocated hip. And achieving optimal fixation of implant is difficult, and there is a high risk of complications. For acetabulum reconstruction, we have to consider false acetabulum and shallow true acetabulum with deficient bony structures. For adequate acetabulum support, 70% of cup should be covered with intact host bone. Optional methods are deeper reaming and use of small-sized cup, augmentation with bone graft, placing cup at high hip center, control medialization, reinforcement rings or oblong sockets. We can use resected femoral head to support uncovered bare area at dome, and this makes bone bed for further revision. This patient is 34-year-old female with Crow type 3, and I did an autograft at dome defect with 2 screws. Post of 11 years, graft was well incorporated, and stem and cup look solid. Crow types are widely accepted classification in acetable dysplasia. Type 1, less than 50%, 2, 50 to 75%, 3, 75 to 100, 4 is more than 100% dislocation. Another classification is Orthopaedic classification. Type A minimal, type B moderate, type C is severe. For reduction of femoral head to true acetabulum, usually there is no need for shortening in crow type 2 and 3, but in crow type 4, there can be some options like a resection more bone from proximal femur with greater trochanteric osteotomy. Number 2 is a subtrochanteric shortening osteotomy and distal femoral shortening osteotomy or iliofemoral distraction in two-stage procedures. This patient is 64-old female, shows crow type 4 DDH with more than 6 centimeters of shortening, so I did 2 centimeters transverse shortening osteotomy at subtrochanteric level. Post of 11 years shows solid union of osteotomy and firm fixation of cup and astrum stem. Considered points of femoral reconstructions are increased femoral anteversion, narrow canal diameter, and associated severe coxa vera or valga, deformity due to previous surgeries. If there is associated increase in femoral anteversion, we may correct by using modular femoral stem, but if there is more than 40 degrees of anteversion, corrective rotational osteotomy is sometimes necessary. For narrow canal, especially in Asian patient, smallest stem is still too narrow for stem insertion. In this situation, expansion osteotomy is sometimes necessary with or without shortening osteotomy. This patient is 57-year-old female with bilateral crow type 4 DDH, showed extremely narrow canal, so I did etiotype expansion as well as shortening osteotomy at proximal femur with use of astrum stem. Post of 4-year X-ray shows solid union and firm fixation of cup and stem. If there is associated coxa vera or valga, especially due to previous surgeries, we need corrective angular osteotomy. This 34-year-old female was operated 10 years ago in Russia with valgus stabilizing osteotomy and iliacal lengthening. Apparent leg length was same in long bone scanogram. So I did 4.5 centimeter shortening as well as 35-degree variation osteotomy at maximal angular deformity area. On the CM control, I could fix astral modular stem, but it was very difficult due to obliterated femoral canal at diaphysis. Post-op 3-year X-ray shows well-fixed stem and cup with solid union of femoral osteotomy. We reported the result of subtroch shortening osteotomy in higher degree dysplasia in DDH and compared with pathologic dislocation cases in childhood hip infection. From 96 to 2013, 60 hips were done with subtroch shortening osteotomy, followed with average 12.3 years. Left side is dislocated septic hip, right side is DDH, and we compare the results of shortening osteotomy in both groups. Among 66 hips, 25 hips in each group were matched according to age, gender, BMI, and LLD. Post-op hip score, correction in leg length discrepancy were better in DDH group, and we see more stem substance in infection group, and time for union was longer in infection group as well. For complications, reoperation rate was higher in infection group with additional fixation of osteotomy and more stem revision. Implant survival at 10 years was higher in DDH group. In acetabular reconstruction in DDH, identification and preparation of true acetabulum is important. I think deeper reaming and use of a small-sized cup is a recommended procedure. For high hip dislocation, subtroch shortening osteotomy is a recommendable procedure, and if there is associated femoral deformity, sometimes we need corrective osteotomy. Thanks for your attention.
Hello, everybody. I'm Yunsu Chen from Shanghai Jiaotong University, number 6 People's Hospital. Today, I will talk about the sliding trochanter osteotomy in crowd 4 DDH in total hip arthroplasty. For the total hip arthroplasty for the crowd 4 DDH patient, there is 3 goals. First, we should reconstruct a painless, stable hip. The second, we should balance the leg length. And the third, we should improve the low back pain and knee pain. And there is a very important goal, which is balance the leg length. Unfortunately, there are still no consensus on correction of leg length inequity. This is the crowd A1A type, which is unilateral crowd 4 DDH, no pelvic oblique, no spine compensation. And the strategy of leg length balancing for this type, which is we put the cup in the true acetabulum and try to avoid shortening osteotomy unless there is bony leg length discrepancy. If shortening osteotomy is unavoidable, for example, we cannot reduce the hip, we try to shorten as less as possible. For type 1B, that means unilateral crowd 4 DDH with pelvic oblique, but with flexible spine. For this kind of type, we put the cup in true acetabulum. We try to avoid shortening osteotomy unless there is bony leg length. We should enhance the gait exercise. Patient will feel leg length discrepancy in the early period, but will get normal gait with spine compensation. So we can see there is the spine compensation for this kind of patient. And the 1C type, that means unilateral crowd 4 DDH with pelvic oblique fixed and restricted spine flexibility. That means with lower spine degeneration, very severe degeneration. And for this kind of type, we put the cup into acetabulum and leg length balancing with functional leg length discrepancy and not anatomic leg length discrepancy. So we should do shortening osteotomy according to the functional leg length discrepancy. So when we need shortening osteotomy, first, type A or type B, if we cannot reduce the total hip, we need shortening osteotomy, although we make the leg length discrepancy. 2, bony leg length discrepancy. We should shorten the femur to get equal lower limb length. And type C, we should shorten the osteotomy to obtain equal functional leg length. And how to do the shortening osteotomy? The most commonly used shortening osteotomy is subtrochanter shortening osteotomy. There are different techniques. We can do the transverse osteotomy, we can do the step cut, also we can do the oblique cut. So the most commonly used is the transverse subtrochanter osteotomy combined with the S-ROM stem. So we can see after 1 year, the bone union is very good. The advantage of this kind of shortening osteotomy is it can adjust the femur inversion with the S-ROM, also with the bone cut. Number 2, we can make multiple cutting during the operation until we can reduce the hip. And according to the literature, these have a very good clinical reports. But there are some disadvantages of this technique, which is very important as non-union. According to the literature, the incidence of non-union at the osteotomy site range from 0 to 22, highly to the 22%. So when we use this kind of technique, distal stability is fundamental. For example, this is a high dislocated hip. The surgeon do the osteotomy, but after 1 year, got non-union and the stem is loose. When we look back, we can see there are fracture at the distal part. That's because of we cannot make the stable distal part. That means the non-union and the loose stem. For overcome this kind of shortcoming, we decide to use another technique to do the shortening osteotomy, which is sliding trochanter osteotomy. This is the illustration of this kind of technique. We usually will slide great trochanter combined with the gluteus medius and adductus. This is the sliding trochanter osteotomy. We can see when we slide the great trochanter, we can put the stem very easily in, and we can use the Wagner cone to adjust the anteversion as we want. And after reduction of the hip, then we reduce the great trochanter with cables. This make us reduce the hip very easy. And because the cone, we only need 3 centimeters to do the distal fixation, and can very easily to get the primary stability. So this is an example. This is a female, 35 years old, high dislocate. When we do the sliding great trochanter osteotomy and get a good result. There is another patient, 55 years, female, 55 years old, high dislocated. And we also do the great trochanter. When we reduce the hip, we found it is not very easy, but when we reduce it, patient will get very good normal gait. This is 6 months post-operative and got very good union of the great trochanter. So this is our clinical data from January 2017 to December 2018. 31 crowd 4 DDH THA with sliding trochanter osteotomy. We have 5 males, 26 female, average age is 55. Pre-operative leg length discrepancy is about 45 millimeters, and average intraoperative shortening about 2 centimeters. Hip score rise from pre-operative 35 to post-op 84. So there is one union of great trochanter osteotomy with no reoperation needed. So take home message. There is still no consensus on leg length disbalancing in total hip arthroplasty for crowd 4 DDH. Patients should be informed about lower leg length discrepancy after total hip arthroplasty. Most patients will suffer from leg length discrepancy for a long time, whatever with or without shortening osteotomy. Balanced gait can be achieved after at least 1 year. Strategy, according to our classification, is helpful to get a balanced gait after total hip for crowd 4 DDH. Transverse shortening osteotomy with S-ROM is a simple and effective way in total hip arthroplasty for high dislocated DDH. Distal stability is fundamental when you use this kind of technique. Additional plating may be helpful. Sliding trochanter osteotomy may be an option. Our early result is satisfactory. Thank you for your attention.
The incidence of shoe tumor after large diameter head metal-on-metal total hip arthroplasty in Japanese patients. Introduction. 1995, Muir reported on the improvement of these bearing over the existing metal-on-polyethylene articulations, which demonstrated more rapid wear together with granulomas, foreign body reactions, damage of periarticular bony and soft tissue, and associated expansor pulsar muscles. He suggested that Adequate lubrication together with improved material propeller and manufacturing technologies would bring to the market a superior device with greater longevity. Total hip arthroplasty using metal-on-metal articulation were introduced with expectation of improvement, wear rate, longevity, and reduced risk of dislocation by means of large metal head. However, adverse reaction to the metallic debris and aseptic lymphocyte-dominated vasculitis-associated lesions, ALBA, and shoe tumor have been reported in the large diameter metal-on-metal altercations. Unfortunately, several patients have fluid collection or shoe tumors after large diameter head metal-on-metal hip in a hospital. We wish to present our experience with a modern version of a metal-metal bearing, material and method. The performance well from 2008 to 2012. The patients were 139 patients, 21 males and 118 females. The head size is from 42 to 46 millimeters. Stem is ankle fit and profemorsy. All the standard titanium aluminum alloy and all the modular necks. A stable component is the console plus cobalt chrome. Plain X-ray and plain CT findings, we can find out the shoe tumor. MRI and enhanced tomosynthesis find out the mass. Patient with complaints of groin pain and or swelling or hip instability underwent MRI examination in order to detect the presence of fluid collections or soft tissue mass. Left figure, the white area, the fluid collection. Right figured, the mass is the muscular necrosis. The statistical collection between abnormal findings on MRI and age, gender, duration of post-surgery, head diameter, and component position was performed. Result: 34 hips in 30 patients. Average is 21.3%. We revised 5 hips in 5 patients due to any complaints. All cases had corrosions at any modular junctions. Statistical analysis show tumor group versus control group. Age, gender, head diameter, cup inclination, cup anteversion, stem anteversion, stem offset, the almost same. Duration from the time for implantation, they're quite different. We revised stem and cup preservation and just only Hori and head device. Using the active articulation dual mobility total hip arthroplasty. The ceramic helps detect the metal, and Hori, big head Hori, help to gain the stability. We can find out the corrosion all the cases at the both of head neck and neck stick junction. This shows the motion study. Neck head is slightly moved and twisting and squeaking. Conclusion. Our study failed to find statistically different outcomes between males and females with regard to the incidence of shoe tumor following implantation of a large diameter head metal hips. It's important to emphasize that the appearance of symptoms and development of a shoe tumor occurs early after metal hip in some patients. It may represent hypersensitivity to metal material implanted. In this regard, our study suffers from the limitation that serum metal ion level were not obtained from the symptomatic patients. It will be necessary to subject all patients to MRI examinations to evaluate the possibility of silent fluid collection and shoe tumors. After 4 years, alveolar fluid findings is calming down. But be careful about adaptive loosening around the cup will appear. Thank you for your attention.
Hello, friends. It's a pleasure to be speaking at this meeting about instability after primary hip replacement. Instability is one of the most embarrassing situations which a surgeon can come across in his practice. And the best way to avoid it is to realize how not to let it happen. It's a huge problem in primary knees, reported from 0.03 to 10% and up to 28% in revision hip replacements. And of the revisions, 1/3 can lead to instability. It has been classified as early instability, which happens within the first 6 months, causes including old age, cognitive impairment, muscular laxity, fractures, rheumatoid arthritis. Intermediate from 6 months to 5 years, and late more than 5 years, which is usually due to polywear, loss of muscle mass, neurological impairments, trochanteric avulsion fractures, residual component malposition, prosthesis bone impingement. Early dislocations, that is within 3 months of the surgery, assuming the components are well positioned, respond well to manipulation and appropriate immobilization with 60 to 70% success. And in late recurrent or recurrent dislocations, you will usually require operative solutions, which again have 60 to 70% success. Patient factors include abductor insufficiency, previous infections, multiple operations, and neurological impairment. The surgical approaches, there have been a lot of debate that one approach is more prone to dislocation than the other, but with better technique, I think this is a personal choice and debatable. Surgical factors such as soft tissue tension, influences of the joint capsule, external rotations, and gluteal muscles, which should be put back properly after the surgery is completed. The components must be positioned appropriately and get proper leg length and offset. And surgeon has to get proper soft tissue tension to avoid these unstable hips. And patients who dislocate have a notable loss of offset as compared to stable hips. Have a look at this particular X-ray and it will show you a poorly positioned acetabular component and poor offsets. When you malposition the acetabulism, acetabulum, or there is excessive anteversion, it can lead to anterior dislocation, retroversion leading to posterior, and if it is abducted, it leads to lateral dislocation. So must try and get into the safe zone. For the femoral side, malpositioning of femoral components is most important cause of instability, and the head size is so important today. Larger head have a higher jump distance, and now they dislocate less. Femoral offset, neck design, and geometry all play a role in stability of the total hip arthroplasty. Prosthetic design can be very useful, and lower dislocation rates are observed with elevated rim liners in situations of revision hip replacements. If one has had one or two dislocations, there is always a reason for trying out reduction and bracing. But if you have such terrible positioning of the socket, there is no point, might as well consider revision straight away. Surgery, we said, is helpful in 60 to 70% cases, and you must prepare yourself and the patient for further difficulties. The prerequisites, you need to establish the cause of the problem if you don't want it to be repeated, and you must have clear aims and clear surgical planning. The principles are to correct malposition, correct soft tissue tension, address the impingement and constraint. Component revision when the component is in a position like the one you're seeing in this particular situation. Component revision can also, when there is subtle malposition, you can use a CT scan to see what is wrong and address the problem. The component revision also can be checked for intraoperative inspection. Acetabular, you must look for the abduction and version angles. Femoral anteversion, 15 to 20 degrees is ideal with proper offset, and combined anteversion, which is often spoken of, should be 40 to 45 degrees. Modular component exchange, a lot has been spoken about, and that can be done when you have used a component and you only want to change one particular part and not the actual properly implanted socket. Larger femoral heads, we have already said, but the problem can be when you use larger heads, you use thinner polys, and there is a debate on, for in spite of higher quality of poly, that there will be wearing out quicker. Dual mobility cups, a lot of excitement with these, and they seem to be reporting a lot of reduction in dislocation rates and instability rates, going down to less than 1%. Constrained liners have been tried in difficult situations and where the dislocation is secondary to soft tissue deficiency. But there have been situations where these have come out and they have actually again dislocated out of the constraint. Soft tissue retensioning is important at times when you open, and you can advance also the trochanter to get proper soft tissue tensioning if the components are properly positioned. Sometimes there are scars or there are bone cement pieces which can come in the way, and these should be held and removed from the neck area so that these do not impinge and do not lead to dislocation. At the same time, when there is rupture of soft tissue, a repair at the site of the capsule, piriformis and conjoint tendon is very helpful to prevent dislocation, provided everything is in proper position. Trochanteric advancement is very helpful if there is laxity in the abductor mechanism. And please note, revision surgery itself can cause instability. Results are optimum when precise cause of instability is found and appropriate measures are applied. Operate only if the problem can be solved for sure, the patient is compliant and patient is fit. So the take-home message is anticipate the problem in high-risk primary total hip arthroplasty. Prevention is better than cure. Non-operative technique in early dislocation. Most importantly, identify the cause before you go into revise. Thank you very much.
Yeah, we had 5 fantastic talks, and now we have very limited time for discussions. But we have some quick burning questions for our great faculty. I will start with Dr. Park. Fantastic talk about DDH management, questions regarding how do you ensure tight distal fixation? Do you under-rim? Do you have other tips? And question number 2, do you use sometime anti-rotation locking plates? Because you haven't seen any in your examples.
Yeah, very good question. As Dr. Chen already stated, the distal stability first from stem is sometimes a problem. So I saw in that situation in about 10%, I think. And in that situation, I routinely do the ribbon graft from resected diaphysis, about 3 centimeter, 2 centimeter. It's resected in half, and it's ribbon grafted at the transverse osteotomy site, and rigidly one cable is fixed. But that is very unstable. I do the plating, 4-hole plate, if distal stem is too loose. My routine practice to get the more stability is a ribbon graft around osteotomy site.
Thank you.
Okay.
Dr. Chen, very good talk, and again with tips on the subtrochanteric osteotomy, but you also commented on your sliding trochanteric osteotomy. What tips have you got for us for how to fix the trochanteric osteotomy? Because trochanteric non-union, trochanteric escape is a problem for us when we do revisions. How do you avoid that? Is Dr. Chen there? Dr. Chen actually may not be there. So can I ask a question of Professor Sugimoto then? Professor Sugimoto, your stems with the modular neck, did you take the stem out? Did you do a stem revision when you did your revision for LVAL?
Yeah, and it's a good question. So we started to all revise the cup and stem, but in the shoe tumor cases, we can't find out loose about the stem. So, and the Profima, the very, so, and bone ingrowth is so very difficult to pull out the stem. So I retaining the stem, and if I revise the stem using the SROM and the Coride system, is better for us.
Okay, thank you. Yeah. We are out of time. Sorry, Seb, go.
Yeah, no, thanks a lot. It was a fantastic session, really difficult topics, fantastic talks. But yeah, for the matter of time, we have to jump in the next session. Thanks to all. It was great. And now it's the place for the hip session about infection. Enjoy the day.
you. Amjad, did you want to head off?
Yeah, Noam, why are you dealing? Noam?
Yeah, hi, good evening.
Yeah. Hi, good evening. Yeah, start presenting. I have just called you. Yeah, start. Your time is passing out. Hello?
Is it not? Is the recording not on?
Yeah, you were the first one to speak.
I'm going to talk about the optimal treatment for acute hip PGI in light of contemporary evidence. I have no disclosures. So acute hip PGI is a real problem occurring in about 0.3 to 3% of the people undergoing joint replacement, and with increase in joint replacements that we are seeing in recent years, we are expecting the PGI rates to increase as well, with an anticipated $1.8 billion being paid annually for treating these complications. So when talking about the optimal treatment for acute PGI, really we're talking about, do we do an IND or do we go ahead and replace everything that's in there, whether in a single or two-stage fashion. And we're taught for years that the choice of treatment is based on the time, because we know that the longer we wait, the more chance biofilm is going to be present and that acute IND is going to fail. But what is acute irrigation and debridement? Is it for people undergoing surgery after 1 week, 4 weeks, 12 weeks? Where do we cut the line? And really, if you look at the fact, 30 to 80% of the people fail after IND when it is performed, even within a 12-week period. So who do you do it to? How do you choose? One would say, no, I don't care. I would do it to everyone just because it's a much less painful operation, both the surgeon and the patient. But recent evidence shows consistently that if you do an IND and fail, your chances to fail with a two-stage later on is higher. And by the way, that's with a different kind of bacteria many times. So really, should we focus more on other factors than time? This is a microscopic view of the bone 3 days after an infection with MRSA. You can see in yellow how MRSA is deep into the canaliculi of the bone, not allowing the immune response system that you see here in red to come close to it. So obviously an IND for this patient would fail. And the community has realized this, and a lot of studies have been performed to identify risk factors associated with complications. One of them recent from our institution, and we saw that there are several factors that really increase the risk for failure after acute irrigation and debridement. We saw that acute hematologenous infections failed 2 times higher compared to acute infections. We also saw the same trend with revision surgery compared to primary. Obviously, we saw that the more the patient is sicker, his chances to failure are higher, especially if he has diabetes, COPD, or malignancy. We also saw that patients that come in a more septic fashion tend to fail in a higher rate. In terms of organisms, we saw that organisms that are antibiotic resistant or polymicrobial infections tend to fail more as well. And this is an interesting finding. We looked at if time is associated with failure, and we saw no association if patient is treated earlier compared to later within that 12-week period of time. And this question was raised in the recent international consensus meeting, asking what is the recommended time interval to divide between acute and chronic PJIs, because that's going to obviously influence the treatment. And I quote the recommendation: we recommend moving away from the traditional division between acute and chronic infections based only on time. PJI is a continuum that leads to an establishment of biofilm. And this question really was discussed for a long period of time. And the conclusion was, when choosing a treatment for acute irrigation and debridement or acute infections, you need to look at host factors, operative factors and organism profile more than the actual time from surgery itself. So what do you do with that? How do you translate that to clinical practice? There are some classifications out there, like the crime AD and the click score, that can guide treatment. But really recent developments in machine learning and artificial intelligence has brought us to look at this in a different way. And we published this recently, and this won the Hip Society Award. We did a multi-center international study in over 30 centers around the world. And we had over 1,000 patients, and we developed an algorithm to help us predict who's going to fail following irrigation debridement. We saw similar risk factors, as I showed before, that are associated with failure. And interestingly, we also saw something that has been shown in recent years. If you do not exchange the polyethylene when you do a hip replacement or hip revision and acute IND, your chances to fail are much higher. So I urge you to exchange the polyethylene in any patient you do an IND on. So the algorithm performed very nicely. You can see here that patients, like the algorithm said that will fail with 90% chance. They actually failed in 90% of the cases. This is very promising, and we developed an app and we inserted it in the ICM Philly app, which is free of charge. You can go in and use it at any time you want. This could help you in your clinical practice. This is an example of a patient with a low risk, and it shows how the successive treatment changes if a surgeon does an exchange of the polyethylene compared to not. And that's one field that we have seen a lot of developments. The other field is actually within the antibiotic treatment, which we tend to neglect. And one of the main questions that we didn't have an answer for many years is how long do we need to treat patients with antibiotics after surgery? And based on consensus meeting, this was set as a minimum of 6 weeks, but really like a few months ago, published article in New England Journal of Medicine should change our practice and really make a difference. They looked at patients that are treated with antibiotics for 6 and 12 weeks in a randomized controlled trial, including over 20 centers in France, and investigated the results. And you can see here that 40% of the people were undergoing debridement and implant retention. And looking at the results, you can see a 2 times higher rate of failure for patients treated for 6 weeks compared to 12 weeks. So this also should urge us to treat patients with antibiotics for at least 12 weeks after irrigation and debridement, and a major development in that field as well. Questions that need to be answered, and hopefully will be in the next coming years, is first of all, do we need to wait with irrigation and debridement until we have an organism isolated? I'm not sure we're going to find an answer for that. In the meantime, we should settle with this consensus meeting recommendation that there should be performed as soon as possible. Another major question that I think is going to be answered in the next few years is what's the optimal irrigation solution to treat acute PJIs. Currently, we have no good evidence to suggest one over the other. And finally, and especially relevant to hip PJIs, is do we perform a 1-stage or a 2-stage revision? It is very tempting to, in light of the high rates of failure with irrigation debridement reaching sometimes 70%, to just say, especially for the cementless hips, it's a single stage. It shouldn't be hard to do, and probably will success in a higher rate. But unfortunately, there is no good evidence to make this recommendation. And the only study looking into this was 10 years ago, showing promising results. And I hope this talk and these recent developments would urge researchers to look on whether a one-stage replacement will lead to better success in both compared to a two-stage and irrigation debridement. Thank you. Appreciate your time and listening.
Challenges of PJI infections management in limited resource setting. Increasing lifetime expectancy will result in increasing active elderly population. There will be a rise in the number of primary and revision arthroplasty. And the longer indwelling prosthetic time is associated with a higher cumulative risk for infections. Although the number of PJI in both primary and revision arthroplasty might appear small, there is an increasing trend in PJI, and this is a devastating complication. PJI itself is a complex interaction of microorganism, host, and implanted prosthesis. Things become more complicated when biofilm, host immune systems, TTT microorganisms, and so on are involved. The treatment of PJI requires complex strategies both in diagnosis and treatment. The ideal treatment strategies involve multidisciplinary team, proper diagnostic tool, optimum antimicrobial therapy, and surgical management. Here are some of the studies showing the outcome of PJI, whether it's there, one stage or two stages, with eradication rate of more than 80%. However, the reported studies came from tertiary hospital with full-fledged capacity to diagnose and treat PJI. But not all hospitals are well equipped with the state-of-the-art diagnostic tool and treatment capacity. This outcome came from the limited resource hospital are usually unreported. And the current research usually focuses on the challenge to find a newer method for diagnosis, antimicrobial therapy, and surgical strategies. But how about challenges in limited resource setting? Therefore, we distributed questionnaires to 100 surgeons in 30 non-tertiary hospitals with limited resource. The top 3 challenges based on the questionnaires are the diagnosis, treatment, and sociocultural challenges. The first challenge is the diagnostic tools. All surgeons agree to use the diagnosis criteria according to the 2018 definitions of PJI. All surgeons also agree that the diagnosis of PJI becomes straightforward when sinus tract is present. The diagnosis becomes more complicated when no sinus tract is found, especially when there is culture negative due to over-reliance on tissue swab, inability to detect fungal and fastidious bacteria due to the absence of proper medium, or there is a delay to deliver the sample to the better facility. All surgeons use ESR and CRP as first-line testing, but usually the results are inconclusive due to the low sensitivity, and normal result does not mean no infection. And synovial fluid analysis is not always available in these hospitals. Therefore, there is need for battle culture, sonication, or PCR, and alternative serum and synovial markers are usually advisable. But things are not always beautiful, as these things are not available in these hospitals. Challenge number 2, the theme. There is an important role of multidisciplinary team to make the decisions in the treatment options of PJI. Study in Hamburg, Germany showed there is a decreased length of stay and also number of surgical operations when there is a presence of multidisciplinary team. There is also a decrease in culture negative PJI. But not all hospital has the team and the surgeon has to do the one-man show. Difficult to treat microorganisms and antimicrobial resistance is the next challenge. We have been battling the emergence of more virulent bacterial strains and opportunistic infections for the past years. When there is microbial resistance, we have to use alternative antibiotics, better antibiotics. But the thing is, not every hospital has wide range of antimicrobial options. And on our survey, only 50% of the hospital has wide range of antibiotics. The next challenge in surgical options, as the current studies focus on the optimization of their one-stage or two-stage, it requires proper equipment. This is a picture sent by my colleague, a handmade spacer. In our survey, not many options for revision arthroplasties are available. 52% end up in arthrodesis, with 24% in amputations, and only 20% of the patients had a revision arthroplasty. The last challenge is the sociocultural. These limited resource hospitals are not tertiary hospitals. These are distant peripheral hospitals with geographical obstacles. Sometimes there's a delay or lack of referral system. For example, when they have to send the sample or when they have to send the patient for further treatments. And not to mention the low compliance of the patients themselves. Therefore, the battle against PGI requires huge efforts by a multidisciplinary team in diagnosis and treatment. Not all cases can be treated in tertiary hospital, and most of them are treated in peripheral hospital that have to deal with limited resource. Therefore, collective effort from all stakeholders are important to deal with PGI. Thank you very much.
Good afternoon. I'd like to talk single-stage revision for chronic PGI of hip. How are we doing? Firstly, let's say a case. This man with 2 years history of pain was aggressive in recent 3 months. You can see a big abscess in front of thigh. So, firstly, I did abscess exercise and debridement. Then I did a one-stage reconstruction. After that, I put 2 drains, 2 catheters for vancomycin infusion because this is MRSA infection. At 3 years follow-up, you can see the infection has been controlled totally and restored to normal function. So, what's the best treatment? 2-stage or 1-stage, which still remain controversial. 2-stage as golden standard, which is very successful and spacer works well. These people short, nearly over half spacers could be identified or get them, even all patients free of clinical presentation of infection. This is famous people at Avisi, reviewed 500 cases. For 2-stage revision, finally the total success rate is only 67%, and with very high mortality. This is our data. We reviewed 126 cases. Of them, 111 get follow-up, which include sinus tract and previous surgical intervention, which usually consider contraindication for 1-stage. This is bacterials, which including antibiotic-resistant bacterial, fungus, and culture negative. At average, 4.5 years follow-up, 99 cases free of infection. 12 with recurrence, I did further intervention. So finally, the success rate is over 90%. Surgical procedure include the first step, debridement. Firstly, we did so-called mechanical debridement, remove all loosened and necrotic tissue. Exercise scar tissue and sinus tract. The secondly, so-called chemical debridement, wash with saline, soak in hydrogen peroxide, and wash again, soak in aqueous betadine. And then we go to second step, reconstruction. We restore skin, rescrap hand, redraping, exchange new gown and new clothes, new instrument, wash again, reconstruct with cementless prosthesis. We put a catheter into the joint cavity, which used for antibiotic infusion. This is our antibiotic protocol. Systemic plus local use. Topical use of antibiotic is very effective, which can decrease side effect and enhance effective of antibiotic use. So this is the evidence to support this. Let's see another cases. This lady had a more than 11 years history of hematogenous PGI with repeated spacer implantation. For surgery, we identify the organism Staphylococcus aureus. We did one-stage reconstruction. So after surgery, we use local vancomycin infusion. You can see which is very effective. After 1 week, the joint fluid, WBC count, and CRP-ESR restore to normal quickly. So 2 months follow-up, 1 year follow-up for these patients, 3 years follow-up. Another lady with hematogenous PGI, sinus tract for 2 months. You can see massive bone loss in acetabular. We did debridement, wash, stereo, and stop. 1-stage triple shell, PM shell reconstruction. After operation, the same way with vancomycin infusion. This is 1 year follow-up. Function as well. 3 years follow-up. So we would like to give some message with this way, with this method. Exercise skin care and sinus tract. Radical debridement. Wound clean with large amount of saline. Wound immersed with 0.5% iodine. Stereo skin redressing and exchange with new set of instruments. Reconstruct with cementless prosthesis and achieve initiate stability. Systemic antibiotic combined with local infusion for 2 weeks, then keep oral antibiotic until ESR therapy normal. So in conclusion, this is a trend. There is a trend that single-stage revision will be accepted by more and more surgeons and patients in treatment of chronic PGI. Radical debridement and appropriate antibiotic use in single-stage revision must enhance the success rate of infection control, reduce the mortality, and restore the function of hip extremely. Thank you very much for your attention.
Mr. Chairman, ladies and gentlemen, thank you for the opportunity to share our work with you today. It is fair to say that the optimal delivery strategy for antibiotics to the effective joint space of the hip is undecided. Newer technologies such as the use of liposomes as well as smart implants have been described in the literature, but the most common approach and the most traditional approach remains addition of antibiotics to polymethyl methacrylate bone cement. Concerns have been raised about this approach, however, including bacterial adhesion to the surface of cement, modification of the mechanical properties of cement by addition of antibiotics, limitation of the type of antibiotics that can be used, and the interaction of multiple antibiotics when used in the same cement mix. We know that addition of larger quantities of antibiotics does not necessarily improve elution properties of the cement, and we know that they can negatively affect the structure and mechanical properties of cement. For this reason, calcium sulfate delivery systems, in this case stimulant, became attractive to myself and my colleagues. These have been used for some time as bone void fillers. They are known to be antibiotic eluting, and now we commonly use them for prosthetic joint infections, metalwork-associated infections, and prophylaxis in high-risk cases. I became concerned about their use, however, when this paper emerged from UCL in London. This paper these authors found that over 1/3 of cases treated with stimulant exhibited signs of hypercalcemia. Other authors at the time also expressed concerns about persistent wound discharge and heterotopic ossification. Of these, hypercalcemia is potentially the most dangerous, with the risk of cardiac arrhythmias and death. We therefore set out to assess the incidence of hypercalcemia with the use of stimulant in patients undergoing revision total hip arthroplasty in our unit. As secondary outcomes, we assessed the incidence of wound discharge and heterotopic ossification. A prospective study was performed over 2 years. All patients treated with stimulant during this period were included. They were all treated by the same group of consultant surgeons in a multidisciplinary environment. Patients were excluded if they had pre-existing hypercalcemia, renal failure, or parathyroid dysfunction. PJI in these cases was defined according to the MSIS criteria. The white cell count, CRP, renal function, and serum calcium were assessed preoperatively, as well as day 1, week 2, and week 6 post-surgery. Radiographs were obtained at day 1 post-op and week 6. Statistical analysis was performed using the student's t-test. Reference values used were set by our hospital laboratory, as displayed here. 29 patients, roughly equal males and females, were included. Average age was 67 years. Mean ASA was 3. The mean volume of stimulant used was 25 mils. Vancomycin and gentamicin were the main antibiotics added. The majority of procedures were performed for the treatment of prosthetic joint infection. The patients with periprosthetic fractures who received stimulant had this for prophylactic purposes. Over the period of the study, there was no statistically significant increase in the serum levels of calcium, and there was no signs of hypercalcemia in any of this patient cohort. There was significant reduction, however, in the CRP and white cell count over the study period. When represented graphically, the solid line shows the steady state of serum calcium with the reduction in associated inflammatory markers. Stimulant had resorbed and was not present radiologically within the joint space in any patient in this cohort at the 6-week mark. There was no evidence of heterotopic ossification on any radiograph at the final follow-up for the purposes of this study. One patient had a persistent wound discharge, and this required reoperation. She had her initial procedure performed via an anterolateral approach and her revision procedure performed via a posterior approach. At the reoperation for her persistent discharge, a capsular defect was found in the anterolateral capsule, and this was repaired, and the discharge resolved. She had 20 cc's of stimulant placed in the intracapsular compartment. PJI is indeed a growing concern, and irrespective of the surgical approach used, antibiotics are central to all treatment strategies. Their delivery and elution within the effective joint space are therefore extremely important to the management of PJI. Calcium sulfate-based delivery systems have a prolonged duration of elution. All antibiotics are released, and the maintenance of the minimum inhibitory concentration in the effective joint space is maintained with the use of these compounds. Any antibiotic can be used irrespective of its thermostability. The calcium sulfate itself discharges and is no longer visible within the joint space, certainly radiologically at the 6-week mark. A review of the literature shows that our study has relatively small numbers. However, it is prospective in design, and we observed no evidence of hypercalcemia following surgery. There are other prospective studies published in the literature to date, and these show that the main issues associated with stimulant use is in fact wound discharge and not hypercalcemia. The limitations of this study are the small numbers and the variation in patients with no control group, but this is an honest reflection of patients presenting with prosthetic joint infection and who require revision surgery. In conclusion, ladies and gentlemen, I believe that the use of stimulant calcium-based antibiotic delivery systems is a valid option for management of patients with hip-associated PJI. It has low complication rates. However, larger studies for prolonged periods of time are required to assess the true incidence of complications with the use of these compounds. Thank you very much.
Good morning. Thank you, Apas, for giving me this opportunity. I am Professor C.S. Yadav from New Delhi, working in the corporate hospital known for the arthroplasty. And there is no conflict of interest. Total hip arthroplasty in active stage of tuberculosis is very controversial, and it raises these questions like, is eradication of diseases possible in the presence of foreign body? Can implant bone graft incorporate in the presence of active stage of tuberculosis? Another question, will the presence of foreign body, metal, poly, and bone graft will lead to the recurrence? And which implant is safe to use and what are the results? Will post-op protocol will be different than the other condition? If you go through the literature, it is established, total hip arthroplasty is established procedure in the quiescent stage. Literature mentioned it, we should wait few years to up to 20 years. And these patients are young patients. So question is there, they are in their productive age. Should we wait for these patients for so many years? They are in all active stage. So that is the most important question. And if you go through the literature in spine, this very important study, it says tubercular infection can be eradicated even though implant is present. This is very important message from this study. And even total knee arthroplasty has been done in active stage of tuberculosis. It is in CORR. It is a very important studies there. And these are the landmark studies in active, doing total hip arthroplasty in active stage, like UN study. It says THR in advanced active tuberculosis is a safe procedure. Kim et al. Says recurrence during the follow-up. He has not seen in 8 cases, and implant all were well embedded. So this is our experience. 52 cases. We have excluded the patient, those who were having sinus tract and fulminating type of tuberculosis. Rest, all the active cases, they were included. Material was sent for the histopathology and staining and PCR. So you can see in the TB hip, well, graft is very much incorporated over here. You can see over here. And this is the caseous, this is full of caseous material. It is, cup is all white out. In these cases, even after the closure, thorough debridement, sometimes you see the caseous material, it is coming out through the brain. So thorough debridement is must in these cases. And which implant, it doesn't matter whether you use cementless or uncemented. Heat from the cemented implant, it doesn't matter. It doesn't kill the AFV. So laboratory finding, 48 cases, it was positive histopathology. And if you go through the post-op protocol, because these bones are very soft, post-operative protocol is little slow in comparison to the total arthroplasty in other conditions. control residual infection. It is mentioned in the literature, and it can eradicate the remaining infection. Functional score raised from the 42 in our series up to the 88, and in 51 joints, the results were good to excellent. One case, we have to sacrifice the joint because of secondary infection. And we have more than 40% cases, we have mid-term follow-up, more than 6 years. And 3 cases, there was delayed wound healing. And 3 cases, there was reactivation of the infection. That is most important. 1 cases, we have sacrificed the joint. You can see this patient was operated long back, and you can see reactivation of sinus over here. But these sinus, they are different from the sinus from the active infection because they healed nicely after the ATT. And when patient presented to the OPD, they were not symptomatic at all. They were just came for the sinus. So it is different from the septic infection. And you can see we have published case report. This patient we operated 15 years ago, total knee arthroplasty, came with the TV knee with cold access, thorough debridement was done, chemotherapy was given. We saved the total knee arthroplasty. We have published that. This patient, you can see cold abscess, total hip arthroplasty was done, excellent result. Another case you can see, this is the all cold abscess, destroyed head, total hip arthroplasty was done. So this is also very important study. Johnson et al. Says the length of time of the inactive infection should not be alone decisive factor to do total hip arthroplasty. There may always be risk of tuberculosis reactivation. So Yoon et al. Concluded in his study, total hip arthroplasty in TB is the safe procedure. Thorough removal of necrotic material is must. Tubercular reactivation was not affected whether you do cemented or uncemented total hip arthroplasty. Patient with infected sinus tract may not be good indication for immediate THR. It should be done in 2-stage operation. So we have published in CORR our study. So overall message is total hip arthroplasty in active stage immediately relieves agony and suffering, and THA give early functional recovery and encouraging result of total hip arthroplasty in the healed stage of TB and THA in other condition of arthroplasty. So it gives as good as result and provide better level of functional activity in productive years. Most important, these patients are young and ensure patient compliance. So immediate THR should be avoided in the presence of sinus tract and fulminatic type of tuberculosis. Thank you.
Good evening to everyone. First and foremost, I'd like to thank the organizing committee of the 2021 meeting of the Asia Pacific Arthroplasty Society, particularly to my good friends, Dr. Nico Budiparama and Dr. Rani Sorial, for the kind invitation and the distinct honor of being part of the faculty of this prestigious conference. Over the next few minutes, I'll be talking about total hip replacement tuberculous arthritis, a disease entity that continues to affect us in this particular part of the world. I have no disclosures that are in any way in conflict with the content of this particular presentation. We'll start off with a patient of ours. She's a 45-year-old female complaining of right hip pain that's been going on for about a year, associated with an occasional night fever. She was independently ambulatory till about a month prior, where she started complaining of more severe right hip pain that prompted her consult. And she did report some weight loss over the past few months, although there was the absence of swelling or erythema around the right hip. She did walk with a lethargic gait, and further physical examination showed limitation of motion on internal and external rotation of the right hip. Knowing that we had an infectious process at the back of our heads, we took her inflammatory markers, which were elevated, and further imaging of the hip showed the fluid collection as well over the posterior inferior aspect of the right hip. So while we had the diagnosis of tuberculous arthritis as one of the possibilities, we wanted to rule out all other possible disease entities that are presented the same way, particularly septic arthritis, an acute flare of an inflammatory arthritic process, or even a metastatic disease. Knowing that tuberculous arthritis could have a similar presentation with all these disease entities, as it's been given the moniker of being the great mimic. So the approach to diagnosis has been still a challenge for most clinicians, but suffice it to say that at least we know for tuberculous arthritis, it has an insidious onset, and particularly if it affects joints that are easily accessible or palpable, take for example the knee or the ankle. Sometimes you may appreciate a cold abscess, which means swelling that is not erythematous or not warm to touch. As with any infectious process, the inflammatory markers are expected to be elevated. But as has been the approach for Pott's disease, for example, early on, you can do a trial treatment for these patients wherein with a baseline elevated ESR and CRP, you could start them with quadruple anti-COX treatment and take your ESR and CRP again 2 weeks thereafter. And if you have noted a decreasing trend in your inflammatory markers associated with clinical improvement in their signs and symptoms, then most likely you may be dealing with tuberculous arthritic process. Imaging will normally show lytic areas both on the femoral head and the acetabular, but with a distinctive absence of sclerosis, which you might see in degenerative osteoarthritis. And further imaging in the form of a CT or MRI would show fluid collection in the form of the abscess in some dependent parts of the hip joint. Synovial biopsy, however, continues to be the gold standard for the diagnosis of tuberculous arthritis of the hip. But then it begs the question right now, does it mean that you always have to do a stage procedure for these patients, which means do an open biopsy, get enough synovial tissue specimen for histopathologic examination before proceeding with definitive treatment? So the challenges we are faced with are first, the continued absence or lack of a consensus with regard to the diagnosis treatment of this particular disease entity, mainly because of significant differences in the incidence in the different parts of the world. There's not enough evidence in the literature right now because most of the studies are retrospective and only cover a limited number of patients for us to come to a very robust conclusion with regard to how to approach a diagnosis and treatment of this particular disease entity. And so there's still a lot of challenges we are faced with, as there are no established protocols, no established definitions for active disease and response to treatment, when to do one-stage or two-stage surgical intervention, how long anti-tuberculous treatment has to be given to these patients before surgical intervention and after surgical intervention, and how to eventually manage a disease reactivation, which is everyone's fear, particularly after you've done your definitive surgical treatment already in the form of total hip replacement. The most recent systematic reviews, however, points out 4 common points. That first and foremost, that previous TB infection does not preclude total hip replacements. You can definitely do a total hip replacement even in the presence of TB infection as long as your patient has had at least 3 months of anti-tuberculous treatment with note of response to treatment, both with decreasing inflammatory markers and a clinical response as well, and that the anti-tuberculous treatment has to be continued for at least 9 to 12 months post-operatively. Now you can do a single-stage procedure or a two-stage procedure, and the distinct difference between the two is that if there is an exposure of the joint prior to treatment to the external environment in the form of a draining sinus, then you may want to consider a two-stage treatment where you do an adequate debridement first, resection arthroplasty, apply an antibiotic spacer, and once your patient has shown a good clinical response to treatment, thereafter proceed with your second stage or definitive total hip replacement, or in the presence of a recalcitrant disease, which means that with a prior anti-tuberculous treatment for 3 months, your patient did not show any significant clinical improvement or decrease in the inflammatory markers, then a two-stage procedure may be recommended for these patients. The common denominator for these two procedures, be it a single-stage or two-stage procedure, is making sure you do adequate surgical debridement, because this significantly decreases the infection load. This also gets rid of all the necrotic tissue, particularly all the caseation necrosis that you will see around the area that normally just oozes out of the surgical field. And make sure you remove all the dead tissue before you eventually do your single-stage or two-stage surgical procedure. Here's one of our patients who presented, again, with right hip pain with elevated ESR and CRP, for which we decided to do a single-stage surgical debridement and application of a cementless total hip replacement, whereas in contrast with this other patient who may radiographically seem to have a more benign disease, but the MRI showed a more extensive involvement of the muscular areas across the hip joint, a significant amount of synovitis as well, for which we decided to do our section arthroplasty, applied an antibiotic spacer, continued with the anti-tuberculous treatment, and once she did show significant clinical improvement and decreasing the inflammatory markers, we eventually decided to proceed with the more definitive total hip replacement in her case. Now, this begs the question, however, is when is the right time to do the second stage total hip replacement? Are we simply basing it on clinical parameters or inflammatory markers alone? So these remain to be unanswered up to this point. With regard to the choice of cemented or cementless total hip replacements, both are accepted forms of treatment, and the decision is now left to the surgeon, depending right now on the amount of bone loss you are dealing with intraoperatively, as to whether you proceed with a cemented or cementless total hip replacement. Oftentimes, however, particularly in chronic disease or long-standing disease, you may be dealing with a more significant amount of bone loss, be it at the proximal femur, the femoral head, or the acetabulum. And this is where your knowledge and skills in revision total hip replacement will definitely come in handy. So in conclusion, tuberculous arthritis remains to be a diagnostic and therapeutic challenge, particularly in this part of the world, mainly because of the absence of uniform algorithms and protocols with regard to the diagnosis and treatment of this particular disease entity. We do know now, however, that total hip replacement is an option that we can offer to these patients to decrease infection load, to lessen the pain, improve their mobility and function, and eventually improve their quality of life. We may consider either a single-stage total hip replacement or a two-stage total hip replacement, depending on the nature of disease and depending on how your patient responds to treatment. However, what we do know now is that 3 months of preoperative anti-tuberculous treatment is the accepted duration of treatment prior to surgical intervention, after which another 9 to 12 months of post-operative anti-tuberculous treatment should be given to all these patients. There is, however, a need for a prospective study to consider algorithm and treatment protocol validations if we were to come up with a uniform way by which we can approach the diagnosis and treatment of these patients. And so I call on our colleagues in the Southeast Asian region, or even Asia Pacific region, probably we can band together to come up with a robust prospective study to be able to validate such algorithm and treatment protocols as well. With that, I'd like to thank you for your kind attention. And if there are any questions, I'd be more than happy to answer them.
Thank you. Thank you very much, all the speakers, for your beautiful and beautiful deliberation. And this is a very, very, very interesting and very important topic, particularly for our countries in this region, Asia Pacific region. And I would request, Simon.
Yeah.
There is one question there, I think. Yeah.
Look, thanks very much. Look, we have one question which relates to at least the last two papers, so I'll put that up first. First question is from Julius Polera, asking whether in a young patient, say less than 21 years old, who has end-stage TB arthritis of the hip, will you still consider doing a hip replacement for that patient? So I'll ask either Jose Antonio or Chandra, or both of you, in fact, make a comment on that sort of a patient.
I think Syed Jadhav would be good on, because he knows, he's in Delhi.
Yes.
Thank you.
Yeah, Syed Jadhav.
Thank you. Previously, there was a concept in our country, in active state, it should not be done. But what I feel, under cover of ATT of 6 weeks, it can be done with full safety, and hardly we see any recurrence. Even 6 patients, we have not given pre-operative ATT. Even then, there was no recurrence or infection. And these 6 cases, we were not able to diagnose pre-operatively. We suspected, we operated, then we sent material, found it is tuberculosis. So under cover of ATT, it is quite safe and it relieves agony. It is a fantastic procedure, very reproducible procedure.
Thank you, Professor Yadav. I know that I'm doing the same procedure here in my center, and I'm doing, because you know that we have a lot of cases of tuberculosis. Doing these cases, in active stages.
Would it
not
perhaps,
considering malaise?
Would it perhaps be indicative that if you have a young patient with destructive joint disease, that TB would be high on the differential list before you go forward with the diagnosis? So are there ways that you might have a high index of suspicion for that young patient with end-stage disease? Can you tell us how you might investigate that patient?
Jadhav?
First, I think the special consideration here is that we're dealing with a very young patient. So which means that if you outright do present to this patient a surgical debridement and then total hip replacement, assuming you're able to control the active disease with preoperative anti-tuberculous treatment. But then again, at that young age, you're also putting this patient at risk of probably a couple revisions throughout his or her lifetime. And this is probably where you take into special consideration the patient's level of activity and commitment as well. So probably a hip fusion may be an option for treatment first, assuming that, of course, you have good medical control of the disease, and that this patient at some later point, if he or she desires to get a mobile hip at a later stage in her life, then you can probably do a conversion from a fused hip to a replaced hip.
Okay, that's interesting. That's interesting. I have a question for Noam. I enjoyed your presentation, and what was interesting is the difference between, I guess, your experience and Kuku's experience in terms of resourcing. First question for Noam is, are you noticing a change in the demographics of infection? That is, different patients and different organisms? And if so, are you seeing outcome variables with that?
Yeah, thank you. So one of the things that tremendously affects the outcomes of irrigation and debridement, as I showed there, the indication for surgery, if it's acute versus acute hematogenous, if it's a revision versus non-revision, and more specifically comorbidities, especially diabetes, especially COPD and malignancy. Those factors are associated with a much higher failure rate, even twice the times higher. So definitely the patient population that you treat can affect the overall outcome. It's more than one specific comorbidity. I would say it's the combination of many different patient characteristics. That what we tried to show is that multi-institutional study is that if you combine everything into one algorithm, you can see different results, even non-expected results sometimes, based on just the combinations of many different variables. And for your second question, that organism is a very important factor as well, especially those factors that are the organisms that are antibiotic resistant. They are associated with a much higher failure rate, as well as the polymicrobial infections. Those are usually the second or third times that implant fail.
Thanks, Noam. Is a question for Kuku. You mentioned there's certainly a rate of culture negative infection. How do you approach these patients, Kuku? We know identifying the organism is critical, but there's a certain percentage that we don't identify. How does that alter your management?
Yeah, I agree that currently culture negative result is a challenge, because actually the number is quite small, between maybe 7 to 15% of our microorganism or microbiological results are culture negative. But the problems become apparent when we know clinically this is a PJI infection, but we cannot identify. So it leads to the next problem of what antimicrobial treatment we should use. That's why, based on our studies, that most of the cause why there is a culture negative in limited resource setting is because first, actually there is no gold standard to diagnose, because first there is a lack of culture procedure. We know like some fastidious microorganism like fungi and then mycobacterium or maybe propionibacterium, it takes about like at least 21 days to culture to get a result. But sometimes there is no culture system in this hospital, so they have to send to the other hospital. But again, another obstacles of geographical obstacles when there's a delay of sending the sample. So what we usually do with this kind of thing is we refer the patient. We try to educate the patient and refer them to the higher facility, and they will have another surgery for the biopsy to obtain the culture there.
Okay. Yeah. So, right, thanks. We're running short on time. So the answer there is if you suspect but you haven't grown it, you'll send it to another institution with better resourcing, yeah?
Yes.
Okay, thanks. Just one quick question for Amir. Amir, I enjoyed your talk. Why do you think you didn't get hypercalcemia as an issue, but the other investigators have?
Thanks very much for the question. It's a good question. I think the first thing is we were probably more vigilant, but in terms of the amount used, because the first study from UCL that showed it, they used large volumes of stimulant in that patient, and particularly the one patient who had the most significant symptoms and in fact went to the ICU for a while. And I think it was just vigilance and being cautious and careful with the early introduction of it, really. Right. And so everyone who we use it on goes into a prospective database, and we look at them very carefully. And also, we've learned to exclude patients who are at risk of hypercalcemia beforehand.
Yep. Okay. So it's being awareness. So it's awareness. Yeah. And the drainage issue, you think it's a volume related thing as well?
No, I think this is a genuine issue. So I don't use it superficial to the deep fascia. I use it in both the hip and the knee. I found that if ever used in the superficial tissues, you get a continuous effusion. It can be very difficult to control. Yeah.
Some of my foot and ankle colleagues have found the same thing, where there's a lot less soft tissue color. Yep, that's great. Listen, that's been fascinating talk, and we could go on for quite some time, but we're about to close up at 8 p.m. I'd like to take the opportunity of the speakers of this session for making their contribution. It's been fantastic, very stimulating. I'd also like to thank the whole crew for the whole day's effort, the live surgeries, as well as the panel discussion. It's been very stimulating. If you haven't already, then encourage your colleagues to log in and check into the meeting next Saturday. I think it's gone really, really well today, and I hope, and I'm sure it will go well again next week. So I hope to see you all again next week, and thanks everybody for your contributions, and in particular the AV teams behind the scenes who have done a fantastic job. And thanks very much.
Thank you.
Thank you very much, everyone. See you. Stay safe. Thank you, Dr. Snyder.
Recording stopped.